Now, three vessel view shows us the pulmonary artery, the aorta, and superior vena cava. But this view is, this plane is at a subtly inferior level to the carina, and therefore the trachea is not visible in this view. And then you go a little higher, and then you are also able to see the trachea along with the three vessels. At this level, you don't see the bifurcation of the pulmonary artery, but you are able to see the trachea, and therefore you have a better sense of the position of the three vessels and the direction they are going. So this view, in my opinion, is a better view to record than the simple three vessel view. It's not very difficult, you just have to sweep up from the four chamber view. So apical four chamber is an axial view, three vessel trachea view is also an axial view, which is at a supracardiac level. So that's not very difficult to acquire. You can do that when you have a apical or even a lateral four chamber view. You just have to sweep up and you are able to see this three vessel trachea view. Are you able to see it at the first trimester? Yes, the same thing, you have to go up from the fourth chamber. Only remember that these vessels are so small in first trimester that unless you are using color, you will not be able to identify the both arches. So in first trimester, always use color to look at the heart that outlines the chambers and outlines the vessels. So as I said, these two views are a little at different levels at a very subtle angle, but most of us, we are able to get the three vessel, that's the three vessel view, which passes at the bifurcation of the pulmonary artery, and that is the three vessel trachea view, which is a little above the carina, so it cuts through the trachea, and that has an advantage that it allows us to look at the relationship of the vessels to the trachea, whether they are on the left side of the trachea or one or both of them are on the right side of the trachea, and that gives us a lot of information. So it is good to record a three vessel trachea view every single time you are looking at the fetal heart. Now, which are these three vessels? As you go from left to right, you have the ductal arch, you have the aortic arch, you have the superior vena cava, and you have the trachea. On the left side of the trachea, you have these both arches. And in majority of the cases, in the same view, you will be able to see the thymus, which separates these three vessels from the sternum. So these three vessels are not close to the sternum, they are a little distance from the sternum, and the space occupied, this space is occupied by the thymus. So it is good to make sure that the thymus is present. These vessels are not very close to the sternum. So they have a constant relationship, these three vessels. You have the ductal arch, aortic arch, and SVC, and both of these vessels, when you switch on color, you will see that they are flowing in the same direction. So they will appear in the same color, and they form a V because both of these arches join at the aortic isthmus, and therefore they will always have a V configuration, and the apex of the V is at the aortic isthmus. So when you do color, you will see that both of them are seen in the same color, and make sure by referring to your color bar chart that both of them are flowing towards the vertebral column. That's the normal direction of flow in both of these vessels. So depending on whether you have the fetus dorso-posterior, they will appear in blue. If you have the fetus in dorso-anterior, they will appear in red. If you have the fetus in a lateral decubitus position, one of the arch will be in blue and one of the arch in red, so don't get confused that they are flowing in different directions. They are both flowing in the same direction towards the vertebral column, and that is important to ascertain that both these arches, whatever the position of the fetus, are flowing towards the vertebral column, and that is normal whichever the color they appear in. Then you can go a little higher to the 3-vessel trachea view, and there you will be able to see the left brachiocephalic vein and the subclavian arteries that come out of the arches, and sometimes it is important to look for the left brachiocephalic vein and the right and left subclavian arteries. And then look at the thymus. You can measure the thymus, you can do the thymus thoracic ratio, which is normally less than half, and that helps you to determine whether there is enough thymic tissue or the thymus is hypoplastic or it is absent. And we know that if we don't see the thymus, there is a high risk for, particularly for 22q11 deletion, and therefore the importance to look for the thymus. So what are we looking for when we have a 3-vessel trachea view? We are looking for the number of vessels, how many vessels do we see, what is their proportionate size. Normally, yesterday I said that pulmonary artery is slightly larger than the aorta, which is slightly larger than the SVC. So from left to right, the caliber diminishes. Normally they will have a V configuration with flow towards the spine. The apex will be on the left side of the trachea, and as I said, on color Doppler you will see the direction of flow and look for thymus. So these are the things we need to check when you are looking at the 3-vessel trachea view. It is easy to obtain. It allows you visualization of both arches simultaneously, abnormal in most anomalies of outflow tract, and it helps assess the ductus dependent cardiac anomalies, and therefore that's the importance of 3-vessel trachea view. So what abnormal view we can see? We can see that there is abnormality of number, abnormal caliber of vessels, abnormal direction of vessels, abnormal position of vessels, and abnormal flow direction in these vessels. So these are the abnormalities that we might expect. So we might expect 2 or 4 vessels instead of 3, large PA, small PA, large aorta, small aorta, or both arches might be on the right side, or one of the arches on right side, one on the left side, abnormal position, and that abnormal position creates U or O configuration instead of a V configuration. And then we might have reversal of flow in one of these arches depending on whether it is a ductal dependent circulation. So we'll look at the number of abnormalities in 3-vessel trachea view. So you might have only 2 vessels. Now remember that when you are in a cardiac setting, you might not see flow in the SVC because SVC flow is very slow. So you might see flow only in one vessel, but the SVC is there, it is flowing. So you might have to reduce your PRF, filters, etc. to make sure that the SVC is flowing. So here I have only 2 vessels. That means one of the arch is absent. It may be the aorta or it may be the pulmonary artery that we need to figure out, or one of the arch is at a different level, and therefore when I am doing transverse sections I see only one arch at any one time, and that might happen only 2 vessels in 3-vessel trachea view in certain conditions like PIVS, aortic atresia, common arterial trunk, TGA, etc. So here is an example where I see only 2 vessels, and this single artery is a pulmonary artery because there is space in the middle. The central vessel is absent. These 2 vessels are far apart, so I know that. And that might happen in ascending aorta, and then I go up and I see a reverse flow in the distal aortic arch, and that is because it is again a ductus dependent systemic circulation because the ascending part of the arch is absent, and that happens in aortic atresia. Here is a sagittal view. I have the complete ductal arch and the ascending aorta is absent in aortic atresia. The descending arch is getting filled from the ductus. So it is a ductus dependent systemic circulation. Here again I have a single vessel, single arch and the SVC. This is normal in caliber and there is a slightly right-sided curve to this arch. So that might happen in TGA, for example. Here again I have a single artery which is in the center, so that probably might be the aorta, but it is large in caliber, so I need to figure out why it is large. That might happen if it is a common arterial trunk. And then I need to figure out what is happening to the pulmonary artery, so I scroll up and down and I can see the pulmonary artery arising from this common arterial trunk, so that confirms me that we are dealing with a truncus arteriosus type problem. Here again I have a single artery which is close to SVC, so that probably is the aorta, and it is large in caliber. And then I can see that there is pulmonary atresia with ductus dependent pulmonary flow taking the circulation back into the pulmonary circulation. Now instead of 2 vessels, I might have 4 vessels. So I have one additional vein. When there are 4 vessels, it usually is the additional vein on left side, and that additional vein on left side can be an persistent left superior vena cava, or it can be an ascending vein in TAPVC. So we need to look at this vein and make sure what sort of flow is there. So we have the 2 arches and 2 veins on either side. So we have 4 veins, and I can see I go back down, and this additional vein joins the coronary sinus here. So I know that this is probably the left superior vena cava, which is joining and draining into the left coronary sinus. So the left coronary sinus has become fairly prominent. But I need to make sure of the direction of flow, and I see that the direction of flow in this vertical vein is towards the heart. So that definitely is a persistent left superior vena cava. Here again I have the 4 vessels. So I have the 2 veins, but I can see that the direction of flow in these 2 superior vena cava is different. One is flowing towards the heart, one is flowing away from the heart. And that happens in TAPVC when you have the pulmonary veins do not joining the left atrium. They join a vertical vein which drains into the cephalic, brachiocephalic vein. So you have the blood flowing away from the heart. So here I have one vertical vein on left side, which is not left superior vena cava, it is the vertical vein in TAPVC. In supracardiac TAPVC, so that's joining the brachiocephalic vein. Here I have the 3 vessels, but the aorta is large in size instead of smaller in size. So there is disproportion of caliber of vessels, and that can happen in aortic valvular stenosis. So there is a post-stenotic dilatation of the ascending aorta. Another example where I have aorta focally dilated, but there's no aortic stenosis. So the aortic aneurysms are very, very rare, but they can happen. Instead of aorta, here the pulmonary artery is very large, and yesterday we saw some examples that happens in absent pulmonary wall syndrome. Since there are no pulmonary walls, there is a huge regurgitation happening through the pulmonary annulus, and that dilates the pulmonary artery and its main branches. Other hand, you can have small pulmonary artery, and that is very commonly we see in TOF, where you have a malaligned defect, and that encroaches on the pulmonary annulus, and that produces a small pulmonary artery. You can have a small aorta, so different combinations can happen. This artery is large, the other artery is small, and this can happen in coarctation, this can happen in aortic atresias, we have already seen. So you need to look at the aortic isthmus to make sure that there is no aortic coarctation. Another example of a small aorta, the left side chambers are also small, and that is happening because there is an interrupted aortic arch. The ductal arch is normal, the aorta simply courses straight up without curving back, so there is a interruption in the aortic arch there. Another example of small aorta, significantly smaller, and this also was because of a interruption. There you can see the aorta coursing straight up without curving back, so there is no aortic arch. Then you can have abnormal alignment of the vessels. So here I can see 3 vessels. they have a V configuration, but if you look at the apex of the V, it is on the right side of the trachea. So you have right-sided arches instead of left-sided arches. There are 3 vessels. They form a V, but that is on the right side. So you might have right-sided aortic arch. You might have an isolated right aortic arch, and there might be some additional features, abnormalities with this. Like I have a right aortic arch, but the ductal arch is absent. You just see the bifurcation, and you don't see the ductal arch going up and meeting the descending aortic arch at the aortic isthmus. So you might have a right-sided aortic arch with absent ductal arch, and another common anomaly may be a right-sided aortic arch with an aberrant origin of the left subclavian artery. So the left subclavian arises as the last branch, and therefore it courses behind the trachea to go to the left side. So that sometimes might cause tracheal compressions, and we need to make the pediatricians aware of that, that this forms a vascular ring around the trachea if there is a diverticulum of Comeral. And then some difficult things, we don't want to spend time on that. We might have abnormal branching patterns when you have right aortic arch, like mirror image branching, normal branching, etc. But one more important arch anomaly that produces an abnormal 3-vessel view is double aortic arch, where the aorta bifurcates. It forms 2 arches on either side of the trachea, and that also produces a vascular ring. So here you have something that looks like the U configuration that we see normally in the right-sided aortic arch, and then you need to be careful to make sure that this aortic arch does not branch, and that one arch passes on the left side, one arch passes on the right side of the trachea, and that forms a complete ring around the trachea, so that also can be potentially dangerous for the neonate later on. And then you might have abnormal flow directions in the 3 vessels. So I said that normally both arches would flow in the same direction, but if you have flow in opposite direction, and that you need to make sure, because as I said initially, if you have the fetus in lateral decubitus, if your approach to the 3-vessel trachea view is lateral, you will see both the arches in different color. So you need to make sure that the direction of flow is not towards the spine, and one of them is flowing away from the spine, and that tells us that we are dealing with a ductus dependent circulation sort of an abnormality. So here is another example. You have a reverse flow in the narrow aortic arch, and that happens in aortic atresia because there is no blood coming in from the ascending aorta. The blood gets diverted through the ductus into the systemic circulation. So you have a reverse flow in the ductus there, or you might have reverse flow in the ductal arch, like in situations where no forward flow is coming through the origin of pulmonary artery, and therefore you have ductus dependent pulmonary circulation. So both types of abnormalities might be there. And then the last thing, as I said, you need to make sure that these vessels are well back away from the sternum. They are not too close to the sternum. If they are very close to the sternum, you know that the thymus is either absent or hypoplastic, and then you need to remember that that raises the risk for 22q11 sort of deletions. So here again we see another patient with PAVSD, but the vessels are very close to the sternum. And there are several studies which have looked at the 3-vessel trachea view, and which have found that this is a very important view which allows us a good capability of detecting the outflow tract abnormalities. So I always request everybody not to stop at, even if you are doing a routine scan or a general anomaly scan, don't stop at looking only at 4-vessel apical 4-chamber view, but just go, it's easy, you go up and you get to see the 3-vessel trachea view, And this view has a very great potential to detect, to alert you that there might be an outflow tract abnormality if there is something wrong with the 3-vessel trachea view. So I'll conclude by saying that it is easy to obtain. Visualization of both arches simultaneously is possible. It is abnormal in almost all outflow tract abnormalities, and it helps us to assess the ductus dependent lesions as well. So thank you very much.
Very good morning. I think after yesterday's evening of heavy downpour and a lot of fun around, I think we don't expect many people to come back on Sunday morning. It's as expected. Now, Sudhir has taken us through the 3-vessel trachea view, which is one of the most important components of our fetal echo evaluation. Now, I'll take you through one thing which is called as the heterotaxy. The moment we listen to the heterotaxy, we get little disturbed or worried because we always think that it is very complex, and I will try to make it as simple as possible so that we can use these criteria in our day-to-day practice identifying these heterotaxies. Now, first and foremost thing, there is certain terminology that we need to understand. The most important thing is the situs solitus and situs inversus or situs ambiguous or heterotaxy syndrome. So when I say situs solitus, I always think that the fetal stomach as well as the apex of the heart are on the same side. Quite often it is situs solitus, associated with it the levocardia. Whereas whenever we have a situs inversus, it is just a flip, that is the mirror image, where you have situs inversus, the right-sided stomach as well as the apex also to the right of the thorax. So that is inversus. Whereas whenever there is a discordance between the apex of the heart as well as the stomach, then you call it as heterotaxy or a situs ambiguous. Now, a little bit about the embryology to understand this is particularly, we all know that the abdominal organs are non-paired organs. That is, you have only one liver, you have only one stomach, you have only one spleen. So they are all, and you have only one abdominal aorta, you have only one inferior vena cava. Whereas the thoracic structures are always paired. That is, you have 2 atria, 2 ventricles, 2 lungs. So this is one most important thing. So during the embryological development, these structures follow what is called as the spatially controlled coordinated pattern, which will lead to have well-defined right-sided structures as well as left-sided anatomical position of within the body. So this is the development that is normally taking place. So what happens in situs solitus? on the right side, whatever the right-sided structures will be on the right side, such as the liver, IVC, SVC, right atrium, trilobed lung, as well as the eparterial bronchus. Whereas the left-sided structures, that is the stomach, spleen, pulmonary veins, atria, bilobed lungs, left lung, as well as the hypoarterial bronchus will be on the left side. So this is the basic concept which we need to understand regarding the embryological development. Now, whenever there is a situs inversus, as I said, there will be a mirror image or there will be a flip. That is, the right structures will be on the left side structures will be on the right side. So, whenever we consider this one, the incidence of congenital heart diseases, if you have a situs solitus, the incidence is very low, whereas when you have a situs inversus, the possibility of congenital heart disease is almost about 5%. So, both these conditions we are near not really. So, initially, as we all did yesterday also, we have seen when we were doing the demonstration, the first thing which we have tried to do is to ascertain the laterality of the fetus, then identifying the stomach and the apex of the heart are the same side or the not. With that, we are going to ascertain the situs. So once the situs is ascertained, if it is the situs solitus, we know the incidence of congenital heart diseases are low. If it is situs inversus, the incidence is only 5%. The problem comes when there is a discordance between the apex of the heart and the stomach, that is, there is a situs ambiguous. That is when we are worried about. So that is one thing which you have. So the moment you start evaluating, you first and foremost thing ascertain the concordance between the apex of the heart and the stomach. That is the first thing you are going to do. Now let us know about a little bit about the situs ambiguous or heterotaxy syndrome. Here, what happens is the arrangement of the visceral and thoracic organs in any other fashion other than the situs solitus or situs inversus. That is when it is called as situs ambiguous. It is also known as unknown situs, or you can call it as a complex situs. In situs ambiguous, which is usually associated with various cardiac as well as extracardiac abnormalities. Now, in a heterotaxy, there will be a lot of jumbling of the organs. So what sort of jumbling of the organs will take place? That is, particularly if you take the visceral heterotaxy, there will be an irregular arrangement of non-paid abdominal organs. That is, we have understood that the abdominal organs are non-paid. So there will be an irregular arrangement of the non-paid abdominal organs, whereas the isomerism of the thoracic organs, there will be a symmetric arrangement of otherwise asymmetric structures. We know that there will be the paid structures are the thoracic structures, unpaid are the abdominal structures. So whenever we have an isomerism, what happens is there will be a symmetric arrangement of otherwise symmetric, because left atrium has its own characteristic, right atrium has its own characteristics, right ventricle has its own characteristic, left ventricle has its own characteristic. So whenever there is a isomerism, what happens is there will be symmetric arrangement of asymmetric organs. Is that clear? So that is second thing. So based on this, we can classify this into bilateral right-sidedness or bilateral left-sidedness. That is when you call it as, if it is bilateral right-sidedness, you call it as a right isomerism. If there is bilateral left-sidedness, we call it as left isomerism. Then, these are the appendages. It is slightly difficult to identify these appendages on a regular practice, but then we need to try and see. Usually, with the normal situs, the left atrial appendage will have a finger-like projections, as you can see here. This is the classical finger-like projections which you key on the left appendage, whereas on the right side you have this as a rounded dome-shaped appearance. So this is, anyway, don't worry about that, that's not an important thing. Now I will let you know what exactly is the left isomerism is. Now when I say left isomerism, or whenever we say that it is the left isomerism, it indirectly tells us that there is a bilateral left-sidedness. That is, the absence of the right-sidedness and the left-sided structures will be superimposed on the right side. That is a simple way of understanding this. So, the paid left-sided viscera which are absent and the right-sided viscera will be there. So, what happens is the left-sided viscera, suppose for example you have the left-sided viscera, that is the spleen, it becomes polysplenia. There will be more of spleen, and what happens is there will be bilateral morphological left atrial appendage. That means in the thorax, the right atrium is replaced by the left atrial morphology. So what happens in the right atrium? Normally the right atrium has got the SA node, isn't it? It is the conduction. So when it is replaced by the morphological left atrium, the conduction defects will start. That is the reason why you will be having the presentation as an arrhythmias. So that is the blocks, that is the conduction blocks will be there. So not only that, this will also be associated with multiple cardiac abnormalities such as the AVSD, pulmonary stenosis. Then the right atrium, the absence of right atrium, it results in cardiac arrhythmias. Then there will be bilateral morphological left lung, which you may not be able to make out. Most important again is the multiple spenules, because there is a more of bilateral left-sidedness, but then that also it's very difficult to make out on ultrasound. And then we have intestinal malrotation. Another most important thing is, as we know, we have always said that whenever there is a left-sidedness, the right-sided structures, particularly the inferior vena cava, will get interrupted. So what do we have? We have an interrupted IVC, where the circulation from the distal systemic circulation goes through the azygos. So azygos is present, but because there is an interruption, so the systemic circulation from the lower part of the body is drained into the right atrium through the azygos continuity. So basically in left isomerism, all the right-sided structures are replaced by the left-sided structures. So simple way of understanding is that whenever you have a situation where you have a complex cardiac abnormality, where you have conduction defect, where you have interrupted inferior vena cava, it has to be a left isomerism. This is as simple as that. So that is one thing which you have to keep in mind while evaluating these things. Then comes the right isomerism, that is the right-sidedness, bilateral right side. It is similar to the bilateral left-sidedness. What happens is the right-sided structures will be will be in abundance, whereas the left-sided structures will be suppressed. So in this one, what happens is bilateral morphological right atrial appendages will be seen. Instead of one on the left atrial appendage, the other one is the right atrial appendage. Then we will have multiple cardiac abnormalities, and at the same time there will be bilateral morphological right lung, absent of spleen, and at the same time what happens in the abdomen is that the aorta and the inferior vena cava will be juxtaposed. Normally we understood in the initial stages itself that when we see the aorta is left side and anterior way up to the spine, whereas the inferior vena cava is right-sided and anterior, isn't it? So instead of that, you will find them juxtaposed, that is adjacent to each other. So that is one thing which can be on the left side or it can be on the right side. So this is another one. So as far as the right isomerism is concerned, most important thing is you will definitely have a complex cardiac abnormalities. There will be a veno-atrial concordance, that is an abnormal connections of the venous connections. Third one will be that there will be juxtaposed abdominal aorta and inferior vena cava. So these are the things which will prompt you to think in terms of right isomerism. So what is the incidence of these things? It is only 1 in 7,000 births. The recurrence rates are almost 10%. Right isomerism is more common than the left isomerism, and quite often it results in complex cardiac block, heart block at the same time, and quite often the heterotaxy is sporadic. In about 10% of the cases, there can be a genetic mutation, and the genes which are implicated are ZIG3, left YA, cryptic, and ACVR2B. Rarely a heterotaxy syndrome runs in the families also. It is an autosomal dominant or autosomal recessive X-linked inheritance. Now, how are we going to prenatally diagnose a heterotaxy? There are only 4 factors that you need to consider in suspecting the possibility of a heterotaxy. First and foremost thing, the fetal heart and the stomach on opposite side. That is, you have established situs ambiguity. There is one. Second most important thing is presence of complex cardiac abnormalities. Quite often, both right isomerism and left isomerism are positively associated with complex cardiac abnormality. Third one, whenever there is a left isomerism, the right-sided structures, that is the right atrial appendage is absent. That is the reason why the SA node in the right atrium is absent. So it will result in conduction defects. So it presents as presence of complete heart block. The fourth most important thing is abnormal veno-atrial connections. That is, in a left isomerism, there will be interruption of IVC. In right isomerism, there will be the TAPVC. So these are the things that you have to keep in mind. So this is as simple. So once you establish that the site is ambiguous, look for the conduction, look for the cardiac abnormalities, look for the veno-atrial contraction. That's the only 4 things that you are going to look for. So basically this is the very reliable sign. This is the one which alerts you to think in terms of a possible abnormality, because as we all know, we start the fetal heart examination right from the upper abdomen. Whenever you do the upper abdominal section, you find that the aorta is, which we have been telling since yesterday. Instead of that, if they are just altered or they are flipped top, then you call it a situs inversus. In left isomerism, you will find the prominence of azygos, which takes over the interrupted IBC. You have the azygos continuity, you don't find the inferior vena cava. In the right isomerism, you find that they are juxtaposed with each other. So this is the basic. So when you do the first section, that is the upper abdomen, that is when the clue comes in, and then you start evaluating the fetal heart. Then you are going to look for the atrial appendages, which is not that easy to make out, but quite often if you find, but particularly when the fetal heart is abnormal, probably you may be able to identify these things, because you have already had an idea of a possibility of a heterotaxy because of the upper abdominal section, where you found that either there is an interrupted IVC or there is a juxtaposed great vessels. In this one, you can see this sort of a sickle-shaped, this is a left isomerism, so there will be more of left-sidedness, in which you can find that there will be a sickle-shaped left atrial appendage. Not only that, it is associated with complex cardiac abnormalities such as the AVST. Now, the other important thing is that whenever there is a right isomerism, you find that this sort of a large atrial, that is what is called as the pyramidal shaped or a dome shaped right ventricle. So this is very, very classical of a right isomerism. So prenatal diagnosis of left isomerism, 2 morphologically similar left atrial appendages instead of 1. Atria appear like sickle shape. Interruption of the inferior vena cava, structural cardiac abnormality, complete heart block, and viscerocardiac heterotaxy, other than the situs tortoisis and situs inversus. So these are the features which will help you to identify left isomerism. So that is as simple as. Now you know very well that these are the things that you are going to look for. That's all. Beyond that, there is no need to get any confusion. Similarly, when you have a left isomerism, you have that there will be more of left-sidedness. So automatically it will be associated with the conduction defects, where you have an abnormal conduction. At the same time, there will be a double barrel sign, which is basically because of the interrupted IVC, and the azygos has taken over. You can see that the ductus venosus is directly opening into the right atrium. Here you see both the vessels which are of different colors, which are suggesting that the aorta and inferior vena cava are adjacent to one another. This section very clearly shows in the HEMOC view, the right atrium is receiving blood from the SVC, but nothing from the IVC. So that this is how you are going to diagnose left isomerism, which is the blood. Another, as I said, this is also associated with the conduction defects. So whenever there is a left isomerism, I said one of the most important factor which prompts you to think in terms of the irregular rhythm. So here you have atrial contraction, but the ventricular conduction is not there. So with every 2 to 3 beats, you have only 1 ventricular conduction. That is definitely could be a complete heart block. So this is one thing which you have to keep in mind. And this helps us in identifying the possibility of left. Now coming to the right isomerism, here, as which has been taught, now we have 2 morphological right atrial appendages. That is one. Atria will be blunt, and the atrial appendage will be blunt and pyramid shaped. Juxtaposed abdominal aorta and inferior vena cava on the same side. Structural abnormality, complex cardiac abnormality is seen. There is no heart block because the right atrium is there, so the sinus, SA node is present. Abnormal veno-atrial connections such as TAPVC and visceral cardioheterotaxy, so ambiguous situs. So these are the features which will tell that this is a right-sided isomerism. So here we have a classical case where you have a dome-shaped right atrial appendage. Not only that, you can see the area behind the heart. You can see that there is a TAPVC which is very classically delineated, and this is also associated with complex cardiac abnormalities such as the AVST. So these are the features which you have to keep in mind. And then this is also the same. And then we have the juxtaposed. You can see here the aorta and the inferior vena cava are adjacent to one another. So very typically of a right isomerism. Okay. So diagnosis of isomerism is made in the presence of combination of at least two features. That is, one could be because of the either an interrupted IVC or a juxtaposed great vessels, that is the aorta and the inferior vena cava. Second most important, complex cardiac abnormalities. Third most important is presence of conduction defects. So these are the features that we have to keep in mind. The associated visceral abnormalities could be malrotation, malfixation of the bowels, gastric volvulus, esophageal hiatus, biliary atresia. Right isomerism quite often is such which leads to high risk of infections. So prognostication, most often intrauterine course and posterior course are different for right and left isomerism. Hence, accurate prenatal diagnosis is mandatory to allow appropriate counseling. Left atrial isomerism, as we all know, is always associated with heart blocks, which can lead to congestive cardiac failure and fetal demise. Whereas right atrial isomerism is associated with complex cardiac abnormality and faces significant high mortality and postoperative morbidity. Associated visceral abnormalities may affect the long-term outcome of these fetuses. So this is the concise chart where you can see that whenever you have, these are all the features that you have to consider. What are the things that they appear in the left isomerism and the right isomerism? Then the algorithmic approaches. First and foremost thing, as I said, first when you see the site is ambiguous, right-sided heart or stomach, and then when it is associated with the second important thing that you are going to do is to look for the veno-atrial connections. If the veno-atrial connections are abnormal, either the abnormality could be because of the absent IVC. In that situation, there will be a zygos continuously, and it is going to lead to diagnosis of left isomerism. Or it can be because of the juxtaposed IVC and aorta, which is because of the right isomerism. Now, these veno-atrial connections can also be associated with fetal bradycardia because of left isomerism, where the SA node is replaced by the left atrium. But if in case if it is normal, that the veno-atrial connections are normal, then you need to evaluate other conditions. And quite often both these heterotaxis are associated with complex cardiac abnormalities. So this is how you are going to evaluate heterotaxy, which can be easily made out without any help. Thank you very much. And we have a focus course in November 15th and 16th at Hyderabad. Thank you.
Thank you, sir. And next, it's my absolute privilege to welcome a true pioneer in the field of radiology and fetal medicine. He is also the founder of Fetal Foundation of India, a noble initiative providing free obstetric ultrasound services, and also committed to training specialists across the country. So we are truly honored to have you here, and we are eager to hear your insights and learn from your vast experience. We welcome Dr. Ramamurthy Garu to kindly take over the stage.
Namaskar. Good morning. Thank you. It's wonderful to be back in Palakollu. This is my second visit, and Palakollu, I can say, has grown. Last time the venue was not so magnificent. This is a great venue for a place as peripheral as Palakollu. Is it Palakollu a district? Is a taluk? It's a taluk, isn't it? It's not a district headquarters, right? So this is the way our country is really progressing. Thank you, Dr. Narayan Rao, for this invitation. And thank you for the committee, Godavari Ultrasound Association Committee. And without much ado, okay, Praveen is sitting here. He's put us all together. He was the one who married IFUMB to Gusa. Correct? He's the priest who oversaw the marriage. Okay, with that, we will start with intracranial cystic lesions, ultrasound approach. So, how do you... So, an intracranial cyst in the fetus can arise from any intracranial plane or structure. There doesn't matter, there's no visual. They are anechoic because they are fluid containing. So, a cyst in ultrasound is easy or hard? Cyst in ultrasound, easy or hard? Loudly, I want all the youngsters. But we must realize that the cerebrum also is hypoechoic. So the contrast is not there. So you have to be very attentive. That's number one. Number two is, we all know that the near half of the brain is hidden by reverberation echoes, isn't it? So cyst is in the near half might not be seen very well. That's number two. And number three is the posterior cranial fossa is a small space surrounded by lot of bony confines. So if you find a cyst in the posterior cranial fossa, to locate a small cyst in the posterior cranial fossa might be a challenge, right? So let's look at the strategies that we have for maximizing detection. The first thing I want you to realize is the cranium is not a set of three planes. Iswag asks us to do three planes, the transthalamic, the transventricular, and the transcerebellar. Is the brain only those three sections? No, it's a volume. And to treat it as a volume, you must take a real-time sweep, axial and coronal, not given by the ISWAG, but you must do it. And this is the way you store a sweep. Just go up and down so that you cover the brain in between the basic sections. So, limiting yourself to basic sections, you might miss a lesion. Also be sensitive to a potential midline shift, and always look at the near ventricle and document the near ventricle. If you document the near ventricle, at least this portion, you're sure there's nothing gross happening, right? So here you have the far ventricle. I've moved the probe posteriorly, I've got the near ventricle, and in the process of doing that, I have actually eliminated the entire near ventricle in some cases, or in others, at least a part of it. If you're doing measurement of the ventricle, you make sure that the two hemispheres are symmetric. I can measure here because they are symmetric. I cannot measure here the near ventricle because it is asymmetric. So for seeing, asymmetric is good. For measuring, make sure that the two hemispheres are symmetric. So these are the ways you can really maximize your chances of picking up a cyst. Now when you detect a cyst, you've got to look at it in terms of shape, size, location. Doppler, go to a differential diagnosis and come to a diagnosis. And once you diagnose, follow up for size of the cyst, what happens to it, and whether it's potentially going to obstruct the ventricles or not. Also look for other intracranial abnormalities and extracranial abnormalities. And if you look carefully, I have done this word location in yellow because if you get your location correctly, you have got your diagnosis. That's it. You know where it is, you know what is the diagnosis. That is the importance of the location. Now that location is important, we've got to answer location in 3 questions. Is it inside the neural tissue, axial, or is it outside? For example, this is an outside extra-axial lesion, whereas this is an intra-axial lesion. Is it infratentorial, that's the plane of the tent, or is it supratentorial? And is it midline, as you can see here, or is it off the midline, as you can see in this? Wherever the cyst is, once you detect a cyst, you must go into the extended neurosonogram mode. No stopping with the basic and saying, okay, I'm lifting my hands, I've found a cyst, that's all, I'm not going to do anything more. That's wrong. Multiplanar, extended neurosonogram, you might use 3D. TVS is extremely important, as I show you in future cases, and of course measurements. You can use color for landmarking, and I'll show you examples of that, and MRI is a useful added investigation. So let's look at the first question, whether the cyst is intra or extra-axial. What you do is to examine the relationship of the cyst to the brain around the cyst or in the vicinity of the cyst. Now let's look at this. If the cyst is indenting, compressing, or displacing the brain, that is extra-axial, right? On the other hand, if the brain surrounds the cyst, if there's a claw sign, and if it is intimately related to the lateral ventricle, here the brain is surrounding the cyst, and it's very intimately associated with the lateral ventricle, you know that it is intra-axial. Whereas here, the cyst is quite a distance away from the lateral ventricle, as you can see. And this is a very important thing, and we'll allude to this as we go by. Now, you can also classify cysts by etiopathogenesis, and first is normal spaces and variants, and I've shown you an example of a cyst in the cavum villi interpositi. Here is a developmental cyst in terms of an arachnoid cyst of the midline supratentorial. Here is a vascular cause, vein of Galen aneurysm, and here is a destructive cause, a porencephalic cyst. We will come back to all these cases as we go on. So the normal cystic spaces are CSP, CV, CVI, and CM. And we know how these look. This is the CSP in multiplanar, that is the coronal, and this is the CSP and CV in the mid-sagittal section. Also, we must understand the CSP is not only seen in the transcaudate plane, coronal, it's also seen in the transthalamic plane, coronal, and the CM all of us are very, very conversant with, and that is the retrocerebellar cisterna magna in all the 3 fields. Now here is another case which shows you a space out over here. Intra or extra-axial, quickly. Intra-axial, extra-axial. Midline or off midline? Midline, and it's indenting the parietal lobes. Go multiplanar. On cranial, you see, on coronal, you see the cyst over here. Again showing you that cyst is inside or outside the brain. Outside the brain, mid-sagittal, classical location, just under the splenium of the corpus callosum, and if you look at it, it is dissecting between the fornix and the tela choroidae. Classical beak sign that you have, classical beak sign that you have, and this tells you that this is a prominent space called cavum villi interpositi, and I've shown you this in axial, coronal, as well as in the mid-sagittal sections. Now let's come to the parafalcine cyst. So we'll go to extraaxial, supratentorial, midline. Quickly we'll go through it. And this is a 26-weeker, colpocephaly, pointed anterior horns, no CSP. There is a midline extraaxial cyst, which on coronal is parafalcine. It's got a septum there. And when I go mid-sagittal, I see the vermis here. I see the cyst over here, but I don't see what? I don't see corpus callosum. Complete agenesis of corpus callosum with an interhemispheric cyst, and that's the MRI showing you the forks, showing you the interhemispheric cyst, and classical communication with the third ventricle you can see here. Those are the two thalamic bodies, right? Now let's look at this 25-weeker, again midline, extraaxial. You can see it compressing the brain from outside, and you will see that in the mid-sagittal section on transabdominal, you see only a bit of the corpus callosum here. The posterior corpus callosum is totally missing, and the cyst is emanating out. So you go transvaginal, and in transvaginal, your findings are quite clear. The corpus callosum is incomplete, the cyst is sitting there, and when you do your coronals, you will see that the cyst is clearly on one side of the forks, and this is the corpus callosum, which is a little skewed, right? And when I go posteriorly, that's the cyst, parafalcine, extraaxial, midline, and it is communicating with the third ventricle. Always bear that in mind. In callosal abnormalities, the interhemispheric cyst communicates with the third ventricle. Whether it's a complete agenesis or a partial agenesis, that is what happens. And this is the MRI of the same case, showing you the T2 weighted images. That's the cyst which is in direct communication with the third ventricle. In fact, the cyst is a blowout of the roof of the third ventricle, which is the tela choroidea. Now, again another cyst, parafalcine, transabdominal, you see the corpus callosum here, not very clear, you see the cyst here. So you change your probe, go to transvaginal, and now answer this question. The cyst is seen midline, but what about the corpus callosum? Intact or not? Loudly, intact or not? Intact. So when you see a cyst with an intact corpus callosum, please think of a arachnoid cyst. And that's a midline arachnoid cyst. And on the transvaginal coronal, you see that the corpus callosum is intact, and that is the parafalcine cyst sitting in the midline, displacing the brain. On one side, it's compressing, right? Here is the next case, and this is a midline cyst again, extraaxial. Turn the color Doppler on, you find the circle of Willis all around the cyst. And this is called vascular landmarking. Because the vascular, circle of Willis is around, so you know that this cyst is sitting in the suprasellar cistern. So it's a suprasellar cyst in all the three planes, with color in all the three planes, without color, and that's your diagnosis here, right? Now, again, another cyst, same location, midline, extraaxial, under the splenium, but when I turn the color Doppler on, I find the internal cerebral vein and the great vein of Galen, which is cephalad or caudad to the cyst. It's cephalad. So this diagram will help us. This is the internal cerebral vein, vein of Galen. If the cyst is inferior to this, it is a quadrigeminal cyst, quadrigeminal cistern cyst. If it is above this, it becomes a CVI cyst. So this is an example of a quadrigeminal cistern cyst that you can see here. This is the vermis of the cerebellum, cyst, splenium, and the great vein of Galen is going on top of the cyst, telling me that the cyst is in the quadrigeminal cistern. On the other hand, again, another cyst, which is in the same location in the axial view. Your eye has caught this. And when you go multiplanar, you again see a cyst under the splenium. But in this case, when I turn the color Doppler on, the great vein of Galen is pushed down or pushed up? It's pushed down. And therefore, this is not a quadrigeminal cyst. This becomes a cyst in the CVI. Nothing to worry. Even a small quadrigeminal cyst, don't worry, just do a repeat scan. And a CVI cyst, don't worry, just do a repeat scan. But in this case, the associated findings are very important. You see that small little nodule? You see that small nodule? You see the small nodule? So together with the CVI cyst, you have periventricular nodular heterotopia. So therefore, your counseling will be for PNH and not for the cyst really. Again, another cyst, same, you see it just under the splenium, but this is easy for all of us. We know that this is the vein of Galen aneurysm, and that is the straight sinus. This is the dilated superior torcula, and that will be the dilated transverse sinus. Do your color Doppler and you find all the findings of the feeders and the main vein of Galen. And this is the mid-sagittal section, shows you the cyst again under the splenium, And this is a 3D color only. You will show the feeders, you will show the vein of Galen aneurysm, a dilated superior sagittal sinus, so on and so forth in this case of vein of Galen aneurysm. And again, another case which shows you a dilated third ventricle. All of you agree that this is not the way the third ventricle looks. There is ventriculomegaly, far ventricle, ventriculomegaly, near ventricle, and I don't see the CSP. There is a septal breakdown, septal absence. So you have to go transvaginal. And in the transvaginal, you find a septal absence. But as I'm doing the sweep, you see another cyst over here. Yes or no? Now what is that cyst? Dilated third ventricle, not this. This is the dilated third ventricle. These are the dilated lateral ventricles. There's absent CSP or septipellucidity, and you're wondering what this cyst is all about. So you go orthogonal, you go to your mid-sagittal, that's your corpus callosum. This is the splenium, and under the splenium you see the cyst. I've shown you 5 cases, all different etiologies. Under the splenium you see a cyst, but here you also know that the third ventricle is dilated, and if you carefully see, that cyst is communicating with the third ventricle, and therefore this is a hydrocephalus, septal breakdown, and because of the aqueductal stenosis, the pressure is high, the third ventricular dilatation has transmitted pressure into the suprapineal recess, and the suprapineal recess is now dilated. This is the third ventricle, and this is the suprapineal recess. We normally don't see it because it doesn't have, or it has very less fluid, but here is a suprapineal sinus, which is prominent, fluid-filled, communicating with the third ventricle, and that is an important differential diagnosis as well. Now, I have one question to ask you. This is mid-sagittal section. What is this? What is this structure? Choroid plexus. Why are you seeing it in a mid-sagittal section? Septal agenesis. So if we can put this as a quiz question, just show the mid-sagittal. Because the choroid plexus is there in mid-sagittal, I know that the choroid plexuses are going across the midline. Can you see that? Across the midline. And that is why it gets trapped in the mid-sagittal section. Is it confusing or easy? Confusing or easy? Thank you. And this is, of course, a tissue bone reconstruction on 3D. I have shown you the third ventricle, a little bit of massa intermedia, and this is the suprapineal recess, which is dilated, and you see the communication very, very well out over here. And this is multiplanar. I've put the dot in the suprapineal recess, and the dot falls there, the dot falls here on the coronal as well as on the axial images. So what is the DD for a cyst under the splenium of the corpus callosum? A prominent CVI in terms of only prominence or cyst, a quadrigeminal arachnoid cyst, pineal cyst, dilatation of the suprapineal recess, and vein of Galen aneurysm. So you've got to sort this out when you see a cyst in between the parietal lobes on an axial section. After this midline, we go to off midline, and here is an example. Those are the cerebral peduncles. This is sitting in the cisterna ambiens, and look at the way it is indenting the brain. It is not in the brain, indenting the brain, extra axial, and this is a cisterna ambiens, arachnoid cyst. You see its relationship to the cerebellum in the axial view, and when you do your coronal, you find it supratentorial, depressing the tent downwards on one side, and this of course is your rotational display. This is your calcini, and that's your sono AVC to make out the volume of the cyst, and that's a cisterna ambiens arachnoid cyst. Quickly we'll move on to, so we finished midline supratentorial. We had an example of an arachnoid cyst off midline supratentorial. Now we go to infratentorial midline, and these are easy, and all of us meet up with this. The normal cisterna magna. This is mega cisterna magna. This is a Blake spout cyst where the vermis is normal but rotated. This is a Vermian hypoplasia. The vermis is small, it's misshapen, and it's elevated or rotated. And lastly, in the spectrum is the huge cyst over there causing flattening of the vermis, elevation of the tentorium, and you have the classical rat tail sign showing you that the Blake's pouch is really huge and large, and it's elevated the tent, and that's Dandy-Walker malformation. All of us are very familiar with this, but let me show you two other lesions. Worst is a cyst that you can see here. This is the cerebellum, and you see a huge cyst posterior to the cerebellum. There is also a septum seen. Now when you go cephalad, the cyst extends anteriorly, and this anterior extension is above the cerebellum or below. It's above the cerebellum. And in the mid-sagittal section, you see the huge cyst extension above what? What is this? This is the vermis, yes or no? It's going above the vermis, and this is a large arachnoid cyst. Why is this not, you can see the MR findings there. Axial, you can see it going anterior, you can see it going above the cerebellum, and on a midline, again a huge cyst, one septum going above the vermis. Why is this not a Dandy-Walker? It's again a big cyst. Why not Dandy-Walker? Quickly. What happens to the vermis in Dandy-Walker? It's lifted or elevates. Do you find the vermis elevated? No, it's retrocerebellar, and therefore this is not Dandy-Walker. This is an arachnoid cyst. Let's look at this. This was actually quite a challenge where mid-sagittal section and multiplanar helps. You see a cyst in front of the cerebellum. That's the landmarking. It's squashed the circle of Willis anteriorly. The ventricles at 20 weeks were normal. At 24 weeks, the cyst has grown in size. The ventricles are beginning to dilate. You do a multiplanar, and in the mid-sagittal section, you see that is the corpus callosum. This is the vermis. What is this? Loudly, brainstem. This is the massa intermedia. That is the third ventricle. And the cyst is anterior to the brainstem or posterior? Anterior to the brainstem. The cyst is so big that the brainstem is arching over it, the pontine belly. Everything is obliterated. You can see the cyst, the brainstem around. So what is the plane? It is a retroclival or pontine arachnoid cyst. Why is it pre-pontine? Because it's front of a pons. Why is it retroclavial? Because it's behind the clivus, right? So that's a huge, and what helped you? You were confused on axial, but the mid-sagittal showed you exactly where the cyst was. So then we'll go to infratentorial of the midline, and here is a of the midline arachnoid cyst that you can see here. The vermis is normal, and you're scratching your head whether it's a unilateral cerebellar hypoplasia or whether it is compression due to an arachnoid cyst. Do an MRI, and on MRI you have, what sign is this? Compare the occipital bone here to here. Don't you see scalloping? So it tells you arachnoid cyst or a unilateral hypoplasia. Arachnoid cyst, right? So this is how MRI helps. Because of the scalloping, I know that this is not an abnormal cerebellar hemisphere, it's only compressed and not hypoplastic. So here is another example. On one hand, this cyst is compressing the occipital lobes. You can see the lateral ventricles here. When I go down, it is also pushing what anteriorly? What is this? Cerebellum. How can one cyst push both the occipital lobes and the cerebellum together anteriorly? It should be either supratentorial or infratentorial. How will it push both? That means it is outside of the dura. It's not, it's in the dura. It's not in the subarachnoid space, but it's dural. And this is a classical dural sinus malformation or a DSM. And you can see on mid-sagittal section how it has pushed the vermis as well as the midline anteriorly. You turn the color Doppler on, you find your classical slow flow happening within the dural sinus malformation. Then we move on to intra-axial. Till now we finished all extra-axial. Now intra-axial quickly. So supratentorial, it could be parenchymal or it could be inside the ventricle. Let's look at parenchymal. And parenchymal, you always have to do a coronal if you find a parenchymal cyst. If it is a cyst which is below the lateral ventricle, periventricular pseudocyst. If it is at the angle of the lateral ventricle, conatal cyst. If it is superior to the lateral ventricle, this is a cystic encephalomalacia. All of them are off the midline. Now I want you to examine this 29-weeker. This is a transventricular and this is a transcerebellar. You've got this on your machine, you've finished running your checklist. Are you going to certify this as normal or abnormal? Two planes I've shown you, normal or abnormal? Normal. It's hard to call a section normal, especially if it's shown in a conference, isn't it? So normal, yes, both of them. Agreed or not? Normal, lift up your hands quickly. Normal, lift up your hands. That means it's abnormal, is it? What is the abnormality? Pardon me? Near lateral ventricle, I've done the near lateral ventricle, it looks good. Nothing was there. Normal. So this is normal. I've documented, shown you. But in the same case, I'm going to show you this sweep. Now tell me, normal, abnormal? Can you see a cyst there? All of you? Let me take you to the... Can you see it? This is why the sweep is important. If you don't do the sweep, you will miss this. Now, is it intraventricular or extraventricular? Looks intraventricular. Multiplanar is important. Now I'm showing you the same case, transvaginal, multiplanar. Look at the cyst. Is it outside the ventricle or inside the ventricle? Loudly. Outside, under the undersurface or over surface? Undersurface. You're going to call it a periventricular pseudocyst. That is the one which is under. This is the one which is under. and when it's under, it's a periventricular pseudocyst. And in such a case, if you have the growth normal, if you have the Dopplers coming normal, if you have the infection profile coming normal, and if you do not have anything else abnormal intracranially, these cysts have a good prognosis, right? So that's as far as a PVPC goes. Here is again another. You see the lateral ventricle there, that's the occipital horn. There's a periventricular cyst over there, but here there is a synecium happening. There are other signs of CMV infection, so you're worried about this particular fetus, right? Now let's look at another one. This is a PVPC outside, but there's florid calcification, which is not subependymal. This is parenchymal, and therefore I'm going to think of Sturge-Weber syndrome, or more likely an Aicardi-Gouttiere syndrome. Periventricular pseudocyst, as I told you, if there are nothing else associated, the prognosis is good. Now let's look at this. The ventricle is dilated, 31 weaker, and you find a lot of cysts happening there, intraparenchymal or extra. Is it intra or extra? Intra. And if you look at the relationship to the lateral ventricle, is it above the lateral ventricle, at the angle, or below? Above. Once it is above, you're very, very worried. This is cystic encephalomalacia. This is an insult to the centrum semiovale of the brain, and your counseling is going to be not good at all. So this is cystic periventricular leukomalacia, very bad. Now you see this 25 weaker, you see a cyst which is happening just lateral to the lateral ventricle. You go multiplanar, and on transvaginal scan, you find this is the right anterior horn, and you see the cyst at where? At the angle, or below or above? At the angle. So you see it at the angle, and also you notice that the left anterior horn is missing. It's not there at all. So you're worried, but it's at the angle. You go parasag, you find this is the cyst which is lateral to the lateral angle, but there's also two little small spaces above. That's a little worrisome. But if you find cyst at the angles of the lateral ventricle, that is conatal cyst, entirely harmless. Nothing to worry, and they are usually in the frontal horn area, not in the parietal, not in the occipital, and you can see the sagittal, parasagittal section over here. We don't have time for details, and you can correlate the pathophysiology of why the anterior horn has disappeared on one side. Now here is a case where you had a bleed in the parenchyma. That bleed has become cystic, and it's evolving into a porencephalic cyst. And I want you to tell me whether this cyst is communicating with the lateral ventricle or not communicating. Communicating. A porencephalic cyst communicates with the lateral ventricle. Since it's evolving, you see some residual clots within, and that is the MRI version. This is the ultrasound version, and that's the MRI version of a post-hemorrhagic porencephalic cyst. Here's a schizencephaly. All of us know it's a big open lip cleft between the subarachnoid space and the ventricle. Here it's actually bilateral. If I play this clip, you will see that it's bilateral. Okay, so it's bilateral clefting, and here you see the communication with the ventricle on one side and the arachnoid space on the other side. Does this mean I stop the lecture? No, just give me another 2 minutes, I'll finish. Towards the end, the projection is gone. Yeah. Yep. Okay, so you see the communication with the ventricle as also the subarachnoid space. We move on to supratentorial intraventricular. So you have the choroid plexus cyst, ependymal, and choroid cyst. Choroid plexuses are very common. If they're isolated, we are not worried. If they are small, we are not worried. You just show that there are no other stigmata of trisomy 18 and carry on with it. But if you have associated findings, here's a 22-week bilateral choroid plexus cyst. You have contractures which are happening. You have a cardiac defect, you can see a scoliosis and a rocker-bottom foot that you can see. Do a karyotype, you have picked up a trisomy 18. We go on to infratentorial parenchymal, and that's a cerebellar cyst. Let's look at one example. Here is an axial section. You see the cerebellum hemisphere on one side, and on the other side you find a cyst sitting within. Now, is it an arachnoid cyst outside, or is it a cerebellar cyst inside? What is your take on this if you find something like this? So there will be a difference of opinion. Some of us will say outside, some of us will say inside. But for me, I thought this was actually the surface, and this is inside. And most of these are glioependymal cysts. A few of them are hemorrhagic. So you do an MRI. This is the transvaginal picture. You see the clarity increases. This is a coronal. This is on one side, you see the lobe. This is the vermis. This is the other side. With the transvaginal picture, what do you feel? Is it inside or is it outside? At least the people this side can see. It's inside or outside? It's inside. And that is the MRI T2. And what sign is this? Claw sign. Typical claw sign telling me that it's intracerebellar and not extracerebellar. So what's the role of 3D? Multiplanar display, location relation to other structures. You can navigate and identify structures. Accurate volume calculation, rendering helps better display. So you have to know some cysts are large and some cysts are small, and some cysts are classical by their location. Some cysts appear late. You have some cysts with syndromes, and of course, you have not only syndromes, but also sometimes, very rarely, you have inborn errors of metabolism. So location of the cyst, you get the differential, and then you go on to the diagnosis. Color Doppler to rule out vascular anomalies, as also to landmark the arterial landmarks around the cyst. Some midline cysts are anatomical. Diagnosis leads to prognostication. Follow-up necessary to assess growth, and 3D ultrasound MRI are useful adjuncts, multidisciplinary counseling. Thank you very much for a very patient listening. Thank you.
Thank you, sir. Now I invite Dr. Mrinalini to come onto the stage and hand over the token of appreciation to Dr. Ramurthy, sir. Up next, we have fetal thoracic lesion by Dr. Sudhir.
Okay, so after that excellent talk by Ramurthy on intracranial cystic lesions, I am going to talk about fetal thoracic lesions. Now we know that we see and we don't see the fetal lungs because our focus is on the fetal heart. But you need to take your focus away from the fetal heart and look at the fetal lungs also every time you scroll through the fetal thorax. They are the homogeneous echogenic tissue surrounding the heart. The lung echogenicity increases during gestation. Thorax, lung, heart proportion is relatively constant. So when you're talking of the lung size, just one global view of the transverse section of thorax is usually good enough. So you see these echogenic tissues surrounding the heart and the great vessels at a supracardiac section. It tells you that you have normal looking lungs on either side. Diaphragm is also visible as a thin hypoechoic line, particularly when you are doing a coronal or a sagittal section. Because the liver is relatively hypoechoic to the lung, so that also demarcates the location of the diaphragm on either side, so it helps to locate the diaphragm in looking for certain lesions. Now lung development depends on availability of growing space, pulmonary fluid secretions and normal fetal breathing movements. All these are necessary for proper development of the lung. So essential for normal lung development, any abnormality of these factors will result into reduced lung development. Now, primary pulmonary hypoplasia bilateral is of course incompatible with life. Unilateral pulmonary agenesis is rare. It occurs in about 1 in 15,000 births. It is often associated with other congenital anomalies. So when you do your scan, you see the lung on one side, you don't see the lung on other side, and consequently the heart and mediastinum are shifted to the side where the lung has not developed. So usually it is, as I said, fairly uncommon, and the cause of unilateral absence of lung is not always possible to elucidate. So here again what we see is the heart is shifted to one side. When you have heart shifted to one side, you have to rule out whether it is pushed or it is pulled because of absence of the lung. You don't see any lung tissue on that side, and when you look at the pulmonary trunk, you also don't see the pulmonary artery on that side, so you know definitely that this lung is absent, it is totally not developed, and that is the postnatal radiograph of that baby. Secondary lung hypoplasia can be due to an underlying cause, and it can be an intrathoracic cause or extrathoracic cause. So you might have space occupying lesions in the thorax which compress the lung and do not let that lung develop, or you might have extrathoracic causes like oligamenos, skeletal abnormalities, a very small thoracic cage which does not allow the lungs to develop, or there could be neuromuscular problems reducing the breathing movements which are necessary for the lung to develop, and all that can result into hypoplasia of the lung. So how to decide whether the lung development is normal is by measuring the size of the lung. That you can do by measuring the area of the lung in the same transverse axial plane where you have the apical four-chamber view. So you can measure the lung area. There are nomograms available for volume measurements. You do a volume acquisition of the lung, do your vocals to figure out the lung volume. But a very simple way is to calculate the thoracic circumference to abdominal circumference ratio, which gives you a relative dimension of the size of the fetal abdomen to the fetal thorax, and this ratio is relatively constant throughout the gestation. So the thoracic circumference below 5th percentile for gestational age would indicate pulmonary hypoplasia. So that's a simple way of getting a rough estimate whether the lungs are properly developed or not. and the mean ratio is usually around 0.9, and 0.8 is the usually accepted cutoff for the TCAC ratio. So it's not very difficult to do. You measure the circumference of thorax, circumference of the abdominal circumference, and find out the ratio. It will usually be above 0.9. When it is less than 0.9, you know this is the lungs are not properly developed. They are going to be fairly small. Then the problem of intrathoracic or intrapulmonary lesions, mostly space occupying lesions, which will not allow the lung to develop. So we have masses in the fetal chest. They are almost always benign. The problems develop due to the physical alteration caused by the space occupying effect of these lesions. So they may result into lung hypoplasia. If they are compressing the esophagus, they will result into polyhydramnios. And if they are compressing the vessels, they will result into CCF and hydrops. So we might find pleural effusion. What are the causes of space occupying lesions in the thorax? Might be pleural effusion. We might have a CCAM or a CPAM as it is called now. You can have bronchopulmonary sequestrations. You can have congenital lobar hyperinflations or a congenital a chaos, or you might have neurenteric or bronchogenic cyst, or you might have a diaphragmatic hernia coming up and occupying the space in the thorax, compressing the lungs as well. So pleural effusions are fluid collections which are easy to see on ultrasound. They could be unilateral, bilateral, anechoic spaces in thorax surrounding the lungs. Isolated congenital chylothorax is found in about 1 in 10,000 birds. In half of the cases, the infusion is isolated, and in other half, there is an associated hydrops, which is resulting into pleural effusion. There could be associated anomalies, some chromosomal anomalies, and therefore we need to do a detailed ultrasound, including the fetal echo, invasive testing for karyotype, infection screens, and assessment for fetal anemia. So you might, as I said, find this fluid surrounding the lung, peripheral to the lung, and that tells you that you have a pleural effusion. It could be bilateral or it could be unilateral. So you need to see whether the lungs are approximated to the heart in pleural effusion and they are away from the heart in pericardial effusion. So that's the way you differentiate a pericardial effusion where the lungs are away from the heart, and pleural effusion where the lungs are very close and compressed along the cardiac margin on either side. The effusions can be small or large, and a lot of them will regress when you follow them up. So here is one such example where we had a large pleural effusion, but that regressed on follow-ups. So, but if they remain persistently large and compress the lung, you might need to tap them. Then you have congenital pulmonary airways malformations. Their commonest lung anomaly account for about a quarter of lung masses in the fetus. The lesion consists of pulmonary tissue with abnormal bronchial proliferation. So it is a non-functioning lung tissue. It may occur in either lung, any lobe, but is most often unilateral. The lesions are cystic in about 3 of the 5 types and adenomatous only in 1 type. So they have a varied appearance from cystic to non-cystic. So Stoker classification is the commonly used classification where you have type 1 with large cysts ranging from 2 to 10 centimeters. Type 2 is with small cysts of up to 2 centimeters. Type 3 is adenomatoid, so you don't see any cystic lesions, and that is usually echogenic. On ultrasound, we usually are able to classify type 1 and type 4, which have large cysts, type 2 which has small cysts, and type 3 is microcystic. So the lung appears hyperechogenic because there are multiple small cysts. So here is an example of type 1 macrocystic type where the cysts are large, more than 2 centimeters, and if they are very, very large, they also might need to be drained. So the lung here is enlarged, it is ballooned, and that is because of several cystic lesions which are more than 2 centimeters. In type 2, you have cysts which are all less than 2 centimeters, so they are small size cysts, and it's not usually possible to aspirate individual cysts in these lesions. Another fetus here with the lung with macrocysts, but they are all smaller than 2 centimeters, and that's the postnatal X-ray of the same fetus. You might do some volume scans to look at the cysts, but that usually does not add to your diagnosis. And then you have type 3, where there are microcysts, and therefore that produces a hyperechogenic appearance of the lung. So you have part of the lung which appears hyperechoic, very brightly echogenic on ultrasound, and on T2 weighted images it will show a homogeneous hyperintense lesion occupying entire the right lobe of the same fetus that as we saw here. The middle lobe and upper lobe were normal. There could be associated anomalies, but they are uncommon. Sometimes you might come across associated renal abnormalities with these type 2 or 3 CCAMs in the form of cystic lesions of the kidneys. So about 30 to 40% of neonates with prenatally diagnosed CCAM may have respiratory distress at birth requiring support or intervention. The lesion may regress more often in later part of the pregnancy, so when you follow them up, the affected lung appears to regress in size. Although the lesion may become unidentifiable on prenatal scan, it does not really totally disappear. It may not be visible on postnatal chest X-ray, so you have diagnosed a CPAM, postnatal X-ray appears totally clear, but that lesion has not totally disappeared, and it might produce problems later on if it gets infected, and therefore a CT or MRI may be required to make sure how much that lesion has regressed. So here is one type 3 CPAM. Here you can see this part of the lung is hyperechoic, and then when we follow that up, this CPAM has become very small. It's almost unidentifiable on the prenatal sonography, and is not identifiable on the postnatal chest X-ray as well. But it would still be visible if an MRI or a CT scan is done. Then we have congenital lobar emphysema, or congenital lobar hyperinflation, as we prefer to call it now. So there is a valve type obstruction of a lobar or a segmental bronchus. So that results in entrapment of fluid and overinflation of the part of the lung without actual destruction of the alveolar spaces. The left upper lobe is involved in about half of the cases, the right middle lobe in about 1/3, and the right upper lobe in about 1/5 of these cases. So you have a enlarged hyperechogenic lung with fairly homogeneous ecostructure there. Another example here, extremely enlarged hyperinflated lung on this side, which has produced a huge mediastinal shift on the opposite side as well. And this hyperinflated lung will produce a inversion of the diaphragmatic curvature as well. So the diaphragm also appears convex inferiorly as compared to what we normally see as convex superiorly. But if you do color Doppler, because there is no abnormally developed lung tissue or destruction of lung tissue, the lung vasculature appears normal. So the distribution of the pulmonary artery branches and pulmonary venous drainage would look normal in these lungs. Then you might have cystic lesions, which are bronchogenic cysts, which are rare. The result from abnormal branching of tracheobronchial tree. Most occur in the mediastinum, but 1/5 occur inside the lung, and then you need to differentiate them from CPAM, but they are usually single. So you see a single unilocular cystic structure there within the lung, or sometimes you might see them in the mediastinum, more commonly near the trachea or the main bronchus there, and we need to consider the possibility of bronchogenic cysts there in the mediastinum. Here is another example, a large cyst inside the lung this time. As I said, so bronchogenic cysts could be intrapulmonary or they could be in the mediastinum as well, and that's the postnatal radiograph of that large intrapulmonary bronchogenic cyst. Then you have bronchopulmonary sequestration, that is pulmonary tissue is in a localized area, does not have normal continuity with the tracheobronchial tree, and therefore it is non-functioning. And because it does not have a communication with the tracheobronchial tree, the secretions pile up, and that is what makes this part of the lung more echogenic. So this segment characteristically also has a systemic blood supply, and that is how we are able to differentiate a bronchopulmonary sequestration from a type 3 CCAM, because type 3 CPAM also appears homogeneously hyperechoic on our ultrasound. But there could be problems when there is a hybrid lesion. So you have in the same lung, part of it is a type 3 CPAM and part of it is a bronchopulmonary sequestration. So we need to look at the vascular supply every single time. Two types have been described. One is extralobar, which develops as a separate lung bud, and therefore it has its own pleural sac. It has a systemic arterial and venous supply. The commonest type are detected prenatally. Or you might have an intralobar type, which is within the same pleural sac as the rest of the lung. It has a systemic arterial and a pulmonary venous supply. So the blood is coming in from a systemic artery, usually a branch of the descending aorta, and the blood drains into the pulmonary veins rather than the systemic veins, as might happen in an extrapulmonary bronchopulmonary extralobar bronchopulmonary sequestration. So it is possible to differentiate prenatally if the vasculature, vascular supply of the lesion can be identified. On ultrasound, it has a non-specific appearance. It appears as a hyperechogenic area within the lung, well-defined, homogeneous, wedge-shaped mass. A typical location is the left lower lobe. And when you look at that left lower lobe hyperechogenic wedge-shaped area, you need to figure out the vascular supply. And here you can see that this area is getting its blood supply from a branch of the descending aorta or upper abdominal aorta. Here is another smaller lesion in the left lower lobe. That's the common site for bronchopulmonary sequestrations. And you have the blood supply coming from the systemic circulation. Another example here, again, typical wedge-shaped hyperechogenic area in the lower left lobe. And there we have the arterial supply coming in from the aorta, but the venous drainage is into the pulmonary vessels. So we think it more likely to be an intralobar bronchopulmonary sequestration rather than an extralobar pulmonary sequestration. Because the vessels might be going in different directions, sometimes if you have any confusion, you need to make sure that the arterial supply is from aorta, and that does show an arterial flow pattern on your spectral Doppler. And this one going into the pulmonary veins, although it appears in red, it is a pulmonary venous flow pattern on your spectral Doppler. That's quite characteristic. Here is a large echogenic area in the lower lobe, and again we can see that this is getting blood supply, arterial supply from the systemic circulation, and the venous drainage is into the pulmonary circulation. So we know this bronchopulmonary sequestration is intralobar as compared to extralobar. So that's the video clip showing you the arterial supply and the venous drainage. As I said, always make sure the sense of your color bar chart so you know that this vessel is flowing in this direction, and these vessels are flowing in that direction. Now, extralobar pulmonary sequestration often is associated with pleural effusions. So here you have a large pleural effusion and part of the lung floating in that pleural effusion. So first impression is that it is a simple large pleural effusion, but when you look very closely, you can find part of the lung close to the heart. So you know that only part of the lung is separate from rest of the lung, which is getting compressed here close to the heart because of this large pleural effusion, and only part of the lung is floating free into that. And that happens when you have an extralobar pulmonary sequestration. So it has a separate pleural sac which collects a huge effusion, and that is compressing the rest of the lung and whole of the mediastinum to the opposite side. So you have this lung here, which is normal, which is compressed, and you have this sequestered part of the lung which is floating within this pleural effusion, and that has a systemic arterial supply and a systemic venous drainage. So you know you are dealing with an extrapulmonary extralobar bronchopulmonary sequestration. Often these, not often, but sometimes these extralobar sequestrations are located infradiaphragmatically, and sometimes they are fused with the liver. So you need to keep that in mind when you find a space-occupying lesion on the left lobe of liver, and that might be an extralobar sequestration which has located subdiaphragmatically, and then you need again to look at the vascular supply. This part of the liver which is which has a different echogenicity has a systemic blood supply apart from the normal hepatic blood circulation. And then you have congenital high airways obstruction, chaos for short. That also acts as a ball valve mechanism, and therefore secretions get entrapped and both the lungs are enlarged, they are hyperinflated instead of one lung that we saw in lobar hyperinflation. That could be because of laryngeal atresia, laryngeal or tracheal waves, tracheal atresia, subglottic stenosis, etc. But what we see is bilaterally, symmetrically enlarged, homogeneously hyperechogenic lungs. The heart is usually placed centrally and pushed more anteriorly and compressed side by side in the midline. That's because of the significantly hyperinflated lungs which are pushing the mediastinum in the center and anteriorly, and that later can cause congestive cardiac failure, and the presentation might be as high drops. So these lungs are hyperechogenic, and the fluid within the tracheobronchial tree makes that tracheobronchial tree stand out. You can see it very nicely. And because these lungs are hyperinflated, they flatten or they depress the diaphragm on either side. So you'll see bilaterally altered convexity of the diaphragms have become convex inferiorly, but the pulmonary vascular tree is morphologically preserved. There is no destruction of the lung tissue by abnormal growths, and therefore the pulmonary arterial tree and the venous drainage is fairly well preserved. Here is a fairly advanced stage where you have a severe compression of the heart that is resulting into congestive cardiac failure. So you have edema, you have ascites, and that tells you that this fetus is already compromised. Again, you have hyperinflated lungs compressing the heart in the midline, and that is producing signs of congestive heart failure in this particular fetus. So high drops develops because of compression of the heart and central vessels. We need to do a detailed scan to rule out other anomalies and a karyotype to rule out chromosomal defects. In few cases where the hydrops is not severe or it regresses, an early delivery with an exit procedure might save this baby, because we need to preserve the respiratory function of this fetus. And then lastly, we have congenital diaphragmatic hernias also presenting as space-occupying lesions in the chest, compressing the lungs and not allowing lung development properly. This happens because of failure of closure of pleuroperitoneal canal that results into congenital diaphragmatic hernia. Herniation of viscera in the thorax interferes with normal development of the lungs and cardiopulmonary vasculature. Majority occur on left side through the foramen of Bogdalek. About 10 to 15% occur on the right side, and less than 5% are bilateral. Rarely we come across a hernia of Morgagni, and that is a little more difficult to detect. What you typically see is the heart which is pushed to the left side. You don't see the stomach in the fetal abdomen, and you see the stomach in the fetal thorax, telling you that the stomach has gone up to the level of the heart, and that is usually because of a diaphragmatic hernia. There is a defect in the diaphragm, and the abdominal contents have gone up into the thoracic cavity. So that usually is not a very difficult diagnosis. But the appearance might sometimes be confusing. If instead of the stomach, bowel has gone into the thoracic cavity, in the first instance it might be confused as a cystic CPAM, a type 2 CPAM, where the fluid-filled bowel loops look like cysts within the lung. So sometimes this gets confused with type 2 CPAM. If the bowel loops are compressed, it looks like echogenic tissue, and that has been confused with type 3 CPAM or a bronchopulmonary sequestration. So it always makes sense to look at the diaphragm. Even in early scans, if you don't see the diaphragm and the stomach and the contents have gone up, that's a clue to tell you that we are dealing with a diaphragmatic hernia there. So when the bowel loops are collapsed, they will appear as echogenic space-occupying lesion. Here the stomach is in midline. It is still a little inferior to the stomach, and something else has gone up to occupy the space. In this fetus, the stomach is in its normal place in the abdomen. But when you go to the thorax, you find the heart is displaced by a space-occupying lesion in the left lung. And then you are wondering whether we are dealing with a type 2 or type 3 CPAM. So you need to observe it slowly, and very often you are able to see the peristalsis within those cystic spaces, telling you that this is small bowel that has gone up and the stomach has remained in the abdominal cavity. But it is easier to look for the superior mesenteric artery, which also gets pulled up into the hernia. So you have an inverted course of the superior mesenteric artery going up instead of down, as it gets pulled up with the mesentery and the small bowel into the hernia, which contains only small bowel. So that's not very, very difficult. Also, all this displacement is going to produce an abnormal course of the intra-abdominal part of the umbilical vein there. And then you might have the hernia on right side. So the heart is displaced to the left side, the stomach is in its normal place, and that happens when you have the liver going up in a right-sided hernia. And if you have any doubt, again use color Doppler to see that the hepatic veins are distorted and they have gone up in the liver, which is herniated on the right side. So here is another right-sided hernia, and what initially looked like a large lung surrounded by pleural effusion. But you can see the lung here, echogenic lung, which is collapsed because of the pleural effusion. And the large part, what you see here, is not the lung, but that is the liver that has gone up. So here I can see the actual defect in the diaphragm, and we can see the liver that has gone up. So sagittal scan help you to actually see the defect in the diaphragm and what part of the liver has gone up. If the fetus is breathing, you can see these paradoxical movements happening because of the movement of the diaphragm. Normally the liver should come down as the chest expands, but here the liver goes up as the chest expands because of the paradoxical movement that happen in the diaphragmatic hernia. So how do we prognosticate in congenital diaphragmatic hernia? There are certain indicators which tell you that the prognosis is not going to be good, particularly a right-sided or bilateral congenital diaphragmatic hernia does not augur good prognosis. If you detect it very early, then the lung development does not happen. If the diaphragmatic hernia is not detected, very often it happens that it actually herniation happened late in the pregnancy, and therefore it was not detected. It presented as breathlessness, respiratory problems at birth. In that case, the lungs have already developed and then they were compressed, so probably the lung function preserves better. Or if there are associated abnormalities, that also does not augur well for the prognosis. So here is a diaphragmatic hernia on the left side. So what you do is you need to assess the size of the contralateral lung, whether that lung is good enough, and calculate certain ratios. The lung head circumference ratio is a common marker that is used for adequate lung size, or a observed to expected lung head ratio, which is a more specific marker. And depending on what you find, how the lung has developed or not, you might be able to give the prognosis in that particular cases. So with intrathoracic herniation of liver, the markers that you use are a little different when the liver is down in the abdomen. So intrathoracic extrapulmonary SOLs, they are masses in the fetal chest. They are almost always benign. The problems develop due to the physiological alteration caused by the SOL, if they do not allow the lung to develop, or if there is polyhydramnios, or there is hydrops. And prognostication will depend on assessment of volume of the lesion, mediastinal shift, do the observed to expected LHR, and look for any hydrops, and then we would be able to help prognosticate these lesions. So if the lesion is unilateral, uniformly echogenic, it could be sequestration or a CLE or a microcystic CCAM. If it is bilateral, we know it is chaos. If it is inhomogeneous, we know it could be type 2 CPAM or a CDH. So thank you very much.
Thank you, sir. Next we have Dr. Narayan Rao onto the stage with the topic Isomacol.
Hello. Yes. Is it out loud? Yes. Good morning, all of you. My topic is isthmosil. This is a tiny troublemaker. So how many of you know about isthmosil? Please raise the hands. Aware of? Oh, very few. Thank you. It is just a small Nike or defect of at least 2 millimeters in the previous cesarean scar. You can see the small defect here. So, what are the probable risk factors or this mechanism for Nike formation? Inadequate healing of lower cesarean scar results in the development of uterine defect, and sometimes it can affect the single layer closure of uterine incision, and it can be due to adhesions formation may delay the wound healing. So most of the patients, it can be a genetic predisposition for poor wound healing. So how to diagnose isthmocele? Just your TV ultrasound probe might just be the superhero that detects and solves the mystery. And we have to take the sagittal view as not in the coronal, only it is seen in the sagittal view. You can see the small defect here. So this is sometimes the defect cannot be seen with normal ultrasound. So you have to inject some fluid or gel, then you can see the defect clearly. So we can classify the defect as simple with one branch or complex with multiple branches. You can see small branches here. Sometimes you can't see just only a small cyst is seen. So for every patient with the isthmocele, we have to take some measurements. So length, and this is length of a scar, and the depth also we have to see. And most important thing is the residual myometrial thickness. It should be minimum 2.2 millimeters. If it is less than 2.2, the risk of ruptures or something complications in the cesarean scar. And we have to measure the adjacent myometrial thickness. This is adjacent myometrial thickness we have to measure here. This is the residual myometrial thickness we have to measure here. And this RMT to AMT ratio, if it is severe when less than 50%, that is if it is less than 2.2, the risk of rupture or risk of some complications. And complications of isthmocele can be divided into non-pregnant patients or pregnant pregnancy patients. From post-menstrual spotting to infertility, chronic pelvic vein dysmenorrhea can occur, most in patients, and even problems during future pregnancies. This little hole can dig a big hole in a woman's quality of life. And life-threatening complications in pregnancy, cesarean scar dehiscence can cause uterine rupture, it can cause placenta accreta spectrum, and placenta previa, cesarean scar, ectopic pregnancy. All these are complications of cesarean scar during the pregnancy, early pregnancy. And implantation within or near the previous cesarean scar pregnancy is the implantation within or near the previous scar tissue. It arises only in C-scar defect, not in fully healed scar. And early detection before 9 weeks reduces the risk of adverse outcomes. And what are the guidelines to detect C-scar pregnancy? In the C-scar pregnancy, the uterine cavity is empty and gestational sac or some small solid mass embedded at the site of C-scar, empty endocervix, and thin or absence of myometrium between the sac and the bladder or anterior abdominal wall, and sometimes we can have prominent vascularity on Doppler. So you can see the prominent vascularity. And how to assess the location of sac in the cesarean scar pregnancy. So location of sac is assessed about two hypothetical lines. We have to draw the two lines. That is, one is the uterine line, and another is the serosal line. This is, if the sac is below this line, the risk of risk of complications are less. If the sac is above the line, complications are more. and the serosal line, which is the outer margin of the myometrium. And the complications can occur. This is placenta accreta spectrum, and sometimes the retained products of conception can retain within the C-scar, can cause so many problems, like bleeding or pain, something. And this is a small scar hematoma, you can see. There is no vascularity here. Patient is complaining of continuous bleeding. Just you can see the small hematoma here. And some post-menstrual bleeding. Some patients complaining of post-menstrual, after completion of menstruation, still the patient is bleeding. So you can see the retained blood clots within the scar tissue. Still you can see the dilated cervix with a fluid within that. And sometimes it can cause retained scar dehiscence or rupture. Assessing the residual myometrial thickness is most important in non-pregnant state, might predict dehiscence in subsequent pregnancies. A depth and RMT ratio more than 1.3 raises the risk to more than 50%. Thank you very much. This.
Morning. Nice to see so many people Sunday morning after a lovely party. The topic is a bit boring, but we'll try and make it a little more interesting. So skeletal dysplasia is, of course, very rare pathology, and we see like 2 or 3 per year. But when they come, you have to scratch your head and come to some conclusion. You can see that majority of them are thanatophoric dwarfisms, achondroplasia, and osteogenesis imperfecta. So almost certainly, if you have a lethal skeletal dysplasia, you're dealing with thanatophoric or osteogenesis imperfecta. And if you have a late presentation after the second trimester, it's usually achondroplasia. Achondroplasia is usually a big problem because of late presentation, and it can mimic a constitutionally small fetus. So we need to have some clues there. So we have 3 types of skeletal disorders. Skeletal dysplasias, which are developmental disorders of chondro-osseous tissues, the classical dwarfism. Dysostosis is a malformation of a single bone, alone or in combination, like polydactyly. And then we have acquired skeletal malformations, very commonly seen nowadays in the first trimester, and that is secondary reductions of bones, so like an amniotic band sequence, etc. And here you can see polydactyly post-action. So it's very rare. We hardly see them, like I said, 0.3 to 3 per 10,000 birds, like 2 or 3 per year. And a large percent are stillborn. So they are very heterogeneous group, lot of phenotypic variability, and they can range from mild affection to perinatal lethality. Definitive diagnosis now is better. Earlier it used to be elusive, but now we can, with molecular diagnosis, things are a little more better. Praveen is already ringing the bell suggesting. So the minimum requirement is to distinguish lethal from non-lethal, but I think that was about 10 years back, and now we need to move further and classify them, at least with molecular diagnosis, as to come to a final conclusion. First trimester diagnosis is possible in most lethal malformations, and that will prevent them from going further and for us to see more of skeletal dysplasias. So we have to offer some degree of differential diagnosis, and we have a lot of tools today, 2D, 3D, MRI, CT, etc. And of course, molecular diagnosis that are conclusive. Skeletal dysplasias have all types of genetic inheritance, can be autosomal recessive, dominant, X-linked, whatever genetic inheritance is possible is there. So because of the phenotypic variability, we used to classify them earlier either with radiology or with pathology, post-mortem X-rays, post-mortem appearances. But today it is largely based on molecular genetics. The moment we find a small long bone, we suggest that we save the DNA, or we do genetic whole exome sequencing, and all the facilities are available now to come to a final diagnosis. And if you see here, these are two very interesting Chinese papers. So the great thing about China is they're doing massive amount of research compared to the rest of the world. And molecular diagnosis is approximately found in almost 80% of skeletal dysplasias. It was unheard of when we started doing fetal medicine in the 90s. We used to come to a conclusion in about 20 to 30% of cases. But with molecular diagnosis, we have now identified almost 436 types of skeletal dysplasias. So it's a huge development in the last 30 years with, with genetics. So we have 436 different conditions in 42 groups, and 364 genes have been defined. So that, I think, is a remarkable contribution to skeletal dysplasia diagnosis by molecular genetics. Of course, there are stray incidences of isolated bone disorders, like you can see here. This is a twin pregnancy with one fetus having a normal thigh length and the other fetus having a short thigh length. And only one bone was bent here, and that is a femoral hypoplasia with a kind of bowing. You can see very well on this image with minimum mode 3D, where you see a short femur compared to the other long femur. And this is the only isolated defect. And this actually being a small defect, but can lead to a lot of problems of limb length, and the fetus may, the baby may require limb lengthening surgery, etc. So they opted for embryo reduction of that one fetus. We reduced that one fetus and continued the other fetus. At the other extreme is this very interesting fetus who at about 30 weeks had this valgus deformity and would just not move the legs, and there was polyhydramnios, and otherwise structurally normal. Anybody wants to venture a diagnosis, lack of limb movements, polyhydramnios, 30 weeks? Huh? Arthrogryposis, yeah. So that was the real fear that we had in our mind. And we doomed the parents saying that this is arthrogryposis, did an amniocentesis, ruled out trisomy 18, and it was very embarrassing actually. because we told the parents this fetus is going to be paralyzed. It just didn't move for the next 10 weeks of the pregnancy. Valgus and this typical appearance. Any other thoughts beyond arthrogryposis? So sometimes you think of some things that you know, and you don't think of things that you don't know, of course, and the diagnosis then helps you, and this was actually intrauterine congenital dislocation of the knee. So what we doomed as arthrogryposis, after birth, the baby was corrected surgically, and baby was absolutely all right now. So you have to be very careful when you talk about antenatally certain conditions. You never know, there might be something you have never heard of. So this is hyperextension of the knee, partial fibrosis of the quadriceps, absence of the suprapatellar pouch, and some other conditions. Of course, they have association with meningomyelocele, arthrogryposis, etc. And you can see that there was hyperextension and valgus, and today the baby is absolutely all right after surgical correction. So sometimes we think we know a lot, and we land up in problems. Now, the common dysplasias are grouped now according to the molecular gene defect. Earlier, we used to group them in terms of lethal, non-lethal. We yet do that as a beginning point in ultrasound, but as a conclusive diagnosis, we've now grouped them according to the typical FGFR3 single gene defect, and this includes achondroplasia and thanatophoric dwarfism, that whole group. So thanatophoric, achondroplasia, then we have the collagenopathies, which lead to hypomineralization, so we group them together, and this is osteogenesis imperfecta, hypophosphatasia, and achondrogenesis. We have the ciliopathies, which usually are associated with small bones, but extra skeletal abnormalities. So you can have renal, cardiac. So this is short rib polydactyly syndrome with kidney, asphyxiating thoracic dysplasia also with kidney abnormalities, Ellis-von Creveld with cardiac deformities. So easy to remember: ciliopathies, extra skeletal abnormalities; collagenopathies, hypomineralization; FGFR3 is classical achondroplasia. And then we have miscellaneous miscellaneous genetic defects. So we have chondrodysplasia punctata, typical feature being stippled epiphyses. You see calcification in the epiphyses. You have campomelic dysplasia, where you have the most severe bowing of the bones that you see, marked bowing with sex reversal. So interesting groups that have formed with molecular diagnosis. The best time to see the skeletal system is the first trimester at about 11-12 weeks, because you can see all the three segments of the extremities, and it's probably the best time to see the skeletal system. Then, of course, at 20 weeks, this is the entire algorithm that you have to follow. You have to see all the long bones, which we normally do. We measure the length, we look at the morphology, whether it is bent, it is straight. We look at mineralization, whether we see the near cortex or the far cortex. Usually we see only one cortex, and if you see both, then there is more penetration, so it's hypomineralized. And of course, you can compress the skull. We look at the thorax. Normally the ribs go 2/3 the length of the thorax. So if it goes shorter than that, we know it is a short rib. And we look at the shape, and we'll see some cases. So we see the shape and the mineralization again in the fetal head. If you see the near field very clearly, then it is a hypomineralized skull. We also look at dysmorphology of the face, cleft lip, micrognathia. As I told you, in some conditions, we can have extra skeletal abnormalities. We then look at the spine, and there are some skeletal dysplasias which will involve the spine, like spondyloepiphyseal dysplasias. So we can have hemivertebrae, we can have rib abnormalities, absence of the clavicle or absence of the scapula. We finally look at the hands and feet, because you could have talipes in some abnormalities, and contractures or deletion defects, and movements. Akinesia is a part of lethal skeletal dysplasia. Most of the time the fetus will hold the hands like this because the arm is short or the feet is short. It will not flex or extend, it will hold it like this because of the short length of the condition. And then we need to look at extracardiac, so renal, cardiac, genital abnormalities. And almost always polyhydramnios is an association of skeletal dysplasia. So in a broad group, when you're dealing with a short femur and polyhydramnios, as I told you yesterday, we need to rule out a genetic abnormality like a skeletal dysplasia vis-a-vis fetal growth restriction, which usually has oligohydramnios. Then with 3D, we can do a skeletal mode reconstruction, where we can look at the sutures of the skull. For example, in some craniosynostosis, the sutures are fused, so it's very important. And also we can see the bones much better with this kind of imaging. Now when we do a 3D, we cut at one edge, and just like you're seeing the moon on sagittal, you can see the moon on the surface, so you can see craters on the moon, and therefore you can see the entire volume of the bone, so not only one edge of the bone, but you will see the entire. Makes it easy to see fractures in osteogenesis imperfecta. So that's the technique. We take a whole sagittal sweep along the bone, that's the green cutting line, and you will get the surface rendering in the minimum mode of the bones. And this can be useful for looking at the spine, and in the regular minimum mode, and this is the sill-out mode, so you can count the number of ribs, etc. Now, the presentation is two types. Most of us, it can be a family history, and this is coming more and more because people who are autosomal recessive got married, their first child got affected, and they probably terminated, or they have that child, then they come in the next pregnancy at 12 weeks. The phenotype is known. We do genetic testing, immediately come to a conclusion, and we will never see the full-blown phenotype of that fetus if it is an affected fetus, because you will terminate that fetus. The other group comes incidentally, no previous abnormality or family history, so this is an incidental mutation. The phenotype is unknown, and that's really what gets us scratching our heads to find out what abnormality it is. We then go algorithmically to look at the age of onset. So earlier the onset, more lethal is the dysplasia. If you have picked it up in the first trimester, almost certainly it would be either thanatophoric osteogenesis or achondrogenesis. We then, in the second trimester, it would present as a short femur. Lethality should be predicted with 100% accuracy. We then describe the morphology of the bones, try to come to a specific diagnosis. With ultrasound, it is possible only in 60% of the cases. Molecular diagnosis is possible in 80 to 90% of the cases. So these are first trimester images of normal fetuses. You can see that we can see the three segments very well. We have reference ranges. Normally, usually about 10 to 11 millimeters is the size of the femur at about 12 to 13 weeks. So roughly speaking, and if you have a shorter bone, an abnormal NT, because many of them are associated with nuchal edema due to the presence of small thorax, it constricts the venous return, and this, you have an ever-expanding list of skeletal dysplasias which can be picked up in the first trimester with the combination of nuchal edema and short, long bones, and of course molecular diagnosis. So here you have a fetus with a slight, with nuchal edema, but the most striking feature is the forehead. You see it's a markedly protuberant forehead with a bridge depression, and that is typical of thanatophoric dwarfism, large head, achondroplasia also, but it's too early, it's first trimester. The bone is very small. You see, it's hardly a dot. That's the humerus out there, which is very, very small, and rest of the bones are also small. And if you do a 3D, you can see that the fetal head is definitely showing a prominent forehead with a bridge depression. But the giveaway is in the coronal view of the thorax. You can see it's a very small thorax. The ribs are almost horizontally placed, and even in the sagittal view, you can see the ribs are short and very, very horizontally placed rather than obliquely placed. And this is first trimester thanatophoric dwarfism. Sometimes they can be associated with other abnormalities. Here, this fetus had an encephalocele along with thanatophoric dwarfism. And every time you find some unusual findings, put it on the net, and you will come up with some unusual associations. So this is lethal occipital encephalocele with skeletal dysplasia syndrome, and even thanatophoric dysplasia type 2 has been described with encephalocele, and so this fitted with this kind of situation. Achondrogenesis is today a first trimester diagnosis because it's a lethal dysplasia. You will have the most severe long bone shortening. There is severe hypomineralization and non-ossification, and the combined entity of the vertebral bodies and the skull being non-ossified is diagnostic. You may have hydrops and polyhydramnios, and this is a typical case in the first trimester. You see the cranium is not ossified, the spine is not ossified. But look at the limbs. As I told you, see the limbs. They are very short. The limbs are short here. You can see here. There's nuchal edema also. And look at the orientation. It's like this. Normal limbs the baby will hold either like this, or will do up, or will keep it on the side. They will do all sorts of movements. But here you can see it's a fixed orientation. Very short, non-ossified. And you can see some clips also if they work. I don't know whether they'll work. Yeah, they're working. So you can see the bones are so short and they are held at right angle. This is very typical of a first trimester appearance of lethal skeletal dysplasia. Diagnosis is of course molecular. We did the diagnosis, it was achondrogenesis type 1A. Then we tested both the parents, and to their utter dismay and surprise, both of them are autosomal recessive carriers, which they didn't know. So it's a good reason to do a genetic kundli before you get married nowadays, so at least you know if there is a genetic defect in either parent. So in the next pregnancy, we'll have to do a CVS and see whether they are having this. But usually the phenotype will be manifest. Now in this fetus with again severe short long bones and micrognathia, you have this typical appearance of the abducted thumb. It's the hitchhiker thumb, and that is classical of a condition called dystrophic dysplasia. Most of the time, skeletal dysplasias is like doing ovarian scans. It's morphological pattern recognition. Many conditions will have different patterns, and you recognize these patterns. So here you have a fetus with severe bowing, small long bones, talipes, and the classical abducted thumb. You can see the thumb is abducted and the ribs are short. It's a lethal dysplasia. Again, look at the hand. But the giveaway was this image. So this is a dystrophic dysplasia. So, and this is another condition which we see very commonly in the first trimester. It's radial clubbing of the hands due to absence of the radius. Many of them are associated with a single umbilical artery, and the differential diagnosis is trisomy 18, Fanconi's anemia, the thrombocytopenia, absent radius syndrome, and the Holt-Oram syndrome. So these are all, this was a trisomy 18 because it had an omphalocele, nuchal edema, and single umbilical artery, and the entire combination more fits with trisomy 18. Then you move to second trimester, so many lethal dysplasias will be detected today, as you saw. And in the second trimester, we do the traditional morphology scan where we look for long bone shortening, we look for bowing or fractures, poor mineralization, small thorax, malformation of the spine, closure of the sutures, fontanelles, and facial dysmorphology. So whenever we have a small femur, we always rule out a constitutionally small fetus. You look at the mother, look at the baby. First trimester screening rules out a majority of the common aneuploidies, because of nuchal edema, but single gene defects may be missed. Of course, as I told you, we need to differentiate fetal growth restriction. They're usually associated with a small abdominal circumference. Oligohydramnios, skeletal dysplasias will have polyhydramnios, and Doppler will be abnormal. And the more severe the long bone shortening, the more likely that this is a skeletal dysplasia rather than all these conditions. And this is a good, useful classification algorithm provided by ISWAG. It shows that if you have a small femur and it is early onset, that is before 24 weeks, then it could, if it is bilateral and severe, it could be achondrogenesis. But we saw many conditions in the first trimester. We saw thanatophoric, we saw the diastrophic dysplasia, of course achondrogenesis. And if it is unilateral, of course it is focal femoral hypoplasia, and we'll talk about that. Going beyond the first trimester into the second trimester, if there's abnormal bone modeling, and if you have bowing and fractures, then we think of all the collagenopathies, the osteogenesis imperfecta, achondrogenesis, and thanatophoric duodenum, where we have the classical telephone receiver type of femur. If they are hypomineralized, it's the osteogenesis imperfecta and hypophosphatasia, the collagenopathies. If there's polydactyly, I told you earlier, it will be a ciliopathy, so short rib polydactyly syndrome. And if you have microcephaly, this is the chondrodysplasia punctata. But here we have the lead point of stippled epiphyses. So the moment we see stippled epiphyses, and then we look for microcephaly and we know the diagnosis. Of course, if it's a late onset, the important thing is achondroplasia. And again, if we have polydactyly, all the SRP syndromes, the short rib polydactyly syndromes, Ellis-von-Creveld-Juins dystrophy. But what we are really worried about is the achondroplasia. Now, so that is the algorithmic approach, but the first step is always, is it lethal or non-lethal? And most of the severe conditions, as you can see here, thanatophoric, osteogenesis, achondrogenesis, the three big groups are all can be lethal dysplasias depending on the mutation. And the non-lethal is, of course, the achondroplasia, which presents late in the second trimester. Of course, you have other conditions like spondyloepiphyseal, etc. So we just do broad grouping. We don't try and remember the non-lethal as much as the lethal ones. And then we come to a conclusion by essentially looking at the thorax. Now you can see the rib is very sharp. It's like a very compact thorax. We can immediately see it. And if we relate the thoracic circumference to the abdomen circumference, if it is less than 60% of the abdomen circumference, we know on a sagittal view, you can see that the thorax is appearing very small even with eyeballing. And then we know we are dealing with a lethal skeletal dysplasias. Of course, there are charts available of measuring the thoracic circumference according to gestational age. But what is most commonly seen is that the rib is not going beyond the center part. And you see some fractures also in the rib. You will see bowing in the ribs. We then look at the long bones itself and look at the degree of limb shortening and the pattern of limb shortening. Now, in a lethal dysplasia, again, I'm repeating, we always see the arms like this, but the long bones are very short. Whereas in a mild to moderate severe skeletal dysplasias, the limbs are more normally oriented to the trunk. So these are the severe affected, again, led by the three common thanatophoric, osteogenesis, and achondrogenesis, and that's the typical appearance. And the mild to moderate are all the other conditions which may have a little more normally looking limb bone. So when we have to classify the limb affection of the which segment of the limb, I usually remember it as RMA. Rhizomelia is proximal, mesomelia is middle, and A is distal acromelia. And if all three segments are involved, it's usually called as micromelia. You can classify different abnormalities according to this, but it's very complicated to remember. So we keep this chart and we really don't try, but if it is severe micromelia where all the three segments are involved, essentially again the three top conditions, thanatophoric, osteogenesis imperfecta, and achondrogenesis. A little words on the common dysplasias. You can see thanatophoric type 1 has severe micromelia. Very typically, it used to be called the telephone receiver, the old telephone receiver. It is an FGFR3 mutation. You can have a platyspondyly, that is the flat vertebrae. Macrocephaly is seen, the head is large. And that's the typical pattern. There is a fracture here, there's bowing, there's small ribs which are extremely crinkled, and that's a typical appearance. You can see the bowing which is marked here, also here, different patterns, and on the 3D surface rendering you can see the fingers are of equal length, short, stubby, and the varied severity of involvement of the femur in different patients, and that's the typical telephone receiver appearance here. The 3D coronal view, as I said, very important because you see the large head, and immediate orientation at right angles of the long bones is very typical. The sagittal view shows the extreme small thorax, indicating the lethality, and the rib is not going beyond the middle half on the sagittal view of the ribs. So these are some of the important views that we always document. The ribs are more horizontally placed rather than obliquely placed. Now, an interesting finding is the intracranial dysplasia of the brain that we can see in the first trimester, even at 14 weeks. So you see this is a small, it's a 13-week, 4-day fetus with short, long bones. But what you see transvaginally is polymicrogyria in the temporal region. Can you appreciate that here? This clip is not working, but oops. Yeah, you can see it here now. So that's the polymicrogyria. So immediately move to the head, look into the brain, and even at 13 weeks you can see this increased convolution of the temporal area, and this is classical of thanatophoric dwarfism in the first trimester. The second type of thanatophoric may not have the typical telephone receiver bone, but it will have this clover leaf deformity of the skull like this triradiate due to premature craniosynostosis. Going on to the collagenopathies, that is the hypomineralization disorders, the leading one in the group is the osteogenesis, where you see once you compress, you can actually compress the fetal skull bone. The near field is seen very well, and that is typical. You have a nasal bridge depression and of course short long bones, and then you may see fractures here, both of the ribs, and there are different types of mutations, but the type 2 is the most common perinatal lethal form that you will see. This is typical platyspondyly. You see very flat vertebrae and the typical rib fractures, bowing. And the sagittal view is very useful because you can actually see the beaded appearance of the ribs, which suggests that there are rib fractures. Now, in this interesting fetus, there was only one bone which was affected, that was the femur, but it presented with a complete fracture antenatally. You can see that here. And the other femur was normal. You can see here this femur showed a fracture, and this was osteogenesis. It was a mild variety, but you can see that the fracture was the giveaway. Of course, the long bones were short. The diagnosis is today again molecular, and that concludes the diagnosis. Achondrogenesis I already spoke about, but hypophosphatasia it can also be various types. It can be different inheritance patterns. There are 6 subtypes, and you can see here a very funny appearance of the bone. You can see all like a double barrel appearance of the bone. So you have the near cortex, and you can see the distal cortex also, some segments of the distal cortex suggesting that there is hypomineralization. And so it involves all the bones except the clavicles. Now here it was an early 14 or 15-week fetus. You can see that the near field is seen very well here. But the giveaway was the spine. Look at the spine, look at the vertebrae. They are very hypomineralized, and you can see that the vertebral bodies are not well ossified, and this pointed us to the diagnosis of a hypomineralized skeletal dysplasia, and this was hypophosphatasia. So look at the vertebrae, very platyspondylene, almost thin, very, very line-like appearance of the vertebrae. It's not the typical solid appearance that you see, and you can see that in the clip here, like a rubbed out spine. The vertebrae are not well seen, and this is typical of hypophosphatasia. At the other extreme, we have over-mineralization of the bone, and this is here, you can see a short, long bone with callus formation. There is fracture and callus formation here seen with intracranial calcification. The diagnosis was, of course, molecular. You can see the face completely dysmorphic, and that is the advantage of seeing the face here. It is a wide philtrum, upturned nose, and extremely dysmorphic face with hyperostosis, with fractures, with short, long bones, and that's the Rain syndrome, or mutation in the FAM20C. Now here, actually speaking, we saw short, long bone and facial dysmorphology, and then we went backwards and got a diagnosis with the molecular diagnosis. So that's a rare condition. Now this is the other condition where you have extra ossification, which I spoke about earlier, and is the stippled epiphysis in chondrodysplasia punctata. Here again you will see both in the earlier days we used to take X-rays, and you can see extra ossification in the epiphysis, and the typical appearance is the nasal bridge depression or the Binder's facies with microcephaly, and that is typical of chondrodysplasia. And suddenly, I don't know, of late, we are seeing a lot of fetuses with Binder's facies. In fact, last month I saw 4 of them, and many of times we don't come to a conclusive diagnosis. There's no genetic abnormality, there's no autoimmune condition, no antibodies, no warfarin, and here we do see a premature ossification of the talocalcular bone here at 19 weeks. Usually it ossifies around 21 weeks, pointing to the diagnosis of a chondrodysplasia punctata. There were no other epiphyses which was stippled, so we did a molecular diagnosis, and it was a mosaic pattern of CDP. So very mild variety of CDP, and maybe you could continue the pregnancy. So the fetal face acts as a good descriptor. You can see that's the typical Binder's facies. This is osteogenesis imperfecta with nasal bridge depression. This is frontal bossing that we see with achondroplasia. And of course, micrognathia is associated with a lot of syndromes, the Treacher-Collin, golden hour, trisomy 18, and this can be associated with skeletal abnormalities. Now, this is a typical condition of severe micrognathia with cleft lip, cleft palate, and that's the Pierre-Robin sequence. And you can see the normal, I don't know why some clips are not playing. Okay, I will show this in my next talk. This is important to see. This tongue, instead of reaching the lower jaw, is falling back, and it's macroglossia, indicating that it is a Pierre-Robin sequence. I don't know what has happened. Can anybody help? Huh? Go outside full screen. Escape, come back. Not working. Escape now goes back to. Okay, we'll leave it for now. I have another talk on. I'll try and so Pierre-Robin sequence. Again, we found both the parents were carriers, autosomal recessive, and this is Treacher-Collins. So you can see micrognathia with ear abnormalities. So it can be a big heterogeneous group, and of course diagnosis is on molecular diagnosis. Now I'm going to skip a few slides because I've shown these in part of the other, so there's hypoplastic thorax, which is part of ciliopathies, so you will have renal abnormalities. Polydactyly is a typical feature of short rib dysplasias. The thorax is very small, it's called like a bell kind of thorax. And we have different conditions, the type 1, type 2, type 3, and most of them are, can have polydactyly, may or may not have, but they may have renal or cardiac abnormalities, and that is typical of Ellis von Cribald. So the moment you have skeletal dysplasia, polydactyly, cardiac, etc., renal, it's the ciliopathy, and again can be seen in the first trimester. Campomelic, I told you, is the sex reversal syndrome where you will see ambiguous genitalia with marked bowing and talipes. That's a typical feature of campomelic dysplasias. And of course, you have spinal abnormalities. You can have a missing scapula, which is a hallmark of campomelic dysplasias. So these are again patterns. Fetal spine, platyspondyly, typical of osteogenesis. And hypophosphatasia, already showed you this earlier, so I will skip it. Whenever you have scoliosis with segmentation defects, that's part of the spondyloepiphyseal dysplasias. You can see severe crab-like appearance of the spine with severe kyphoscoliosis, fusion of the ribs, and this can again be seen in the first trimester. So these are the Charcot-Levin syndromes and other type 2, type 3 type of syndromes. Coming finally to the most dreaded condition is the achondroplasia, because it's a late manifestation, it's not a lethal dysplasia, and we need to differentiate it from a small femur of IUGR, and that the typical appearance of this condition can be sorted with this one diagnostic feature, and that is the alteration of the proximal diaphyseal metaphyseal angle. So the moment you take a femur, you have to got a small femur, you immediately measure this angle of the proximal metaphysis and the diaphysis, and if this is wide, then you know you're dealing with achondroplasia. So that's the typical appearance. You see how wide it is. Normally it's about right angle to 110 degrees. Then you see there is frontal bossing here. And again, the angle is 141, suggesting achondroplasia. Here again, both the parents one parent was autosomal dominant but not affected. So this is a mutation in this condition. You have platyspondyly again here, and the trident hand where the fingers are held in 3 groups, and all the fingers are of similar length. You can see that is typical of achondroplasia. And again, the frontal bossing, this is the baby delivered. So this condition is syndromic condition of IUGR, which I showed yesterday, the 3M syndrome, so I will skip this, and the Noonan syndrome also, which is also a syndromic condition. Finally, moving to craniosynostosis syndromes, where you have premature ossification, and this results in alteration of the skull shape. And since Praveen is ringing the bell, I must wind up quickly. So here you can see the alteration of the skull shape. There is proptosis, the sutures are fused, and this is Crouzon's. This is Apert syndrome, where you have hand abnormalities associated with craniosynostosis. So this is craniosynostosis. You can see the futures are fused, and typical mitten hands of Apert syndrome. So the combination of different skeletal systems being affected gives the diagnosis. This is polydactyly, trisomy 13, and then finally, I will skip this. This is dystrophic dysplasia, already shown. Forearm abnormalities, I already showed. The Fanconi's and radial clubbing. This is Treacher-Collins with again radial clubbing and facial abnormalities. This can be a first trimester diagnosis. So here you have abnormal ears, typical radial clubbing, and micrognathia, all seen in the first trimester. So this is Treacher-Collins in the first trimester. Talipus and other skeletal foot abnormalities can be a part of various syndromes or can be isolated. Here, this is the calcanovalgus foot, which is one foot is normal and the other foot is dorsiflexed, and you can see the extreme atrophy of the muscles, indicating that this is going to be a poor prognosis because there's muscle atrophy. Small foot, a marker of the harlequin fetus. So here this was a twin pregnancy with one foot being small of one fetus, the other foot of the other fetus being normal, and this was because of contractures, skin contractures, so that is a harlequin fetus. And then you can have isolated bones being small. So here you have the fibula that is small, resulting in this plantar flexion abnormality. You can see on 3D the limb length discrepancy between the two limbs. One limb is small, and this is the femular hebemelia syndrome. Or you can have proximal focal femoral deficiency with, again, one femur being small and the absence of the femoral head. This is the classical arthrogryposis, typical moon shape, so with limb lack of movements. And then we have the reduction defects, which can again be picked up in the first trimester. This is the first trimester fetus with all the 4 limbs having amputation of all the distal segments. This was another fetus with only one limb, so mono kind of appearance, and the rest of the limbs were all reduced. You can have individual digits missing. So a lot of possibilities with amniotic rupture sequence. You may not see the amniotic bands. Here what you are seeing is constriction defects. You see the foot is showing a swelling. These echogenic areas are actually the amniotic bands where they are attached, and you can see the postmortem appearance. There's constriction, amputation at multiple sites in the same fetus. Now, and finally, to conclude with this very interesting situation, this fetus had the foot on the face persistently, and we could see on color Doppler this umbilical cord was situated close to this limb, and the fetus had tied a knot on this leg, constricted the blood supply of the leg. You can see how beautifully the knot was tied, and therefore this foot was paralyzed. So in conclusion, molecular testing should be offered to all the fetuses with any skeletal dysplasia, because today we have all the gene panels that are possible, FGFR3, the collagen group, etc., which can make us come to a conclusive diagnosis. We used to do X-rays in the past, but it's probably yet recommended, but you can also do a CT postmortem. These are different appearances of different skeletal dysplasias, but the appearance is very similar to what we showed on ultrasound. And important to say that at 11 to 13 weeks, examination of the limbs is mandatory. Don't forget to examine the limbs. Lethal anomalies can be picked up in the first trimester. There can be a lot of phenotypic variability which can guide the prognosis, but the final diagnosis is always monocular. Every anomaly is rare, so you must save all the material that you get to come to a conclusion and increase the pool of data that we had. So store the DNA, take an X-ray, etc. There are a lot of resources available, and again, thank you for a very patient hearing.
Check. ये क्या आ गया? Huh? Listen, what is this? So after this fantastic talk by Dr. Chandra on skeletal dysplasia, I only want to add, sometimes there are artificially created, like one limb deformity. In my case, I broke my shoe. So obviously one limb is shorter, we have to, but thanks a lot. And I would like to thank you all again for being here and having a very, very successful, another of our outreach programs. Thank you to all of you for being here. So I'm going to be talking on, is 3D necessary for infertility? And I'm going to give you this thing, clinical changes, and I would, by the end of it, I hope I can convince you that 3D is the most important part when we are dealing with in gynecological ultrasound, along with clinical history. So 3D and 4D along with AI in ultrasound is a non-invasive state-of-the-art imaging for infertility, subfertility, recurrent pregnancy losses and implantation failure. And we can use it in all Mullerian anomalies, whether it's a polyp, submucous fibroid, synechia, and then in ovulation monitoring, looking at the ovarian cyst, the inner lining, and the hydrosalpinx. Everywhere 3D plays a good role. Now, what is 3D ultrasound? It's nothing but it gives you more information on as what we can get on a 2D. Now here I have these three images, and we can see that the endometrial cavity, a gestational sac which is eccentric in position, and here there's a fibroid which is growing into the endometrium. How much it is growing, I can't answer. And here this was endometriosis and an endometrial cavity which looks non-homogeneous. We do a 3D and here we have an answer. This is a corneal pregnancy. Here we have a submucous fibroid which is completely growing into the endometrial cavity, and here it was a unicornuate uterus. So it improves the efficacy and management of the gynecological clinical scenarios. So on 2D, what we get is objective information on a sagittal and a transverse view, where we get a single cut section of the anatomy. But when we do a 3D, it's this coronal plane which gets reconstituted by the equipment itself and gives you the maximum answers. We can render this image where we get a complete normal looking uterus, normal convex fundal contour, flat anterior margin, triangular endometrial cavity, and also we can get the interstitial segments of the fallopian tubes are beautifully visualized. The quality of 3D depends on our 2D image. If our 2D image is good, we will get good 3D image. And if there is motion artifact when we are taking a 3D sweep, we can get something which really, really looks abnormal. So make sure that we try and do it again and retake it. OmniView is very useful. We trace this and we have a simultaneous visualization in the coronal plane. And 3D TUI is nothing but like a CT where it gives you the entire extent of the lesion. So timing is the other thing which I always like to talk about. If we do it early, we may miss the anomalies, especially this thing in Mullerian anomalies. Here it was done on 7th day and we were not sure what's happening. Call back the patient on 17th day and here it was very classically clear it's a bicorporal septate uterus. Now if we do for polyps, if they referred when there's a thick echogenic endometrium, we may completely miss it. Here we do see a thin sonolucent rim, but we can miss it. As compared to when we have a trilaminar endometrium in the pre-ovulatory phase or in the estrogenic phase, and even a small polyp like 4 millimeters can be picked up. Now, it plays a very important role in these group of patients with infertility, recurrent pregnancy losses and implantation failure, and these can be the congenital or acquired. And in congenital anomalies, what went wrong, we went through this yesterday, so I don't think I need to talk about this today. But clinically, let's say if a patient is sent to us for routine evaluation for preconception, and we may see nothing but a normal looking uterus, which I've just talked how we look at it, or we may have a persistent anterior impression on the endometrial cavity but a normal fundal contour, and this may be an arcuate variety if we are using ASRM classification, and we can add the recommendation by CUME using indentation depth, indentation angle, and the uterine wall thickness. And according to Esri, all these are considered to be normal. The other group, which may completely be asymptomatic and may be picked up on a routine evaluation of our infertility, is a T-shaped uterus. And here we know that there is narrowing of the endometrial cavity, which is because of the lateral wall thickening, and the uterine to cervical ratio remains 2:3 to 1/3. And here this patient had an adenomyosis, which was narrowing the cavity, and also had a fibroid, which was type 3, indenting the endometrium. Now, when we can use the objective criteria, which I talked about it yesterday, just a repetition, we draw this line from the cornua to the internal os, we measure this thickness, lateral indentation thickness, we measure the angle, and we can measure the T angle, which gives us the specific, we can be sure whether we are dealing with T-shape or are we dealing with borderline this thing or normal. Now, the other group of patients who when they come to us with the history of consecutive pregnancy losses. This patient was young, she had 2 pregnancy losses, and she was sent for a routine evaluation, and we know that when we do on a transverse view, we could see that 2 endometrial cavities, a vascular septum, and this patient had a complete septate uterus. She had an ovarian cyst, hemorrhagic cyst, and she had a polycystic ovary. Now, this was another patient who was persistently bleeding, and she came up with a large fluid collection on one side, which was little on the side here, and the embryo was doing very well for the amount of large bleeding, and also she was pouring. And this, I didn't realize we had done her earlier, and she reminded me, and the earlier pregnancy, we could see that it was a partial septate uterus with a sac on one left side and a right side showing a decidual reaction. Now, septate uterus, we talked about it yesterday. It is nothing but there's a tissue indentation which divides the endometrial cavity into 2, and when it's partial, it ends above the level of internal os. It may go all the way into the cervical os to give a complete septate. Septate uterus do not prevent conception, but they are associated with the adverse reproductive outcome. This is one such example. Now, this patient had 2 MTPs. She had an MTP, missed abortion. She had it done twice, and she was still bleeding. And the reason was that this was not done, 3D wasn't done. So what was happening was they were probably just going onto the left side without realizing that she had a partial septate with lot of retained tissue on the right side. And this was a cornual pregnancy. They can get smaller the cavity, the poorer the reproductive outcome, and then they can be persistent bleeding during menstrual cycle or persistent pain actually. And this was fluid collection in the cervix. Now, the other group of patient presenting could be routine evaluation with history of spontaneous midterm abortion at 18 weeks. So the first thought which comes to us is when we see this is cervical incompetence in patients who have an bicornuate or a bicorporal type of uterus. And once we see this in the subsequent pregnancies, we have to start following them up at 12 weeks of pregnancy to assess the cervix. And we know that these bicorporal, bicornuate uterus, to diagnose them, they have to have an abnormal fundal contour, they have to have an abnormal indentation, they may have a single cavity, the fundal contour may be dipping down or maybe just below the level of the endometrial cavities, and in a partial septate where there is a septum which is more than 150% of the uterine wall thickness. I'm sorry, I'm rushing this up because we went through it yesterday in detail. The other people who can present with is persistent bleeding, and this was one such patient who had this OHVR syndrome, and she had uterine diadelphys, obstructed hemivagina, and the unilateral hematocolpus. These are associated with ipsilateral renal agenesis and Gartner's duct cyst. Another patient persistently bleeding, I mean, she used to come every 3 to 4 months, and they had to evacuate the endometrial cavity because she had an imperforate hymen and she had hematometra. Now, another group of patients, primary infertility, failure to conceive because of azoospermia, and she was for embryo transfer, but no one had done a scan before. She was sent for endometrial receptivity. We can see excellent vascularity, but this was a unicornuate uterus, but she did conceive after that same cycle. They did an embryo transfer, and she did conceive that cycle. And we know this is the only uterine cavity which cannot be picked up on a routine 2D. We need to have a 3D image to show us that it's a single endometrial cavity, single interstitial segment of the fallopian tubes. They may have an absent contralateral horn, they may have a rudimentary horn which may be communicating, or they may have a non-communicating horn. That's when we look for the functional cavity versus non-functional endometrial cavity. Because those which have a functional cavity may have a increased incidence of an ectopic pregnancy. Now this was another patient who was severe pain. She came to us. She had a unicornuate uterus, but she had a large collection just posterior to the bladder. And she was taken for surgery immediately. The question was, are we dealing with a uterine didelphys with a hematometra on the second horn or a hydrosalpinx? And this was a hydrosalpinx. Now, people presenting with primary amenorrhea, the first thing we should think about is uterine aplasia or an absent uterus. This is in this particular MRKH syndrome, who have normal ovaries and their karyotype is normal. This is actually a very rare case, which in literature also reports it less. This patient had a proved MRKH syndrome when she was 14 years. She came at 27, 28 years of age with this large mass in the pelvis. And this looks like a fibroid. We did a 3D, I mean, it looks like fibroid, but she refused to get anything done. She was advised surgery, but she refused. She said, no, I have this syndrome, and this is a fibroid. And I looked into the literature. There were very few cases which have been reported with this syndrome having fibroid. Then the other place, amenorrhea, could be because of this hypoplastic uterus, where there is uterine corpus to cervical ratio is reversed, and they can present with either hypomenorrhea or basically primary amenorrheas. Then there are patients who present with pelvic pain. Now this lady had a unicornuate uterus, endometriosis and a hemorrhagic cyst. So her reason for pain was this. Another one with endometriosis and a T-shaped uterus, and then ACUM, where we have a normal looking cavity and there's a solid focus or cystic component to it which looks like endometrial cavity or an endometriosis. And these patients have a normal uterus here, and this extra segment can have adenomyosis, which may be the reason of her pain. And we've already said the coronal images are excellent for diagnosing these lesions because we have the fundal and the endometrial distortion visualized simultaneously. VCI-C plane is very good, where we can trace the region of interest and it outlines the deformity, and this easier and improves the contrast resolution. And on 3D, again, it's with these indentation lines, interosteal lines, indentation depth, indentation angle, the external fundal cleft and the uterine wall thickness are much easier to calculate as compared to a 2D. So also looking at the fundal contour, 3D is very useful, whether it's fit below the endometrial cavities or the distance between this, if it's more than 5 millimeters as compared to this, which is less than 5 millimeters, and here it's dipping below the endometrial cavity. So this is an abnormal external fundal contour. And then we can just classify them according to the classifications which are available. The other required circumstructural defects which can give secondary infertility and also abnormal uterine bleed are these intracavitary lesions, which may be endometrial polyps or submucous fibroids and adenomyosis. Now here, endometrial lesions, these are polyps. We can see them as echogenic masses which are within the endometrial cavity as compared to a submucous fibroid or the lesions which are rising from the myometrium. They actually grow into the endometrial cavity, and 3D gives us a better delineation where we can see that the fibroid is completely growing into the endometrial cavity and distorting the cavity. Then in polyps, we are looking for the location, size, morphology, number, myometrial endometrial interface, which is one of the most important things which we need to see, and 3D is good for that. And because here these are the group of people in infertility, they are in the 40 plus age group, they may be going for IVFs, and we need to know that these polyps they are dealing with have a malignant suspicion or not, and this was one such patient where we can see, if we look at this myometrial endometrial interface, it's normal, and here we can see that it's a abnormal contour, and this turned out to be a malignant polyp. Obviously, if there's fluid in the endometrial cavities, polyps are much easier to pick up. Then also 3D plays a very important role when we are trying to do fibroid mapping. We can identify them, we can look according to the location in relation to the endometrium. They may be intramural, they may be submucous, they may be subserous when they're bulging completely outside. when it's related to the uterine serosa. And then we can also obviously look at the ultrasound features and the size, and we can classify them according to FIGO system or Lasmer's or the step W classification. I'm not gonna, it's not that you can't do it on a 2D. You can always do a 2D. This is just a 2D image where I marked all these areas where the fibroids can be, but it's much easier on a 3D. You have one plane which you get, and here's one such patient. We can see that this fibroid is growing into the endometrial cavity, and this is at least 50% is growing into the endometrial cavity. This is a hybrid fibroid which shows a mass effect on the serosa as well as onto the endometrial cavity. Intramural, no mass effect, and no mass, and this is the type 3 which is in contact with it. So it's much easier, that's all. It's not that we can't do it on 2D. And then also the other helpful thing is that we have used FIGO classification to classify the submucous fibroids, which how much of the mass is growing into the cavity versus how much is the mass in the myometrium. So those which are completely growing into it, or with the 50% involvement of the endometrium, and those which have less than 50% intracavitary. And the importance is because these are the patients where hysteroscopy, the management varies, whether they want to do hysteroscopy or they want to do reduce the size of the fibroid and then do a laparoscopy. And this is again just type 3 which is in contact, and type 4 which are completely in the muscle layer, and those which are hybrid, and there's the ones which are completely jutting out, which may be more than 50% outside the uterine cavity. And Lasmer's classification and step W classification is actually a better indicator when they're trying the surgical management, because there's a scoring system. It's you give a score, and lower the score, the easier the low complexity, there's easier to do hysteroscopic myomectomy, but as the score increases, they have complex surgery, so they may prefer a 2-stage surgery before, and prepare them with GnRH analogs, which decreases the size. But I personally still prefer FIGO, but I think as a pre-surgical, we should start reporting, and we are reporting these for the surgeons to understand, give them a better impression. AI is another one which plays an important role in fibroid mapping. What it does is it standardizes and streamlines the fibroids, it documentation by the fibroid, it measures them and classifies them. And this is actually a very easy image for the OBGYNs to understand, okay, where are the fibroids located. We draw them, but now the equipment itself is giving us this in this particular patient who has a submucous fibroids. And this software actually delineates the fibroids. You can add them to the report and you get a complete report page which gives the format. Then there are patients who may present with pelvic pain, abnormal uterine bleed, infertility, or they may be completely asymptomatic, and we think in terms of adenomyosis. And the adenomyosis may be diffuse, which may be involving all the layers of the myometrium. It may be focal, which involves only a part of the myometrium, or it will maybe presenting as an adenomyoma, which is a rare form. Now 2D actually gives us these answers because without that we can't diagnose them. We look for these myometrial cysts, which is very classic for adenomyosis. We can see these hyperechoic islands. We see these linear echogenic striations radiating from the endometrium outside and a venation blind appearance. These are the direct features of adenomyosis, whereas the indirect features may be globular uterus. They have asymmetric myometrial thickening, but one of the most important thing is to put in color, because translesional vascularity is very classic for adenomyosis. And then a 3D. 3D plays a very important role because we have a better delineation of the junctional zone. This is a normal looking endometrial cavity, and here we can see there are these protrusions which are bulging out of the endometrium. Both these different patients have an irregular, ill-defined, a fuzzy looking endometrium. And here there's an interrupted endometrium, again protrusions we can see, and this is another patient with interrupted endometrium. They may be completely distorted, like in this patient who had both fibroids and adenomyosis. So it's much easier to present and diagnose them. Now clinical presentation could also be when there's failure to conceive or abnormal uterine bleed, and history is very important because we have to get a past history. Generally would be indicated as surgical intervention or DNC for missed abortions. And we know our answer is there before that we are looking for synechia, and these are characterized by formation of fibrous tissue in the endometrium. So these are endometrial defects, there's interrupted endometrial midline, and these are these fibrous defects which go all throughout into the endometrium. And severity is according to the area of endometrium which is involved, can vary anywhere from less than 30% to severe, which is more than 60%, and completely distorted cavity, secondary to extensive fibrosis. We can also quantify them actually. We can take the synechia and we can take the volume of the endometrial cavity and can get a quantitative assessment. Then another group of patients who can just present with amenorrhea of failure to conceive is when they have retained calcified fetal tissues. I don't see these anymore, but yes, earlier I did see them. These are old images too. Then ovarian evaluation in fertility plays a very important role, where actually 3D is this important because ovarian volumes are more accurate and less than 3 is poor response, and we use this vocal software which gives us more accuracy of the volumes. And there's an increased risk of hyperstimulation. We can look at them and see if they're polycystic, because polycystic ovaries are very visualized on a 3D. Color flow gives us increased stromal vascularity, which again detects is easier on a 3D power Doppler, and then we can measure the antral follicle count. And what happens here, we use this Sono AVC software program. It may be called in GE as this, but most of the equipments have it. We have a different name for it. So what it does, it facilitates the visualization of the antral follicles. It gives an automatic volume calculations. It gives a color coding. It identifies the follicle, gives a specific color, and improves the reproducibility. And then we can have these computer generated reports which actually tells you that these are the number of antral follicles which can be simulated, and they can give you the diameter and the volume, or they can also give you the number, whichever you people are comfortable or the OB/GYN is familiar with to assess this. It's easier to do follicle count, especially in stimulated ovaries, when the follicles are more than 10 to 15 millimeters. The counting is much better. The overlap of using the same follicle counting again is not there. So these again report pages help us. It reduces the time to count the follicles. It avoids double counting and volume-based diameter rather than the average of the 3 diameters. In an ovarian mass, actually 3D may not play a role, except when we do see cystic looking lesion. The lining looks essentially all right, but the same patient, we did a 3D and look at the irregular, which was an irregular lining, and she went for a biopsy first, and this turned out to be ovarian cystadenoma. Another example showing the irregular lining. The other place 3D is helpful is here we have a nice looking 2D image, but when we do a 3D, we find there's an echogenic focus, and put in color flow, there's color in it, so this means there's solid tissue. Fallopian tube evaluation, again, on just taking one plane of the thing, it tells us hydrosalpinx, the most important thing being that this cystic focus is separate from the ovary. And then we can have all the features of hydrosalpinx in just one plane, which is like convolutions folded on itself, C or S shaped, incomplete septa sign, the vase sign where the opposite indentation, but they do not meet each other. Incomplete septa is when there's a septum which goes on from one wall, does not meet the other wall, and 3D rendered image actually gives you a nice delineation of the dilated fallopian tubes. Then the other two signs for hydrosalpinx, beads on string appearance, which are these tiny intramural nodules, which are signs of chronic disease when the hydrosalpinx or the wall of the fallopian tube is thin, as compared to this cogwheel sign, which is seen in acute disease, which is thick, and these are nothing but thickened endosalpingeal folds, which are better picked up on a 3D image. Now, interstitial segments are very well visualized, and here we have some examples. Vertically oriented, interstitial segments commonly seen in tuberculosis, diffuse variable thickening of the interstitial segments, and here when we use the hycosi, which we saw yesterday, it can give you whether there's a block, and also gives you the delineation of the endometrial cavity, which is very poorly outlined here. So just to summarize, like I said, it's a non-invasive study for evaluating all these patients, and we can recognize, we can diagnose them, and our clinicians should be happy when we give them an answer for them to further work up. And this has actually revolutionized the management in women's health care. And I always like to add, if the radiologist frequently recommends additional imaging, it is unlikely that all the information from an ultrasound is being considered. And I'm not an MRI person. I feel we can give a lot of answers on the ultrasound before going to MR. It's more problematic if the patient comes to us, if the MR has already been, because I feel as an ultrasound person, we get biased. Okay, MR is more accurate. But I still prefer doing an ultrasound, and I think that gives you much better answers as compared to the. Thank you so much for your time.
Very good afternoon, and I think since morning you have been having a lot of knowledge being infused, and I think the effort that has been put in order to gather all of you, and you staying with us, and having a galaxy of people like Ramamurthy, Chandralulla, Sudhir Gokhale, Manju Virmani, and Shabnam Bakshi. I think Narayan Rao did a wonderful, wonderful job. I think his team needs a very large standing ovation. Please get up and give them a stand. And he and his family, because his daughters, his wife, and his president, everyone has done a great job. And we are very, very happy that we are together here. And that's all because of the whole Gusa team that has been responsible for it. We thank you very much. Okay, let us get back to business. So let us start off with the first trimester structural abnormalities. I think you have been taken through various aspects of the fetal abnormalities, particularly focusing on second trimester or mid-trimester scans. Now I'll take you through a little bit about the first trimester, what are all the things that we can do and why we should do all these things. Because we know whenever we do the first trimester scans, the most important focus is on dating the pregnancy, detection of multiple pregnancies, identifying the chorionicity, screening for aneuploidies, pre-eclampsia. But it is not just that it is enough, because whenever we try to evaluate or screen for aneuploidies, the basic concept is that we need to use certain ultrasound markers, which again are dependent on the gestational age. Now, with the introduction of NIPT, particularly at about 9 weeks of gestation, 10 weeks of gestation, which most of the obstetricians are nowadays asking for it, where is the role of a first trimester screening? You don't need to do a screening. Quite often, you have the answers with the NIPT. So, we will be jobless in short future. So, that is the reason why we need to do something more than that in order to be still in business. For that only, that is the reason why we need to try and assess the fetal structural abnormalities. In order to assess the fetal structural abnormalities, size does matter. It is always very important that you really can't focus or evaluate a 11-weeker it becomes much more comfortable to do a 12 weeks to 13 weeks fetal scan, where you can very thoroughly evaluate the fetal structural abnormalities. That is one aspect of it. The second aspect of it is the approach. How are we going to approach? Quite often, 90% of the cases, you can manage evaluating first trimester structural abnormalities transabdominally with wonderful transducers which we have now, which are high frequency transducers with a wide range. So that makes us life much more comfortable and much more useful in evaluating these small structures. And always, as I always keep saying, that you need to magnify and you need to take cine loops in order to get frame by evaluation of each of these structures. Now, another important thing is that we have to always keep in mind that there are almost about 2% of the cases which are associated with structural abnormalities, which are the most important factor that we need to keep in mind. Now, today my lecture will be how are we going to approach evaluating these first trimester structures, that is one. Second thing, it is always essential that we need to follow the guidelines or have a checklist so that we know that we are looking into every aspect of what we are supposed to look, so that we are not going to miss something and so that we are not going to create problems. That is two. Three, there is this concept of pre-NIPT scan is one thing which is extremely important, which now I think it is time that we get trained to evaluate these fetuses at about 10 weeks of gestation. I'll tell you why we need to do the pre-NIPT scan. Then what is the proposed plan in evaluating these structures of the first trimester fetus, and what are the anomalies that we should not miss while evaluating the first trimester structural abnormalities, and we need to try and improve our skills in order to evaluate certain structural abnormalities which may not be able to possibly diagnose, to push them into definitely to be diagnosed in first trimester. And I will leave you out with few key messages. Now, when the approach is come, the basic most important thing is we definitely need a good machine. See, previously when I was a student or when I started practicing, everyone used to say that the man behind the machine is extremely important. But now I don't believe it. I believe that the machine before the man is very important, because it's definitely the technology has improved so well that you have to make use of the technology to your advantage and get the best out of these machines. That is two. And it is essential that you need to develop your expertise. That is, your skills have to be honed, and you need to improve your skills in order to evaluate. That you can do by repeatedly practicing the same thing and trying to understand what exactly is the normal things that we can look at it. Then definitely you need to follow the protocols. And another important thing is that the concept of a myth that the color Doppler should not be used in the first trimester is out. Now its color Doppler is mandatory. You need to use color Doppler wherever it is required. So these are the things that are the four most important factors that you have to keep in mind while evaluating these first structural abnormalities. Now the protocols, these are all the list. I don't want to go through it. This is a busy this thing. I will take you through each one of them where we are going to. Oh. What happened to this? I'm stuck here. ఏం ప్రాబ్లం ఒక సెకండ్ అండి 2 సెకండ్లు బట్ వచ్చేటట్టు చూడండి. Fantastic. Thank you. So, I'll not go through this list because these are all big lists, which I'll take you through what we are supposed to look for. Now, initially, when we do the first trimester screening for aneuploiditis, these are the things that we are definitely going to look for. That is the nasal bone nuchal translucency, as well as the tricuspid flow across the tricuspid valve and the flow across the ductus venosus. And at the same time, we are also going to look for the posterior fossa abnormalities by seeing this. Then we have the preeclampsia evaluation, that is uterine artery Doppler. This is the basic concept that we have as far as the evaluation is concerned. Now, what is the proposed plan which I would like to follow, or when I would like you to advise to follow, is that first and foremost thing, first trimester, as it is dating, definitely you need to date the pregnancy, because it's extremely important. That is one of the most important factors which will help you not only in first trimester screening, but it also helps you in dating the pregnancy, wherein the progress or the growth pattern of the fetus can be evaluated, or the growth potential can be assigned. The second most important thing is to identify the multiplicity of the pregnancy. And once you have identified the multiplicity of the pregnancy, this is the ideal time where you can assign the chorionicity. So these are the two things that you definitely have to establish before you progress into evaluating the structural abnormalities. Now, you methodically can go right from the fetal head down, as you always do whenever you do a second trimester anomaly scan. Similarly, you can follow the same protocol, wherein you can start off with the transventricular scan of the fetal thalamus, of your fetal brain, wherein you can see the interhemispheric fissure, you can see the choroid plexus filling the whole of the lateral ventricles. This all put together gives you what is called as the butterfly sign. So whenever there is an interruption of the interhemispheric fissure and you find that there is a single ventricle, you know that you are dealing with a monoventricle, which could be because of a cleavage abnormality. Now, regarding this ventral induction defect, Ramurthy will be taking us in detail. Second section is what is called as a thalamopedunculaar section, wherein you can see the slit-like structure, which is actually the aqueduct. Quite often, it is not possible for us to see the aqueduct in the second trimester unless you do a sagittal section and that to look for it. But in the first trimester, the advantage is that you can clearly see the aqueduct. Not only you can see the aqueduct very clearly, you can also assess the distance between the posterior aspect of the aqueduct to the occipital bone, which will indirectly tell you that there is any Arnold-Chiari-2 malformation, which is basically when we have an open neural tube defect where there is a CSF leak results in traction of the cord. So this is one thing which, not only that, another important thing is these are the cerebellar peduncles that you can see nicely. The cerebellar peduncles always converge. If they are diverging, you know that there is either they are parallel or diverging. That means there is something abnormal in the posterior fossa or in the in the spine, which is resulting in this abnormality. Then comes the posterior fossa, that is particularly the transcerebellar section, where you can nicely see the fourth ventricle. You can see the choroid plexus, which are like a bar, and then you can see the Blake's pouch, and you can see the cisterna magna. So these are all the things that you can do just by taking three conventional axial sections of the fetal brain. Similar to that, what we follow in this second trimester or the mid-trimester scan. Then comes the sagittal fetal phase. Fetal phase is again, I'm sure all of you who has been practicing ultrasound and doing first trimester evaluation, particularly for the aneuploidy, optating this particular section is not a difficult thing. All of you can definitely get this sort of a section, and this section gives us a lot of information. For example, it starts from the facial profile, where you can see the frontal bone, where the pattern of the frontal bone can be identified, whether it is sloping, whether it is bossing, all those things can be made out. Not only that, the prefrontal thickness can also be assessed. And then we have the nasal bone, and then we have the palate, which has this line-on-line sign, which is described, which can tell us about the palate. So these are the things, and then you can draw an inferior facial angle, which tells us about the micrognathia. So this is another important factor that you can make out. Second important thing is that when you do the coronal section of the fetal face at this gestation, what happens is you can see both the orbits. You can see the outlines of the orbits very clearly, the margins of the orbits, and also the interorbital distance. That is, either the orbits are close to each other or far apart from each other. That is basically by putting one more orbit. That is, you need to accommodate one more orbit in between, then it is normal. If it is accommodating more than one orbit, it means it is definitely hypertellurism. If it is accommodating less than one orbit, it has to be hypotellurism. Then comes the premaxillary triangle, which you can see nicely here, where these are the zygoma, on either side the maxillary processes, and you see two small nasal bones on either side. So this confusion about nasal bones can be reascertained by doing this particular section. That's one. Second important thing is the base of the premaxillary triangle is formed with the palate. So the palatine abnormalities can be made out. The third most important thing is here, you can see the mandible which has two ossific centers. If there is only one ossific center, that is a single ossific center, it indicates that there is a micrognathia or a retrognathia. So this much of information can be obtained by just doing these three sections of the fetal face. Now coming to fetal heart, the fetal heart is one thing which definitely it is little difficult because quite often it is a very small tiny one, and to get a good sections of it is difficult. But then if you start practicing, there are at least you should aim that you are going to get at least three sections that are the most important thing. One, as I said, as I've been telling since yesterday, that the fetal apex of the fetal heart and the stomach relationship, are they concordant or are they discordant? That is one. Second most important thing is the assessing the axis of the heart. So whenever we think in terms of the fetal heart abnormalities in the first trimester, if you go back and look into the aneuploid screening which you do, the factors which you consider to be abnormal or increased risk for aneuploidy, increased nuchal translucency, tricuspid regurgitation, abnormal venous ductus venosus flow, indicate that there is a cardiac problem. So indirectly, when you have that, so these three markers are taken into consideration. Whenever these three markers are there, associated with it, if you take the axis of the heart into consideration, your detection rate goes up to almost 88% in a low risk population. That is very, very important factor, that because not that most of the patients, and the incidence of cardiac abnormalities is quite often more in the low risk rather than the high risk population. Now, the second section that I am going to look for is basically put the color Doppler on and try to understand or evaluate the interventricular septum. The third most important thing is that you take the three vessel view. So by taking these three things, first and foremost thing, you have established the situs. Second thing, you have understood the four chamber view and their abnormalities, like any ventricular discrepancy, any axis deviation, or any chamber abnormalities can be easily made out. Not only that, you can also see the atrioventricular valves. Put the color Doppler on, it confirms the flow pattern, and then do a three-vessel trachea view. As morning it was said, the three-vessel trachea view gives you most of the information that is required as far as the conotruncal abnormalities are concerned. So basically, it will definitely help you in identifying these conotruncal abnormalities. That is sick. Then comes the fetal abdomen. So whenever you start scanning, whether it is a second trimester scan or a first trimester scan, there are three physiological cystic structures that you have to definitely look for. One is the fetal stomach, second one is the fetal bladder, third one is gallbladder. Gallbladder may or may not be seen in the first trimester, but then stomach and urinary bladder will definitely be seen. So you should make it a habit to look for them, because if they are not there, you are not sure whether they are absent or they are not filled or they are emptied. That's the reason why the first sweep itself should give you an idea whether the stomach and bladder are seen normally or not. Once you have established that, then you assign the configuration or the pattern between the stomach, the abdominal aorta, and the inferior vena cava. That relationship should be established. Not only that, you are also going to try to see whether the stomach and the fetal heart are corresponding to the same side. If once you have established that, it could be situs solutus with levocardia, or it could be situs inversus with dextrocardia. So if you make out that the stomach is on one side and the apex of the heart is on the other side, obviously you are dealing with an ambiguous situs ambiguous. So that gives it's extremely important clue for you to thoroughly evaluate on cardiac abnormalities. Then comes the second section where you are going to move your transducer a little lower down. The most important factor that you are going to consider is the insertion of the umbilical cord into the anterior abdominal wall. Once you have established the insertion of the umbilical cord into the anterior abdominal wall, you can most often rule out the anterior abdominal wall defects, whether it is a supraumbilical, umbilical, or infraumbilical anterior abdominal wall defects. So that will help us. Then you have identified the bladder. confirm the bladder by putting the color Doppler on, wherein you can see that the umbilical cord is a 3-vessel cord or a 2-vessel cord. When you find 2 uterine arteries, the umbilical arteries skirting the bladder, you know that you are dealing with a 3-vessel umbilical cord. Then comes down and then look for the pelvic bones, and at the same time you can also look for the fetal kidneys. As you can see them, the fetal kidneys can be identified as early as about 12 weeks of 11 to 12 weeks of gestation. Most important factor that you need to consider is that most of the times these fetal kidneys at this stage of gestation are usually echogenic. That is one thing which you should not get disturbed. You always have to follow them up in order to re-ascertain that the echogenicity is normal or abnormal. So that is another thing which you should. And another thing is that we need to look for the sagittal sections of the bladder, genital tubercles, and the diaphragm. You can most often see the diaphragmatic contour and the kernel sections for the kidney and the spine. Then comes the other section, that is the spine. You can take the sagittal section of the spine. Entire spine can be evaluated. Vertebral configuration can be seen. You also see the skin continuity very clearly delineated so that you can rule out certain small open neural tube defects. Then extremities, as just now Chandralula has told us, that we have to look for the extremities properly in the first trimester, because that is a very, very important period where most of the extremity abnormalities can be picked up very easily. Digital abnormalities also can be picked up much more confidently at this stage, but not in the second trimester, where quite often you may have a clenched fist, which makes us difficult to identify the digital abnormalities. So this is the plan that you need to follow in order to evaluate the fetal structural abnormalities. Now this one section I'm sure all of you take. This is one section which gives us enormous information which you really make use of it. First and foremost thing that you know that this is the sagittal section. You have been looking for the nasal bone, you are looking for the palate. You can see, as I shown you before, you can see the falx cerebri. This curtain-like echogenic area is nothing but it's a falx cerebri interhemispheric fissure. Just below that, you have the thalamus, which is a rounded ball-like structure. There is a waist here, which continues downwards as the brainstem, which you could easily appreciate in the sagittal section. Then we have the fourth ventricle, that is the intracranial translucency. You have the brainstem intracranial translucency, and then the cisterna magna, and of course the mandible, stomach, and then you have the card insertion and the bladder. So all these structures with one single section, which you always do. Only thing is you need to focus to look for these things so that you get this information. That is them. Then comes the spine, and then we have, why are we doing this cell-free DNA? Cell-free DNA is very, very optimally done at about 10 weeks of gestation. So we need to develop a skill in order to evaluate these embryos, that is 9-weekers, so that there is a definite indication for a pre-NIPT scan. What are the indications? In case if there is the lady presents with a positive pregnancy test, and it is confirmed that the fetus is, you do a transvaginal examination to confirm the fetus, whether the fetus is present or not, or viable or non-viable. In that situation, if it is non-viable or if it is only a false positive, there is no reason why you need to do an NIPT. So that is the reason why we will not do NIPT. Second important thing is, if you have detected a structural abnormality in the pre-NIPT scan at about 10 weeks of gestation, where is the need for an NIPT? Because you are going to ask for a genetic test which is pertinent to the structural abnormalities which you have detected. So there is no role for an NIPT. Third most important thing is, if you have diagnosed multiple pregnancies, asking for an NIPT may not solve our problem. It is much more the usual traditional screening that we are going to follow. Suppose there is a pregnancy which is it is less than 9 weeks, it doesn't make sense asking an NIPT. That is the reason why. So this pre-NIPT scan not only is indicated in order to ascertain whether NIPT has to be done or not is one part. Second important thing is, there are certain abnormalities that you can definitely pick up in the pre-NIPT scan, such as the crania, where you can nicely see the absence of the cranial wall, Or you can even see the butterfly sign which is absent with the interhemispheric fissure being interrupted, which shows that there is a cleavage abnormality. Or you can have a situation where you have the fetal heart which is pumping outside the thorax, which is an ectopia cardis. Or you can have a situation where you have a crooked spine, omphalocele, as well as adherent to the anterior abdominal wall. Or you may have a situation where you have a conjoined twins. So all these abnormalities can be picked up. In this situation, there is no reason why we need to do an NIPT at all. So that is the role what we are going to take part as far as the pre-NIPT scan is concerned. And this is one thing which you should promote and use in your day-to-day practice. This lady is one who has done a lot of work. She has evaluated almost more than 1 lakh patients, where she did 98% of her work evaluating the structural abnormalities transabdominally. Only 2% she used transvaginally, and almost about 500 cases, anomalies were detected in the first trimester. Almost half of all the second trimester abnormalities were detected quite early. So that is the role. So with this impetus that we need to do, there are certain red flags which prompt you to really look for certain abnormalities. Suppose, for example, you have a classical pathological herniation. First and foremost thing, you need to differentiate between a physiological hernia and a pathologic hernia. One, you have confirmed that there is a pathological hernia, which definitely is going to be bigger than the transverse section or the area of the abdomen, or when you see the liver inside. So definitely you need to think in terms of a pathological omphalocele. In that situation, definitely you need to look for further evaluations of this thing. Second important thing is the patient presents with an increased nuchal translucency. You get a karyotyping done, and karyotyping done comes out as normal. So you are definitely have to look for whether there is any cardiac abnormality, renal abnormality, or a skeletal abnormality. Third most important thing is consider the family quite often. This lady actually came to me in the first pregnancy, where we did the scan and we could found that there was an occipital defect and there was a cephalocele. Not only that, the fetus had multiple cystic areas in the kidneys, which was Meckel-Gruber. So with that history, she came back for the second conception, and I really felt very sorry to see this again, that there was because she came back with the previous history, I wanted to look very carefully about the cranial vault, and this is what I find, where there was a cephalocele. Or sometimes you may have a direct evidence, that is when you do a systematic approach following the proposed plan, you will definitely detect a certain sorts of a spinal abnormalities. Now, to give you an idea that there are some abnormalities in the first trimester which can definitely be diagnosed. There are some most often can be diagnosed. There are some which you may not be able to diagnose, like agenesis of corpus callosum, cerebellar hypoplasia, renal agenesis, CPAM, and duodenal atresia and other things. So these are the things that what we have to plan is that the ones which you definitely do, as I'm sure all of you have been diagnosing this acrania, exencephaly, anencephaly sequence. Now with the present introduction of identifying the butterfly sign, if you have an interruption of the interhemispheric fissure at about 10-12 weeks of gestation, positively you should be able to diagnose this monoventricle with the unfused thalamus and a facial abnormality, which is very classical, which is going to be a ventral induction defect, that is alobar holoprosencephaly. Or we may have a skeletal abnormality, that is the cranial abnormality, as I showed you before also, that there could be a cephalocele. These cephaloceles can be different. It can be occipital, parietal, frontal regions, but quite often the commonest is the occipital region. You can also see that there is a traction of the card, and you can see the herniation of the brain parenchyma into the sac. Then comes as you go down into the abdomen, you try to evaluate the insertion of the umbilical cord. You don't find the insertion of the umbilical cord, and sometimes you find some sort of a membrane which is enclosing the herniated part, and you put the color Doppler on. You can see the umbilical cord to the right of this thing, or sometimes you may find this sort of a free-floating bowel loops, as you can see here, which confirms the diagnosis of an anterior abdominal wall defects, either as an omphalocele or a gastroschisis. Then we have the body stock abnormalities, where we may find this sort of a omphalocele as well as the gross skeletal abnormalities and cardiac abnormalities, which indicates that there is a body stock abnormality. Now, this is one thing which definitely is going to be of great help, identifying the bladder, identifying the size of the bladder. Whenever you find that the size of the bladder is large, normally is about 7 millimeters, anything less than 7 is considered as normal. Anything between 7 to 15 is considered as abnormal, or even more than 15. If it is 7 to 15, you definitely, more than 7, you definitely call it as a megacystis. But whenever it is between 7 to 15, first and foremost thing, you need to think in terms of a possible chromosomal abnormality, because 20% of trisomy 18 and 13 will have this sort of a megacystis, which is between 7 to 15. If it is more than 15, one has to strongly suspect the possibility of a lower urinary tract obstruction. So that is how we are going to make use of this particular feature of a large bladder in the fetus. Then we have the neck abnormalities. The neck abnormalities could be basically because of a cystic hygroma, or you can find that there is a nuchal edema, which is seen in the whole of the body, shows that there is a soft tissue edema. Because of the prompting of this, I did the transvaginal evaluation of the fetal heart, and you positively find that there is a hypoplastic left heart syndrome. So at about, I think it was 11 weeks, 5 days that we could diagnose this. So this gives us a lot of advantage of counseling these patients, evaluating further for molecular testing, and take it forward as far as the management is concerned. Now, coming to the fetal heart, as I said, there are most important thing is the markers that you are going to take into consideration is NT, TR, DV, and axis. Axis is extremely important, as I said. The bare minimum sections that you are going to do is, these are the bare minimum sections. One, the upper abdomen, stomach, relationship has to be evaluated. Then comes the grayscale 4-chamber view, wherein you can find the relationship of the apex to the stomach. Put the color Doppler on, evaluate this discrepancy or sizes of this, the chambers, its relationship posteriorly, location of the aorta, and also identify the septum by putting the color Doppler on. Take it up a little more, then you see the 3-vessel trachea view. Gives you almost, and 98% of the times you can definitely achieve this many sections in every fetus which you are going to evaluate. So only thing is that you need to put the effort in order to look for them. So these are all the various things. As I said, first and foremost thing, when you see, look for the correlation between the apex of the heart. So for example, here, the apex of the heart is here, whereas as I take you down, I can see that the fetal stomach is coming onto the, this side, the other opposite side. So there is definitely a situs ambiguous. Not only that, when you find this sort of a thing, you will definitely look for other cardiac abnormalities here. As you can see that there is a atrioventricular septal defect, and you can also identify echogenic walls of the interventricular septum as well as the tricuspid. So it is a fibroelastosis, and you can also assess the reversal of flow by going into the 3-vessel view, where because of the hypoplastic or the fibroelastosis of the lateral ventricle, in the left ventricle, there is a reversal of flow. Discrepancy of the chambers can be identified, which can prompt us to think in of a. Now going to the 3-vessel view, you can nicely see the 3-vessel view. Location can be seen, sizes can be assessed. Not only the direction of flow can be easily obtained. For example, here you can see that the 3 vessels are there, but the flow in the great vessels, one is blue and the other one is red. Obviously, you know that there is a reversal of flow, that is the ductal dependent flow. So this is again an important thing. And also the configuration, as I said, it can be a U-shaped, where you know that it is a right-sided aorta. Sometimes you can pick up these lesions which can show that there is a parallelity of the vessels, which can also prompt us to give us information regarding. So this is what you can make use of in there. Now the aim of today's evaluation of fetal structural abnormality is to push the fence sitters, that is the 50% diagnosis to 100% diagnosis, in which we try to evaluate the ventricles, lateral ventricles, posterior fossa, eye lens, profile of the face, mandible and upper lip. Not only that, the spinal canal can be evaluated more specifically, mediastinal shift can be ascertained, and the other things I'll show you as I take you through. Now this is the classical examination of a fetal faces, where I have started with the intracranial the transventricular section. Then I progressed into the identifying the interhemispheric fissure. Now I have gone to a situation where I can see the metopic suture, I can see the orbits on either side, I can see the lens, I can see the premaxillary triangle, I can see both nasal bones. Now again a little more, I can see the premaxillary training nicely. Two ossific centers of the occipital bone can be seen. These are the things that you can see. So all these things can be obtained. In the profile, you know the frontal bone, nasal bone, palate, and the chin. So this is what you can make out by using a methodical approach. There are various facial abnormalities that can be quite early detected. As you can see, this was a 12 week, 6 days fetus where we could see that there is hypotellurism. Here, there is a increased space, intraorbital distance is increased, which is hypertellurism. You can see proboscis or cyclops and cleft lips very early in pregnancy. Now coming to the cleft lip, cleft palate and micrognathia, these are the work that has been done extensively, micrognathia, maxillary graft sign. Particularly we know that this line-on-line sign is extremely useful in identifying the cleft palate. Whenever you have this sort of a discontinuity, you know that you are definitely going to, or instead of having these two lines, you may have only one line which indicates that there is only vomer, not the palate, and that again tells you that there is a hard palate abnormality. Similarly, you have the premaxillary retronasal triangle where you can see whenever you find there is a cleft palate, you can see that there is a discontinuity in the base of the triangle, so that it indicates that there is a cleft. Sometimes you can find, normally you should find two ossific centers. If you find only one ossific center, and then you know that you are dealing with a micrognathia. This was just the rendering of the same baby, which showed that there was a severe micrognathia. So this is the inferior facial angle, which can also help us. Now coming to the ventricles, as I said, in the first trimester, the choroid plexus should fill the whole of the lateral ventricles. Very little fluid is seen in the anterior horns, whereas there is a disproportionate size of the choroid plexus when compared to the ventricles. Obviously, you are dealing with a ventriculomegaly, which has to be kept in mind, which is an ultrasound feature. You need to work on that and to establish the cause for ventriculomegaly. Now, the fourth ventricle, large fourth ventricle, or a posterior fossa cyst can be easily identified, as you can see a large cystic area in the posterior fossa. Now coming to the spinal abnormalities, I am not going to details of the posterior fossa abnormalities because that takes a lot of time, whereas here there are certain spinal abnormalities which we can pick up very easily in the first trimester. First and foremost thing, there are certain direct and certain indirect features. Indirect features, there are almost about 13 indirect features that you can come across. The direct features basically are when you find this sort of a cystic area in the sacrococcygeal region. Sometimes you may find that there will be a widening. Skin defects can also be done when you do a soft tissue rendering. Or you may find various indirect signs that as, see normally, you know, this is the brainstem occipital bone ratio. Whenever this ratio is altered, it is either it has to be because of some open neural tube defects, or there is a posterior fossa cyst which again alters, that is flattens the brainstem and alters the brainstem BS-BSOB ratios. And then you have the acorn sign where you can find that this the skull is, acorn is a fruit which can be seen like this. This is the, which also will have a small biparietal diameter. And as I said, in the thalamo-peduncular view, you find the peduncles will be converging, whereas when they are parallel, you obviously know that you are dealing with an open neural tube defect. So these are the things, and then mediastinal shifts can be easily made out by putting color or even on the gray scale itself, and the axis rotation of the fetal stomach also will help us in identifying these links. Now the another most important thing is the renal abnormality. As I said, the renal kidneys can be made out as early as 12 weeks of gestation, and whenever you find this sort of a situation, this is a combination of occipital encephalocele with multicystic dysplastic kidneys, which is a classical feature of a Meckel-Gruber syndrome. Then skeletal abnormalities, as it has been already covered by Chandar. I will not be going into details of it, but then you have to make it a habit to look for all the three segments. Femur, tibia, fibula, femur, tibia, fibula on both sides, humerus radius ulna, humerus radius ulna. Not only that, the hands and the feet has to be, because this is the best time where you can nicely see the digits or the fingers very clearly. There are various abnormalities such as this can be made out like the talipers, or you can make out polydactyly, you can make out ectrodactyly, syndactyly. All these things can be made out by evaluating the limbs in an appropriate way. Not only that, whenever you find that there is a frontal bossing like this in a small bone, and you have a protuberant abdomen and a small thorax and a short, long bones, obviously you are dealing with a thanatophoric dysplasia. So these are the abnormalities which can be easily picked up in the first trimester. Amniotic band syndromes also have to be kept in mind. Even though they are not abnormalities, they are limb reduction defects which can be made out in the early trimester. Umbilical cord length may not be of great help, but then whether it is a single or double, three vessel cord can be identified. So to sum up, a word of caution is that there are a lot of limitations in detecting anomalies at 12 weeks of gestation. Please always, it requires reconfirmation at 16 to 18 weeks. Don't be in a hurry to terminate. Please reconfirm your suspicion in 16 to 18 and always look for the adnexal reasons. That is one thing which we quite often ignore, and that is where you may have a heterotopic pregnancy and you will get into trouble. Thank you very, very much. Ramurthy to come over and then take over the dais and deliver a lecture on ventral induction defects.
So what are ventral induction defects? Dorsal defects is, the dorsal process is the process of closure of the neural tube. Remember, neural tube is a groove, and then the groove closes. This act of closure is called dorsal induction. So dorsal induction defects are actually neural tube defects. But what's ventral induction? Ventral induction is where the prosencephalon, which is the cephalad-most vesicle. Remember, after the caudal and the cephalic neuropores close, the neural tube is now segregated from the rest of the fetus, right? And the head end of the neural tube expands into three distinct vesicles: prosencephalon, mesencephalon, and rhombencephalon. The prosencephalon, to start with, is a single vesicle which divides into right and left. right? This act of cleavage is called ventral induction. So when two hemispheres are formed from the single holoprosencephalon and the corpus callosum connecting the two hemispheres form, that is ventral induction. So cleavage of the hemispheres, formation of corpus callosum, and formation of the septi pellucidae. These form what is known as ventral induction. So in this lecture, I'm going to deal with only holoprosencephaly. Only the cleavage aspect I'm going to look at. There's no time in half an hour to look at corpus callosum and septal agenesis. We will leave that. We will look at holoprosencephaly. Now, holoprosencephaly is when this cleavage fails to occur. When it fails to occur, there is the two hemispheres do not form, right? So how do you identify what are the clinical repercussions, or what are the clinical kind of presentation these children have? So remember, this cleavage occurs at around 5 to 6 weeks of conceptual age. Therefore, by the time you get to the 11 to 13 weeks, 6 days period, you will be able to identify whether the cleavage has not occurred or has occurred, at least in its severe form. So what are the causes? You have 2 or 3 main causes. One is syndromic, chromosomal, single gene disorders. One is teratogenic, maternal diabetes, alcohol, retinoic acid. But the most common cause is non-syndromic, autosomal dominant. These are the genes and 10 other genes which are involved. And when there is a holoprosencephaly in the fetus, we need to look at the parents very carefully, both the mother and the father, for early or subtle signs of ventral induction defect. We'll come to that as we go by. If there's a holoprosencephaly and mid-facial anomalies alone, you don't call it a syndrome, you call it a polytopic field defect. Only if this, in combination with extrafacial, extracranial defects, that becomes a polymalformation, and that is when you think of syndromic. So what is the spectrum? This is the Myers classification. The Myers class, can you take off the last panels? You will enjoy these slides much better if this goes and that goes. Just put off those two, please. Just put it off. You will enjoy the slides much better. So here is the severest aspect of the spectrum, alobar. There's no segmentation or cleavage at all. Here, semilobar, what has happened is the frontal horns not cleaved, the bodies of the ventricles not cleaved, they are single, but the occipital horns have cleaved, right? Now, lobar is the mildest, where the occipital has cleaved, the bodies of lateral ventricles have cleaved, only the frontal horns are fused. You will have to know this, because unless you know this, you won't be able to identify these findings in the ultrasound pictures. And now I'll come back to the middle hemispheric variant, where you have the frontal horns cleaved, occipital horns are cleaved, only bodies have not cleaved, right? So here the parietal cortex is continuous, whereas you have an interhemispheric fissure in the frontal and occipital aspects. So wherever cleavage has occurred, the two ventricles separate. There is an interhemispheric fissure in that region. Where it is not cleaved, you do not have an interhemispheric fissure, and the ventricles are continuous side to side. You can't say fused ventricles, you have to say non-cleaved ventricles, right? So that is what it is, how it translates. Now we will come to each one of them. Whenever you have in the basic examination, you might have findings, and the findings is an absent CSP or an absent interhemispheric fissure in the anterior complex. That is your first warning signal. You know, in your checklist, you have to look for the cavum septum pellucidum. You've got to look for the anterior hemispheric fissure and the anterior complex, which we will deal with during the workshop. But if these are abnormal, like for example here, you don't see the cavum septum pellucidum, I don't see the anterior interhemispheric fissure, and therefore my thought process begins to think in terms of a potential holoprosencephaly, and I have to do a full neurosonogram. You can't limit to 3 planes and say my scan is over, you go. You have to do a neurosonogram, and I'll show you cases where all the 3 planes are important and you get to see findings in all 3 planes. Now let's look at this 22-weeker. And in this 22-weeker, in the classical transventricular plane, you don't see anterior interhemispheric fissure. You don't see a cavum septum pellucidum and septi pellucidi. Instead, what you see is the frontal cortex is continuous from side to side. The ventricle is primitive, continuous from side to side. Then the cortex bends in over here. This is the hippocampal ridge, and from the hippocampal ridge you have a cyst which is billowing out or blowing out posteriorly. So this is called the dorsal cyst. No interhemispheric fissure, and the ventricle is not cleaved. Therefore, this is alobar holoprosencephaly. Now what happens in such a case when you do a mid-sagittal, you will see that this is the cortex, this is the primitive ventricle, and through the posterior aspect it opens out and communicates with a large cyst, and that is the dorsal cyst, right? Now what happens in coronal? In coronal, you will see when I go anterior coronal, the frontal cortices are continuous with each other. The interhemispheric fissure in transfrontal coronal plane should extend all the way down to the floor of the anterior cranial fossa. Here, do you see it? You see only a part of it, and all this is missing or there? It's missing. Then you go posterior, you will see that the ventricle, the lateral ventricles on either side are communicating with each other. They have not cleaved at all. And again, you see the interhemispheric fissure is incomplete. No septum pellucidum or cavum septum pellucidum, and no what structure? What do you expect to see here? Loudly? Corpus callosum. No corpus callosum. Remember, if the hemispheres don't cleave, there is no role for corpus callosum. Why is the corpus callosum there? Because there are 2 hemispheres. If there are no 2 hemispheres, where is the question of having corpus callosum? No function. It doesn't form. So wherever there is cleavage, corpus callosum in that segment forms. Wherever there is no cleavage, no corpus callosum forms. These are basic concepts. If you have them, you can translate them into practice. So you go, this is transcaudate, you go transthalamic, you see the classical thalamus and absent third ventricle. So you see that the thalami have not cleaved. Why? Because it's a part of, fill up the blank. It's a part of what is the name of the lesion? What encephaly? What prosencephaly? So thalami are a part of prosencephalon. Remember, the prosencephalon has telencephalon giving rise to the cerebral hemispheres, and the diencephalon giving rise to the basal ganglia, the thalami. So in holoprosencephaly, you have a holotelencephaly as well as a holodiencephaly. And a fused thalamus tells you that the diencephalon has not cleaved. Third ventricle is absent. So these are the coronal findings that you have. And in the same case, you'll have to look at the face. The orbits are prominent. There's bilateral, paramedian, clefting. There's a prominent, not proboscis, that's a prominent pre-maxilla. That's a prominent pre-maxilla that you can see. And if you see the central or the sagittal plane, you find a flattish nose and a little protuberant pre-maxilla. So those are the facial midline anomalies that you have seen in this particular case. Here, if I were to go back, what does this remind you? This reminds you of a cup or a ball or a plate. It's a cup. So there are three types of holoprosencephaly depending upon the configuration of the cortex. So this is a cup shaped. On the other hand, you see here that all around you have cortex. So this is ball shaped. This is ball shaped. And here you have how many nostrils? One nostril, it's called sebocephaly. Fused or uncleaved thalamus, classical heart-shaped thalamus projecting into the primitive monoventricle, and those are the choroid plexuses that you can see here. Let's look at this 19-week fetus. I'm showing you the transabdominal pictures, and on transabdominal pictures you see a primitive ventricle absent anterior interhemispheric fissure. There is no CSP at all, and when I go backwards I will see that the primitive ventricle is there and the choroid plexuses are continuous. That is sometimes a headlong clue. Why? Because the choroid plexuses are hyperechoic. They go from side to side and they excite your curiosity, and that is how you will start thinking in terms of a holoprosencephaly. Now you leave the transabdominal probe, you will have to do a multiplanar, you have to go vaginal. And when you go vaginal, you will produce spectacular pictures like this, which no MRI can give you, right? So you will see that this is the primitive ventricle, that is the cortex, hippocampal ridge. There's not much of a dorsal cyst over here. We'll see over here small dorsal cyst, but you see what? Uncleaved thalamus. These are the cerebellar hemispheres, occipito-bregmatic section. This is transventricular section. All the findings that you see, and when you do a mid-sagittal, you have an abnormal nasal profile, but I've turned the color Doppler on to show you one sign. What is this sign? Snake under the skull sign. So the anterior cerebral artery should be deep down. It is just under the calvarium, and it's called a snake under the skull sign that you can see over here. And you can also see the choroid plexus in the midline and the fused ventricle, which is getting cut in the midline, very well seen. In the coronal, you again see the uncleaved ventricle, and you also see the choroid plexus, which are side to side touching each other. And in this particular case, the orbits are very close to each other, and they are also very small. So microophthalmia and hypotelorism. And this is a sign which oftentimes we see. That's the frontal bone from side to side. And here is the vaginal scan showing you those small orbits. And this is the nostril. How many nostrils? Only one. So sebocephaly. Generally, sebocephaly is associated with an intact lip, as you can see in this. You can see the lip is intact, as you can very well see, and that's the sebocephaly or single nostril, right? Now we move on to semi-lobar, and in this I will shut off these and I'll activate them at the right time. Now, what is your first sign that tells you there's something wrong as you're scanning? Anybody? More importantly, what catches your eye? The choroid plexus are causing the midline. That catches your eye. And then you look for your what? CSP, seen or not seen? But what is seen? Interhemispheric, seen. Correct? So therefore, you're going to suspect again lack of cleavage in the parietal area, and I don't see the CSP over here. The occipital horns, do you think are separated or fused? Separated, right? So you have a headlong clue over here. So let us see what the coronal looks like. When I come anteriorly, what is happening here? Continuous. There is no CSP. The frontal horns are small or good sized. They are hypoplastic, they are small, they are continuous. But when I go posterior, what happens to the occipital horns? Separate or fused? When I come to the body, fused. Okay? So therefore, this is semi-lobar holoprosencephaly, and in the midline, you find that is the region of fusion between the hemispheres. This is not the corpus callosum. This is the vermis that you can see here. That's the vermis, and that's the fused hemisphere across the midline. Again, 24 weeks in the parietal region, it is continuous, but when I come to the occiput, you have distinct one horn, distinct other horn. You have midline facial features in terms of a very flat nose, a clefted lip, proptosis that you can see, again semi-lobar holoprosencephaly, and in this case you have echogenic kidneys, you have a DORV, you have a proboscis which is sticking out, a rhinia, no nose at all. You can see the proboscis coming out here. There's a single umbilical artery, and when you have extra craniofacial abnormalities, you will know that you're dealing with a possible syndrome. You do your karyotype, and that's the trisomy 13. Okay, so it's an unbalanced translocation type of trisomy 13. It's a 13-14 translocation, and that's the midline orbit, and that is the proboscis that you can see in this particular case. That's the proboscis, and this is the midline orbit, and there is no nose at all over here, right? So that is a trisomy 13 translocation type. Here's a 27-weeker, and when you do your coronal, you find that the frontal lobes are continuous, incomplete interhemispheric fissure, but I've shown you only one anterior cerebral artery, and that is called azygous anterior cerebral artery because it is single, right? So that is the finding that I wanted to highlight over here. And here you will see that there is only a small bit of the corpus callosum in the splenium region. Why is that? Because only occipital horns have separated out, right? The frontal horns and parietal portions of the cortex have not separated out, so the bodies of the ventricles, frontal horns are uncleaved. Again, semi-lobar, and in this again you find that there's a snake under the skull kind of appearance of the anterior cerebral artery. Now lastly we come to lobar. Here is a 20-weeker. Frontal cortex continuous, or is there presence of interhemispheric fissure? Continuous. CSP present, CSP absent. CSP absent. Now look at the bodies of the lateral ventricles. Bodies are separate, occipital horns are separate. only frontal cortex, right? There are facial abnormalities in terms of bilateral cleft. So only when the frontal cortex is uncleaved, the bodies and the occipital horns are cleaved, you know you're dealing with lobar. So the lobar HPE has a differential diagnosis with septal agenesis. And what are the differences? This is a coronal of septal agenesis, whereas this is a coronal of lobar or semilobar holoprosencephaly. So here what do you have? The midline is continuous. You can see that. When I go to the frontal, the midline is up to down, and the frontal horns have cleaved, they are good size. Here there's no up to down at all. The frontal horns have not cleaved and they are small sized, good sized anterior horns, small sized anterior horns, right? And as I play this clip, you will agree that the cavum septum pellucidum is not seen. We'll come to that. Is not seen. And here also the no cavum septum pellucidum, because the septi pellucidi are not there. And here also there's no septi pellucidi, right? But most importantly, I want you to also see the anterior or see the superior aspect of the interhemispheric fissure. Is it seen or not seen? It is seen. And what is this? Corpus callosum. And what are these two small lines here? Callosal sulcus. So corpus callosum present means callosal sulcus is present. Whereas here you see that the anterior or the superior interhemispheric fissure is incomplete. You don't have a callosal sulcus, you don't have a corpus callosum. This is how you differentiate between septal agenesis as well as lobar holoprosencephaly. And lastly, look at the dicaricature. As I come anteriorly, the anterior horns diverge. Can you appreciate the divergence? Just see how they diverge. Whereas here, there is no divergence. So many features intrinsically. Then you come to the face. In septal agenesis, the face of the fetus is essentially normal, whereas in lobar holoprosencephaly, definitely you might have midline facial defects. And lastly, we come to middle hemispheric variant. Before I take a couple of cases of microform and septo-optic, and then we'll come to first trimester and finish. So in middle hemispheric fissure, which is a hemispheric variant, which is also known as scintillencephaly, as I said, the frontal horns are cleaved or uncleaved? Loudly. Cleaved. Occipital horns are cleaved, whereas the body uncleaved. Now this is transabdominal, whereas if I do a transvaginal and I do a axial reconstruction, again cleaved, cleaved, uncleaved. And again, what do you see here? What is this? Interhemispheric fissure. Because the frontal horns are cleaved, you have a interhemispheric fissure. Again here, because the occipital horns have cleaved, you have an interhemispheric fissure. But in between, there is non-cleavage. So we will look at the coronal section now. Frontal horns cleaved or not cleaved? See what happens. Okay, now tell me, frontal horns cleaved or not cleaved? You see the interhemispheric fissure, yes or no? Now I come to the next one. Now I go back to the bodies. Bodies are not cleaved. Bodies are not cleaved. The temporal horns are cleaved. And then when I come there, the posterior bodies are also not cleaved, but the occipital horns are cleaved. This is classical middle hemispheric variant. And in this case, when I do a mid-sagittal section, you will find that there is a small dorsal cyst. This is the uncleaved portion of the ventricles, and you might see a small corpus, element of corpus callosum anteriorly, because the frontal horns are cleaved. So you do your color Doppler, you find an abnormality in the circle of Willis. You do your skull, what is this? Snake under the skull sign. This is the dorsal cyst that you can see here, and this is the inversion, showing you that the frontal horns have, occipital horns have cleaved, but in between the bodies have not cleaved, and this is the dorsal cyst on the inversion mode. And this is, of course, reconstructing the axial from a sagittal acquisition. You see everything very, very clearly, and I'm not going to repeat it. Now let's go to the more subtler forms. Microform holoprosencephaly is the term used if you have mid-face craniofacial anomaly in the absence of brain malformation. For example, let's look at this 23-weeker. The ventricle, normal or abnormal? Quickly, normal, abnormal? CSP, normal. Brain otherwise looks good, no problem. I'm showing you the coronal over here, and I'm showing you the coronal posterior and coronal transcaudate. You see the cerebellum is normal. So there's nothing grossly wrong over here in these basic sections. In this particular heart, there was a subaortic stenosis. You can see it's not at the valve, it is under the valve. The entire outflow tract, even before the valve, is narrow. So there's a subaortic stenosis over here. The NIPT is low risk for common trisomies. But when you do the face of this particular fetus at 23 weeks, I'm showing you the premaxillary triangle. What do you see here? Premaxillary triangle, normal or abnormal? The triangle should be a triangle. What is it over here? The nasal bones are parallel to each other, and the nasal aperture is wide or narrow? Narrow. So what do you call this? You call it congenital nasal pyriform aperture stenosis. So the aperture of the nose, bony nose itself is narrow now. In this background, I want you to see the maxillary bone. What do you see here in the midline? This is a socket of a tooth. The incisor should be on either side of the midline. Here the incisor is exactly in the midline. Here the incisor is exactly in the midline, right? And that's the surface rendering, which is normal. So what do you call this incisor? You call it central median maxillary central incisor. So these are these subtle findings. So this is what you've got to look for in the parents. Ask the parents to, both of them, to show their teeth and see if there's a single incisor. That's called microform HPE. And lastly, septo-optic HPE, also called as minimum HPE. Here what happens is the pre-optic area, that is the area in front of and the area which is below the anterior commissure, is what is continuous. There are a lot of findings in lobar versus septo-preoptic, but remember, septo-preoptic is more often an MRI diagnosis, more often a postnatal diagnosis, and we don't get to see this so often by ultrasound. It's really, really subtle, right? Lastly, before I let you off, first trimester diagnosis, 13 weeks, you can see that there's a primitive ventricle, thalamus is not cleaved, and most importantly, you will see that the frontal bones are prominent. And what is this? If this is one frontal bone, this is the other frontal bone, this is the metopic suture. The metopic suture should be very wide in the first trimester. Here it is narrow. So premature closure of the metopic suture, you can see very well here. And on transvaginal scan, you again you see the choroid going side to side, no anterior interhemispheric fissure, one orbit, the other orbit. Look at the space between the two orbits. Hypertelorism in this case, and there is a huge median cleft lip and cleft of the primary palate and secondary palates. And this is another 12-weeker showing you a holoprosencephaly that you can see here with an AVSD. And how many fingers? Polydactyly, all telling you that this is a trisomy 18, right? So survival and postnatal clinical features, intracranial abnormalities, if they are severe, you have profound developmental delay, severe motor deficits, limb spasticity, axial hypotonia, bed-bound, non-verbal. So this is a tremendously bad disorder to have, and of course it is lethal in its A-lobar form. 33% mortality in 24 hours, 58% mortality first month, and 29% only survive at 1 year. And those who survive will have such great consequences, very, very profound consequences. And of course, facial anomalies also matter. Ocular impairment, obligate oral breathers in arynia, and feeding difficulties because of clefting. So lobar and less severe forms have better neurodevelopmental outcomes compared to the severe forms, but certainly semilobar and alobar are very, very severe lesions in the brain. So holoprosencephaly plus mid-phase anomalies equals a polytopic field defect. Non-syndromic, look for subtle findings in the patients. But if there is extra craniofacial anomalies, think syndromic. And in milder types, MRI might help in diagnosis. And remember, you've got to do your invasive diagnosis in terms of a CMA and a WES to look at the mutation and appropriate counseling. And since we tend to pick up these lesions, at least the severe lesions, early in pregnancy, termination of pregnancy is definitely an option. Thank you very, very much for a very patient listening. Thank you. Okay. I think you should all breathe after that master class, a wonderful master class of something we'll not see a lot of these cases because they were very rare cases which Ramamurthy showed, and I think we are happy to see all of that. So coming to more simple topic is the fetal upper GI tract. GI tract is basically an atlas, so I will just show you images because these are typical images and you identify them and you have the pathology. Essentially, we are dealing with pathologies of the mouth, esophagus, stomach, duodenum, and some part of the proximal jejunum and ileum. Now, you can see that these all developed from the pharyngeal spaces.
and the foregut is what we are dealing with. As with all other organs, they are usually first solid in the embryonic phase, and then they undergo vacuolization, and in that process of the hollow gut tube, which is initially occluded by endodermal proliferation and then recanalization, defects can happen because you may not have a proper recanalization. It may form a cyst, which is a duplication cyst, or it may lead to some form of narrowing or atresia, like an esophageal atresia, duodenal atresia, bowel atresia, and this leads to polyhydramnios and manifestation. So polyhydramnios is usually the first sign of a problem, and then you start looking for the stomach shadow, you start looking for the esophagus, you start looking for the bowel. So these are the three types. So the initial endodermal proliferation goes through vacuolization. You may have atresia, you may have stenosis, or you may have duplication. So polyhydramnios is what we see, and the more proximal the obstruction, more earlier is the polyhydramnios. As you know, the swallowing starts by about 11 to 12 weeks, and once there is any deficit in the swallowing, and we will then manifest as polyhydramnios. It usually starts in the late second or third trimester, and not all cases of atresia may be associated with initial polyhydramnios. 50% are associated with the hydramnios, and especially the distal ileal and colonic obstructions are usually don't have polyhydramnios. So that can be a problem. So the first problem that we will address is a pyloric stenosis. Very rare to make this diagnosis antenatally. It's a common neonatal problem. You have a pediatric patient coming with vomiting, and this is usually a progressive disease and presents after 3 to 4 weeks of birth. And these are, of course, nice pictures of the face. Sorry, I think I got it mixed up. The pyloric stenosis will come later. First will be the face. That's a normal face, and you can see the baby swallowing, and that's very important to see the face, because sometimes you may see this tumor, rare oral tumor called an epulis. It was usually seen it's a more described tumor in dogs, and it is due to disorganized growth of the upper lip cell mass. So some people believe that it could be due to the hormones, maternal hormones, and this was a 35 week fetus, and believe me, till here all the scans were normal, and 34 weeks we suddenly saw this swelling in the lip, and that's you can see it is arising from the upper lip. When the baby opens the mouth, the lower lip is sliding over the mass, and that's the lip. And you can see the blood vessels also arising from the upper lip, and that was the fetus. It was important to pick this up, because suddenly at 34, 35, at delivery, if the mother sees a mass like that, it can be quite a ghastly presentation. The good part is it is very well surgically correctable. In about a minute or two, the surgeon with the scalpel there, you can see, just excise that mass, and it is a good outcome. So epulis, it has no associated abnormalities, no genetic association, and does not recur after surgery. So it's quite a safe thing to have. Vis-a-vis these very large oral teratomas, which cause life-threatening intraoral teratomas, which arise from the maxilla, mandible, or palate, and they invade the skull base, the nasopharynx or oral cavity, and of course do not allow swallowing, so there's polyhydramnios, and very rarely have these been corrected, especially if they are smaller in size. You need to keep the neonatal setup ready for an exit procedure, and that is a possible correction. But most of these which are so large, will require termination. The third malformation is essentially of the chin, because it does not allow you to swallow, and that causes polyhydramnios. And as I was trying to show, these are associated with various syndromes, as you can see here. So this is essentially two types, retrognathia or micrognathia. Retrognathia is an inferiorly placed mandible, whereas micrognathia is a small mandible. So what do? We do an inferior facial angle going from the chin to the nasion, and the mean value is 65. If it is less than 50 degrees, you can see that is retrognathia. Whereas in micrognathia, we measure the width of the maxilla and the width of the mandible, and this ratio, mandible to maxillary ratio, less than 0.8 is defined as micrognathia. So these are the normal fetus with all the normal methods of measurement. That's how we measure it, outer to outer, and we get this ratio. So some of the common syndromes, Treacher-Collins, Pierre-Robins, I've shown in the morning. These are the common syndromes with micrognathia. This is another index that we measure. We measure the length of the mandible. It's called the jaw index, and related to the BPD. So the anterior posterior diameter of the mandible divided by the BPD is a constant figure throughout gestation. If it is less than 23, indicates micrognathia. So that's an important measurement. And this is the classical Pierre-Robins. And this was the tongue. You can see this is a normal fetus. The tongue is reaching the mandible here. Whereas in Pierre-Robins, you can see the tongue doesn't reach the mandible. It falls back. It's a large tongue. It's macroglossia. And the tongue falls back. And that causes a cleft palate and cleft lip. The constant pressure of the tongue on the palate prevents it from developing. And because of the small mandible, the tongue is falling and obstructing the, so that was a sagittal section. This is an axial section. You can see the tongue occluding the pharyngeal airspace. Normally, we would see a good pharyngeal airspace. On the surface rendering, of course, you'll see the sloping chin and a small chin, which is the typical Pierre-Robins. This is the Treacher-Collins. So Treacher-Collins is acrofacial dysostosis. You will have limb abnormalities, ear abnormalities, and mandible abnormalities, and all this will cause lack of swallowing and polyhydramnios. We then go down to the most important missed abnormality, that is the TE fistula or the esophageal atresia. So that's a normal sagittal section. You can see here, that is the trachea, which is seen through and through behind the heart. And if you're very careful, you will see an echogenic area behind the trachea without a lumen or a faint lumen. That is the esophagus. So that's the trachea, that's the esophagus. And going down, you will see the normal stomach with the pyloric part here. You can see that here. And a small amount of duodenum, very little triangular duodenal cap that is seen. That is a normal finding, the stomach and the duodenum. So this confirms a normal, a well-sized stomach confirms the presence of a patent esophagus in most cases, except that if there is esophageal atresia with distal TE fistula, then that can become very, very difficult because the stomach will yet be seen. So this is, of course, a congenital diaphragmatic hernia. You can see the stomach has gone into the chest. That's the mesenteric artery going up because the bowel loops have gone up. And this can also cause obstruction and polyhydramnios. So first thing we always want to see is where is the stomach? Is the stomach in the chest or is it in the abdomen? If you don't see it in the abdomen, then the first thing you rule out is a congenital diaphragmatic hernia. We then look for presence of bowel. That's the normal bowel which is collapsed. That is the normal stomach. And as you go on to 18 to 20 weeks, you will start seeing the normal bowel loops. So, and that is later on, of course, you will see it. So that the first thing when we don't see a stomach is always rule out a congenital diaphragmatic hernia. Now that was a classical Bogdalek hernia with the stomach behind the heart. These are more subtle types of hernias. You can see that the stomach is yet in the abdominal cavity, but there is only one bowel loop which has gone up. So that is a single bowel loop, and this is a retrosternal hernia. It is called a Morgagni type of hernia. That is the sternum. That is that lucent area next to the heart is the small bowel loop, and the stomach is yet in the abdominal cavity. Now, this is a third type. It's called a hiatal hernia, where at the hiatal level, you can see the stomach going up, and you can see this very interesting presentation here. With each breathing activity, you can see that the stomach was rotating, almost like going through a volvulus, and it was trying to herniate, and surely after some time, we could see that the stomach was entering into the hiatus. You can see it here, and that was also seen in the axial view of the chest. You can see it here behind the heart. So it was better seen at the level of the sagittal section. And this was the attempt of the stomach. You could actually see the stomach rotating along its horizontal axis and trying to go into the, so very minor form of hiatal hernia. You then move on to the atresias, and the first atresia that we always want to see is the esophageal atresia. I think this slide has got mixed up. This was supposed to be with the hypertrophic pyloric stenosis. So when we see an enlarged stomach which is disproportionate in size, we need to repeat the examination. Important thing for detection of esophageal atresia and hypertrophic pyloric stenosis is repeat examination. If the findings remain the same, that is, if the stomach is not visualized or small, we suspect T fistula. If the stomach is large and distended and polyhydramnios, then we suspect congenital hypertrophic pyloric stenosis. So that is a persistently distended stomach, and this was a case of congenital hypertrophic pyloric stenosis. Now we have some standard charts, so we measure the length, and that's how we decide whether the stomach is large. Of course, it is visual, but we have some standard charts which can tell us whether this is a distended stomach. It can be a pyloric stenosis, it can be a pyloric web, or it could be an intestinal malrotation or a distal obstruction which is causing distension of the stomach. So here you see quite a grossly distended stomach with what appears to be a very thickened pylorus, which is seen better here in this particular case. There are also charts available for fetal volume, but I think diameter is good enough. At the other extreme, you don't see the stomach, or the stomach shadow is almost a slit-like. And that, of course, is when you start suspecting a esophageal atresia. But we never base our diagnosis on a single image. We call the fetus back in a week or so, and then we confirm whether there is actually an absence of the stomach. Now, this was a very interesting case where we were not seeing the stomach, but we were seeing something else. So I would like you to give me a diagnosis. What do you think this is? It's a rare finding. You'll probably never see it again, but sometimes you have to think out of the box. You don't see the stomach, you're automatically thinking of esophageal atresia, but there are enough clues on this image to tell you what this pathology could be. Can anybody say? We have switched on the color. You can see there is deviation of the mesenteric vessels to the right side. So what do you think? No stomach, some mass. So what mass can be there? Just in a fetal age. What is a congenital mass which is commonly seen? I showed off the face, epignathes, or oral teratoma. So this is the teratoma. You can see that this part is a mass. You see that calcified area? That's a mass, and that's the mesenteric vessels shifted. You can see the clip. Oh, the image is gone. You can see the clip. all the vessels are shifted, and this part is showing no vascularity, and this was a large abdominal teratoma. So remember, sometimes out of the box. And I'll show you a few cases which mimic pathology and which are out of the box. So this is the differential diagnosis of small stomach and polyhydramnios. You can have nasopharyngeal tumors, we already saw. You could have cleft lip. You could have laryngeal stenosis, Pierre-Robin's, Treacher-Collins, muscular defects like muscular problems like arthrogryposis and other conditions. So this is a full differential diagnosis of stomach not being visualized. But of course, our main concern is esophageal atresia. So the moment we don't see a stomach shadow, the next thing we like to see is the neck. And if we see a pouch sign, that is a dilated cystic area in the neck, which is a typical dilated esophageal pouch, below which the esophagus is atretic, this is called the esophageal pouch sign. It is 100% specific for esophageal atresia. The problem is it is not a sensitive sign. It is seen in only 30 to 40% of cases. And sometimes you may need to do even an MRI to see it, because it may not be seen on ultrasound. So it's a very specific sign, but poorly sensitive, and it may not be seen all the time. So these are, of course, all the different types of esophageal atresia with T fistula. Type C being the most common with a distal T fistula, and that is the culprit for which secretions from the trachea may go into the stomach, and you may see the stomach shadow, and you may miss esophageal atresia completely. So in fact, whenever I have severe polyhydramnios, I always write, please note, a TE fistula, isolated cleft palate, or a very small cardiac shunt may be missed in this scenario. It's always written in my report as a rider, and I suggest you should also do the same. So type 1 has the poorer prognosis than type 3, but type 3 is the most common condition. So that's the normal trachea, and you can see that small white shadow with a black lumen behind is the esophageal shadow. So detection rate of esophageal atresia by ultrasound is very poor, almost 10 to 40%. Although the positive predictive value is better, and that is because a majority of them have an associated fistula, and absence of stomach is rare. Polyhydramnios develops late in the second and third trimester. The prognosis depends on the type of the atresia, which we cannot tell antenatally, the length of the esophageal defect, which again we cannot measure antenatally. You can measure it on MRI. And of course, associated anomalies, which we can see, the bacterial anomalies, they can be associated with aneuploidy, as you can see here, and therefore amniocentesis is definitely necessary to rule out trisomy 18. And the neonatal survival, if it is an isolated defect, is 95%. Of course, there can be problems of tracheomalacia and etc. But important thing is whether it's isolated or not. And first important thing is detection. So that's an absent stomach. This fetus was associated with severe associated abnormalities. You can see there are hand abnormalities here of syndactyly and agenesis of ductus venosus. So failure to identify a pouch does not exclude esophageal atresia. So there have been a lot of interesting articles in the research where people have seen different techniques to try and diagnose esophageal atresia without the esophageal pouch sign. And this is one of them. So this, one of the authors has suggested is that you look at the trachea in the sagittal section. It's a normal tube, and if you find some dip in the tracheal shadow, then that is called a print sign or imprint sign. So what is the mechanism? It is that if this part of the esophagus is atretic, this part of the trachea will herniate, and it will go into that gap, and the moment you see this kind of dip, then you should suspect a tracheal, a kind of esophageal atresia. So that is shown in the cartoon there, and here you can see that's the way it looks. So the trachea will herniate, and instead of the pouch sign, you may want to see this on a sagittal section. So that's a fetus with absent stomach. That is the pouch sign here. And on the sagittal section, there you can see that there is a slight herniation of that tracheal shadow here, suggesting that this is the area of the esophageal atresia. You can see that slight bulge out there. And why is that important? Also to measure the length of the atresia. So you can probably measure, but it's not very, very accurate. So you can see this is the bulge here that we are seeing, and that is the lumen of the esophagus above it. We had a pouch sign, so we knew we were dealing with esophageal atresia. So that is the segment which is atretic. So it's quite a logical sign, but not seen always, because you need the fetus to be sagittal and looking up. If the fetus is prone, then it becomes difficult to see that sign. Now here is another fetus with absent stomach shadow, and this clip is not working, but here again you can see the same finding. There is herniation of the pharynx, severe herniation that is seen here. So that's the same fetus. I think this is the clip. There's polyhydramnios and marked polyhydramnios. So severe polyhydramnios is the hallmark. Okay, it's only showing polyhydramnios. So if you don't see a pouch sign, then it is recommended that you do a fetal MRI, and this is an important another sign where you see a biconvex appearance of the pharyngeal fluid shadow. Normal is like this, parallel, and if you see it like this, then that suggests that this could be a distended fetal hypopharynx, a sensitive novel sign for prenatal diagnosis of esophageal atresia. This has been described on MRI, but I think even on ultrasound we can attempt to do this. So as I said earlier, the sensitivities are very low. The specificity is high, positive predictive value 100%, small stomach 75%. Polyhydramnios has high sensitivity but low specificity because many conditions can be involved. So you can only suspect and follow up this condition. Please do an MRI if you are not seeing the pouch, and this may be helpful. Now that is an MRI. You can see here that that is the esophagus here, that white shadow here. That is the trachea which is dilated, and you don't see that segment of the esophagus. So that is a good way of looking. Some people have also done dynamic MRI during swallowing, and you can see increased peristaltic activity in the esophagus, and that is the pouch sign, and then you don't see the esophagus, and you can actually measure the length of the esophagus. So that is important. Now here is another mimic, so another brain teaser. You can see a fetus with polyhydramnios, and you are seeing this cystic shadow here, small cystic shadow. So is this a TE fistula with esophageal atresia? Polyhydramnios, very small cystic shadow looking like the stomach. And we were completely fooled because we said this is esophageal atresia, there is polyhydramnios, and the stomach is seen, so, and this turned out to be a duplication cyst of the stomach. So sometimes you can be really fooled, and they continued, and this was actually a duplication cyst. Now this is while we are looking for the pharyngeal pouch, sometimes you come up with very rare diagnosis, but very useful antenatally. This was a great pickup. As I'll show you, this was a fetus with polyhydramnios, and what do you see here? Any particular, is that a pouch sign? So what are you seeing? Can you see that small cystic lesion here at the base of the tongue? It is compressing the pharynx. You see the pharynx behind is almost slit-like. And then you see more images. Yeah, so this is at the base of the tongue. It is more towards the vocal cords. And you can see that, look at the way it is compressing the pharynx. The pharynx has become very narrow. And in all the images, and there are some more images, you can see that better now at the base of the tongue. And so the important thing was, that is the magnified image. This was very important to tell the pediatrician and the pediatric surgeon, because this can cause severe stridor at birth because there is compression of the pharynx, and this was a vallicular cyst. Look at that same cyst antenatally, and this is at birth, how big the cyst looks at birth, and the fetus was having severe stridor and breathing difficulties, and the ENT surgeon had to be called in because we knew there was a cyst. They were kept standby, and with the laryngoscopy they punctured that cyst, and they excised it. And this is a vallicular cyst which causes due to obstruction of the mucosal glands at the base of the tongue, and the mucous secretion continues, the lesion increases its size and causes obstruction and polyhydramnios. So the differential diagnosis, of course, all the other tumors, the teratomas, etc. Appropriate counseling is required because you need to keep the ENT surgeon ready for intubation and laryngoscopy and excision. The entire cyst has to be removed. Recurrence is likely, so they have to very carefully remove the entire cyst, and the fetus has to go for an elective LSCS, and you have to keep the placental cord undivided till you excise the cyst, because otherwise the fetus can go into severe hypoxia, and that's what they did. So this is done under LSCS, under tocolysis, while the oxygen supply is still maintained through the placenta, that the laryngoscopist could remove the cyst. So this was a very important antenatal diagnosis to do. The other most common fetal atresia that we see is, of course, the duodenal atresia. And we have three different types. Type 1 is the duodenal diaphragm. Type 2 is the complete duodenal atresia. Type 3 is the complete separation of the two ends due to an annular pancreas. So you can have different pathologies. You can have atresia, stenosis, membrane, mid-gut rotation causing band due to a band of lard or a volvulus, or an extrinsic obstruction due to an annular pancreas or a choledochal cyst. What we of course see on ultrasound in a typical case is the characteristic double bubble sign. So distended stomach and distended duodenum, and this is something we usually don't miss. So diagnosis is easy. It can be a late manifestation because the fetus has to swallow, so you will pick it up more in the second trimester, and polyhydramnios occurs late. So usually we don't wait for polyhydramnios. We usually see the stomach shadow, look for an extra cystic lesion, and look for duodenal atresia. It has very common associations with trisomy 21, so we do a fetal echocardiography, amniocentesis, etc. Now, if you see a double bubble, we are suspecting an atresia, but if you see the entire length of the duodenum, you can see the entire loop. This is what we would normally see with a band of lard. So this was a case of a band of lard. And you can see here all the segments of the duodenum are distended, 1, 2, 3, and then you have this typical appearance of a rat tail sign. So that is typical of annular pancreas. So when you have a rat tail sign, you can see here that the entire duodenum is distended. So, so all the different types, you have atresia, you have band of lard, and this was a annular pancreas that we were seeing. Associated abnormalities are high, skeletal abnormalities. You can have other atresia associated with a duodenal atresia. And of course, cardiovascular, genitourinary, trisomy 21 in 30%, and IUGR will be seen in 50% of cases. If you have a single atresia, remember there can be multiple atretic segments. This was a very interesting fetus we had where we picked up a duodenal atresia, and this fetus also had the pouch sign. You can see the pouch sign here. So this was an esophageal atresia with a duodenal atresia. Both the atresias were corrected at birth. It's a very sad story, and therefore I wish to tell it for prospective mothers. After correction on the, I think, second month, the parents called us for the first second month birthday celebration, and 4 o'clock in the evening I get a call, we're very sorry, the party is cancelled because the baby has died. So we're wondering what happened, why the baby died, and unfortunately while feeding, the mother slept on the baby suffered hypoxia and the baby died. This is so sad. Double atresia, you picked it up antenatally, corrected it surgically, and because of probably lack of sleep, and this is quite common, we think of it, but it's quite a common problem. So this was one of the very sad stories that we had. Another mimic for you. What is this? Duodenal atresia? Does it look like duodenal atresia? Yes, because there is double bubble, right? So typical double bubble. Is not communicating. So you see here, that's the duodenum. So you turn the probe a little bit and you can see that that's the duodenum and that's a cyst, and this was a duplication cyst of the duodenum. So moment you see double bubble, don't jump to the conclusion. You need to see it following up that it is communicating, as with all the other cases of annular pancreas and band of lard that I showed you. You can see the entire communication. And here you don't see the communication. So the moment you turn the transducer, that's the triangular duodenum there, and that was a duplication cyst of the duodenum. Now finally, to round up, so that was as far as upper GI. I was told to cover only upper GI, but 1 or 2 cases, because this also leads to dilatation of the upper GI system, and this is the volvulus. So normal, we know that at 10 weeks we have the retraction of the bowel from the umbilicus, and it rotates and comes back, but sometimes there are adhesions which form and which do not allow the complete rotation, or the bowel undergoes a twist, and this can lead to a volvulus. So before that, before the volvulus, as with the duodenal atresias, you can also have small bowel atresias. They also present with polyhydramnios, although a little later in the second, third trimester, and you will see dilated bowel loops with associated distension of the stomach and duodenum. So diagnosis is quite easy. The moment you see more number of dilated bowel, you know you're dealing with a distal obstruction from the duodenum. It's a small bowel obstruction, and you can have multiple atresias at the same time, or a single atretic segment, very difficult to make out on ultrasound. And even at MRI, at times we have sent the patient for MRI and they just say atresia, they just follow, most of the times they mimic an ultrasound report. But here is a case where we were certain there was dilatation of the bowel here, you see. So any bowel which is more than 7 to 8 millimeter in diameter or more than 15 millimeter in length, we always suspect. These are not specific signs, and sometimes it just reverses. So we need to follow up most of these cases of atresia. This we were sure because this was persistent dilatation of the bowel, but a couple of weeks later, the entire dilatation had disappeared. So this was, of course, something that you need to keep a watch on. Now, what is this? This is another mimic. So you are seeing stomach and you're seeing cystic areas. What do you think this is? Multicystic kidney. So be careful that all cysts that you see along the abdomen are not bowel. This can be a stomach and a multicystic dysplastic kidney. So I think finally I will skip these slides on MRI, because these are essentially used when you're dealing with polyhydramnios. You're seeing some bowel loops dilated, and you need to do an MRI to rule out this syndrome called the megacystis microcolon intestinal hypoplasia syndrome. So the moment you see a distended bladder with polyhydramnios and you're not seeing the bowel, you need to rule out this syndrome, because you will not be able to see the intestines in this situation. MRI may be useful. So you can see on MRI, you are seeing very small atretic areas of the bowel. Now finally, this was what I was talking to you earlier. If there is a lack of rotation, or if there's a malrotation, or if there's a band, as I showed you earlier, that case of band of lard, this is the case of band of lard obstruction. You can see the typical C-shaped complete dilatation. But more than that, suddenly if you have a fetus which is very hypermobile, moving a lot, polyhydramnios, then do suspect volvulus, and this is what you will see, the typical donut sign. You will see dilated bowel loops, and in the center you will see this donut sign, and I think I have a clip here. Oh, this clip is got overlapped a bit. Let me just do something about that. So that's how it should be. And so the moment you have dispersion of bowel like this, and then you have this central kind of donut appearance, you suspect a volvulus. And unfortunately, we lost this baby because the bowel was severely gangrenous, and we couldn't salvage this baby. So many of them, after an atretic segment, may rupture, the bowel may rupture, and it may form meconium peritonitis. There's of course a differential diagnosis. It can be iatrogenic, it can be fetal infections, it can be due to some vascular impairment, or an atretic segment. And what we actually see is ascites with multiple echogenic areas. You can see a lot of echoes, and then it forms a cyst with calcification, that is a pseudocyst. You can see here large pseudocysts, and the prognosis can be quite guarded, because if there are multiple atretic segments, there might be a large amount of bowel loss at surgery, and it all depends on how much bowel is involved in this, and this is finally a calcified pseudocyst, and you can see that both in MRI also. So this is another case. I don't know, the clip is not working. So case of polyhydramnios, but all the bowel loops were distended equally. In atresia, you will have bowel loops which are distended asymmetrically. But this here, all the bowel loops was symmetric in their distension, and this is typical of congenital chloride diarrhea. It's it causes severe electrolyte disturbance, and again, the pediatrician needs to know about it, because it can be quite a life-threatening situation. So in conclusion, the important clue to diagnose of upper GI abnormality is the amniotic fluid status. Usually they will present with polyhydramnios. You need to have very accurate diagnosis, and multimodality approach should be used to have the location of the defects. You may not be able to tell how many number of defects are there, but at least some attempt with MRI, etc. Associated malformations are very important to pick up, because chromosomal abnormalities may be associated. Therefore, we need to resort to an amniocentesis. The age of onset of disease is important. The earlier the onset, the worse is the prognosis. Age of delivery and growth restriction also impact on the outcome. So if it's, do not attempt to have a premature with growth restriction, they can cause a lot of problems due to lung immaturity. And of course, specific prognosticating factors will depend on the individual pathology and progression. If there is progression over time, then that is worse the prognosis. Disappearance over time, as we saw, is better prognosis. So thank you. That was my last lecture, and I thank you for a very, very hospitable presence here, and I look forward to further interaction. Thank you to the family of Narayan. They did a wonderful job. Thank you very much.
Thank you, sir. I request everyone to please step out for lunch, and sessions will continue post-lunch. Thank you.
Now, can you get the picture on the monitor there? Picture on the monitor, the ultrasound picture. However, we put these off, look at the, yeah. Machine picture, ultrasound machine picture.
Good afternoon, everyone. Good afternoon. Where Dr. Ramamurthy sir is going to be scanning on our latest HERA Z20 product. So wanted to talk to you about this latest ultra premium ultrasound called Z20 or Z20. I have a short video. Okay. Z20, as we were saying, is an ultra premium product with basically, typically in an ultrasound, the lateral resolution, uniformity and the frame rate are in competition with each other. With this system, with the second generation software beamforming, you are able to get all the three together: resolution, penetration, uniformity and frame rate. We have various AI-based tools which helps you. Typically for an anomaly scan, which would go from 30 to 60 minutes, because you are looking at various views and trying to measure, annotate, freeze, all of this. Here, the moment you sweep the system from the head to the toe of the fetus, it's able to identify which plane you are in, take the measurements, give the annotations, and you can see on the right hand side that it has already saved these images. It looks at the anatomical landmarks, for example, for BPD, cavum, septum pellucidum, or thalami as a landmarks, and identifies that this is the correct measurement plane that you have taken. On the left hand side, you can see that there is a checklist of the different views as given by the ISWA guidelines. So the moment you have completed, there is a tick mark. You can very easily identify which other scans is missed out, so that you can focus on the same. Especially if the fetal position is not appropriate. It will take you a lot of time, and this ensures that one sweep you're able to get all the planes and need not wait for the baby to move to the appropriate position. So this shows that within few seconds, 3 keystrokes, all the measurements are completed. In the case of manual, it's still going on. So almost 72% savings in the time for first trimester, second trimester, as well as third trimester scans. This is an easy check. This is completely customizable by you. As per this, we have given as per ISWA guidelines, but yes, you can customize as per your protocol as well. This is a very interesting feature called easy volume. When you're taking a volumetric measurement, it's very difficult to maneuver to get the fetus or umbilical cord or placenta. This is going to identify different structures, and selectively you can see whatever you want. For example, I only want to see placenta, that's possible, only umbilical cord or only fetus. That's something that you can do because the system intelligently identifies different structures. The next step is giving you volumetric quantification. So in this case, you can see that the fetus volume is provided and the placental volume as well as AFI. These are more accurate because this is based on the volume data, and the system very intelligently is able to identify. And because of paucity of time, this is the last slide I will talk about. We have an easy structure. System again is based on an AI, identifies which organ or which view that you are scanning, accordingly applies all the automation, customizations in terms of optimization in the scans. For example, it be PRFs or depth or any of those provided. So that's about it from our side. This is, as I said, available in Samsung stall. We would be very happy to take up any queries that you have. Looking forward to your visit. Thank you so much. Thanks for your time.
I have to introduce our subject for today. She is a lady who is about 22 years old, and she is a second gravida. Her first frequency on this machine as on now. So I have chosen my transducer and I do my survey scan. So up and down, down, up, down, up. So immediately in a couple of seconds, I know that the head is up, the breech is down, and one thing I'm sure is that it's a single gestation, it's a fetus, so it's comfortable. I can see the heartbeat, like a volume is normal, placenta looks normal. So I have got my bearings. Now once this is, the head is up and the breech is down, I put myself in the fetal position, and I know when I put myself in the fetal position that this is the left hemisphere, this is the right hemisphere. I'm already zooming down on the head. This is left and this is right. So with this orientation, let's begin a mid-trimester anomaly scan. I'll take off the arrow and I'll go real time. So my idea first is to get that ISWOG requirement. What is the ISWOG requirement? ISWOG requirement is I need 3 planes, transventricular, transthalamic, and transcerebellar. So I start with the transventricular plane. I'm doing real-time live scanning, and when I feel that yes, the ventricle has come well, the CSP is brilliant, I freeze. So you can see that I have frozen this image. Why? Because I see a nice CSP and I see a very good definition of the far ventricle. The near ventricle, as we all know, is hidden in reverberation echoes, right? Now I will freeze this, I will store it, and then I can go real time, and then we will discuss what is a checklist. Checklist is extremely important because unless I've got it, I've used my skill, I've got the transventricular view, but I should also know what to see to call it normal. What am I going to study in the section before I certify this section to be normal and move on to the next section? So that is important, and the checklist for transventricular, transventricular or any other brain section should be systematic. You can either start from the midline and move towards the periphery, or start from the periphery, move into the center. So what I will do is to go from the center to the periphery, and I'm trying to get a good CSP and a far ventricle, which is good. Okay, for discussion's sake, I will use what image I get now. My gain is okay, I'm happy with the maps, the optimization is fine. There's no time to do optimization. This machine, as I scan, has been optimized. So we will go to the transventricular view and we'll look at the checklist, right? So as I said, you can start from the midline and go to the periphery. When you start in the midline, we must first acknowledge the presence of the anterior interhemispheric fissure, posterior interhemispheric fissure. Then you must acknowledge the presence of the CSP, presence of the anterior horns. Can I go to the, we'll take another picture. This is the last one, isn't it? Okay, or yep, okay. So you will see that anterior interhemispheric fissure, posterior interhemispheric. This is CSP. The CSP is the CSP because of these two. What are these two structures? Loudly. No speaker here, I can't listen. So are people answering anterior horn or frontal horn? Am I right?
Yes, sir.
Yeah. So the anterior horns are immediately lateral to the CSP. A CSP is not a CSP if the anterior horns are not there on either side. Let me increase the gain. Can you see the anterior horns?
Yes, sir.
Can you see it there? Yeah. So this indeed is a CSP, and having known that the CSP is present, we'll come to the details of the CSP in another magnified view that's called the anterior complex. We will store this. This is already stored, no? It's stored, okay. We'll come to that. So after looking at the CSP, the details of which I'll come to a little later, we move outside. Two anterior horns over, CSP is over. Then we move outwards. When we move outwards, let us look at the far hemisphere because it's better seen. When we move outwards, you will see the subarachnoid space on either side of the midline. That's full of CSF. And then you will see the medial surface of the cerebral hemisphere as a white line here. And why is it white? Because the pia mater is clothing the brain here. Wherever there is pia mater, ependyma or choroid plexus, it becomes hyperechoic. So for example, this is ependyma lining the lateral ventricle, medial wall of lateral ventricle. Brilliant. This is pia mater, looks brilliant, especially when they are perpendicular to the line of transmission of ultrasound. Having said that this is the medial surface of the brain, this thickness between the ependyma of the medial wall and the pia is indeed the medial parenchyma of the brain. Which lobes? This is what lobe, everybody? What lobe?
That is temporal, occipital area.
Occipital lobe, correct. So this is the occipital lobe. So this is the medial side of the occipital lobe. And then you have this, which is the medial aspect of the parietal lobe. How am I confident that this is parietal lobe and this is occipital lobe? Anybody?
Occipital horns are in relation.
No. You see the gentle...
Parieto-occipital sulcus.
Excellent. Parieto-occipital sulcus. Can you see that slight dip there?
Slight dip, sir.
Slight dip. This is only 20 weeks, 6 days. I don't expect anything more. That is why gestational age is important. So you see a small little dip over here. That tells me that the parieto-occipital sulcus is developing in this location. And therefore, why is it called parieto-occipital? It separates occipital lobe posteriorly from parietal lobe anteriorly. So it's called parieto-occipital. So this is the medial surface of the cerebral hemisphere, parietal lobe, occipital lobe. Then I work my way around. This is the occipital cortex. You can see the occipital horn ependyma, not very bright because now it is collinear. The ependyma is collinear. And then again the ependyma becomes slightly hyperechoic because it becomes perpendicular. And this, just as this is the medial wall, this is the lateral wall. So this is the lateral wall of the lateral ventricle of the posterior or the occipital horn, and you see the plug of the choroid. Very well, wall-to-wall plug of the choroid. Then after that, you leave the lateral wall and move outwards. Remember, the general direction of movement is from midline to the periphery. As you run the eye and do your checklist in day-to-day practice for every case that we do. So this is the lateral wall of the lateral ventricle. Move outwards, you will see the cortex over here, the parenchyma, which is both white matter and the gray matter of the cerebrum. So you see this thickness indeed is the convexity parenchyma of the cerebral hemispheres. And here you see the thin line inside is the pia mater on the convexity. Just like this is pia mater on the medial side, this is pia mater on the outer side or the convexity side. And outside of that you see hypoechoic layer, subarachnoid space, and then the calvarial bone. That is the way you move from midline outward, layer by layer. You don't have to give a commentary in your everyday MTAS because there's not going to be no audience, there's not going to be any giant screen, but you have to run this picture in your own mind within a matter of seconds and move on. So when I do that, I suddenly see that there is a depression over here.
Lateral fissure.
That is the lateral fissure, and for 20 weeks, 6 days or 21 weeks, this is perfectly normal. So the lateral fissure would separate what from what? Just like the parietal fissure, parieto-occipital separated occipital lobe from parietal lobe, this separates what? Any answers? What lobe is this?
That's frontal.
Frontal. What lobe is this?
Temporal.
No, it is not temporal. You don't get the temporal. Parietal. You don't get the temporal in the transventricular view. I'll show you when to look for the temporal. So this fissure separates out the frontal from the parietal, and ultimately you have a frontal operculum, you have a parieto-temporal operculum this side, and we will come to that if we have an older fetus. So that's the lateral fissure which demarcates frontal from parietal, and you have the, what is this? Pia mater on the frontal parenchyma, yes or no?
Yes, sir.
Yes, and then what is this space?
The subarachnoid space.
Wonderful, subarachnoid space, and your study of the far hemisphere is over. Yeah, it took so long, I took 10 minutes to explain, but it takes less than 5 seconds for you to observe this. Am I exaggerating or is it true?
True, sir.
Very true. Not only true, very true.
Very true, sir.
Yes, so you see the occipital cortex, you see the subarachnoid space behind the occipital cortex, and this goes, the fox cerebri or the interhemispheric fissure posterior goes, and it divides into 2 leaves enclosing what?
That is superior
sagittal sinus. Superior sagittal sinus as it goes down to the torcula of the fetal brain, right? Now the challenge is that I have done so much for the far hemisphere, I feel I am unjust to my 2 children. I have seen one child very well, but the other child is not seen. So your duty is to look at the near hemisphere, and what I will do now is to actually show you the maneuver wherein you move from transventricular. I am going live again. This is transventricular. You can see that the far hemisphere very well seen, but the near hemisphere not well seen. Now what I do is move the probe posterior and angulate. What do you see now?
Yes, the near ventricle also well.
Near ventricle well seen. Well lateral seen. Wall, medial wall, plug of the choroid and the cortex, right?
Yes, sir.
What do you feel? Are the hemispheres symmetrical across the midline or asymmetrical?
Asymmetrical.
Pardon me?
Asymmetrical.
Hey, come on, yeah.
Now, it is obliquely placed.
No, very oblique or slightly oblique or parvane, parvaledu?
45 degrees around.
Would you say parvaledu? I don't know my Telugu. My mother tongue is Telugu, but it's Karnataka Telugu. Oh, is that the right word? Parvaledu? Correct,
yes, sir. Yes,
okay.
Sir.
Because coastal, I feel nervous to open my mouth in Telugu. Okay, so this is tolerable. So I can easily say eyeballing that this is normal ventricle, abnormal ventricle.
Normal ventricle.
And it's almost symmetrical, so I can, even if I want, I can measure it. I'm not going to show you measurement. I know this audience is fantastic. They know how to do the measurement. We know how to go at the parieto-occipital fissure, inner wall to inner wall, perpendicular to the
wall of the ventricle.
Wall of the ventricle, right? And if you don't forget your rules, you have to use your zoom box before measurement so that you get a zoomed picture, and then you can go internal to internal, perpendicular to the lateral wall at around the parieto-occipital fissure. If you don't have the parieto-occipital fissure as a landmark because it's a young fetus, just go outside of the glomus of the choroid plexus. The glomus of the choroid plexus, you can see the magnification view of the crosshair. I'm going to the inner to inner, and this is perpendicular to the lateral wall. Simple, and the answer is 5 millimeters, normal, no problem. Okay, you can do that. So that is how simple. I'm going to repeat the maneuver. Here is a classical transventricular plane, near ventricle not very well seen. Now I come posteriorly and angulate. See how nicely you see it. Are you convinced or not convinced?
Convinced, sir.
Very convinced. You want me to repeat? I can repeat, because you have to know that this is not one-off chance. Every time you do it, you will get it. In an obese patient, it's very hard, but here I'm really blessed today to see Madam N, because Madam N is 34 kgs, right? So I'll repeat it again. This is transventricular. Go back, angulate. It comes. It's not a coincidence. It's a purposeful, very deliberate procedure. You can see the near ventricle. No excuses. If you don't do this in your mid-trimester anomaly scan, you haven't done your basics right. Please, please remember. And again, to show you the midline echos and to show you how nicely the pia mater is delineating the medial surfaces, and you see the subarachnoid space. So quickly from here, we'll go to the anterior aspect again, and I will take you through the concept of anterior complex. Is the image seen? Is it too much bright, or do you want me to reduce the gain, or is it okay?
Slightly reduce the gains.
Now?
Yes, sir.
Now, yes, thank you. So what I do is to put the zoom box and zoom on the
anterior complex,
on the CSP. Having done that, I will look at the anatomy of the CSP. What are these two?
Frontal horns of lateral ventricles.
Okay, who is interacting with me? Yourself, introduce yourself, please.
Sir?
Tell me your name, yeah, come on.
The frontal horns of lateral ventricles.
Okay, doesn't matter. Frontal horns of the lateral ventricle, wonderful. Now this is what? Dr. Naidu,
sir,
you answer from the patient, you get the answer from the crowd also, please. So if this is the cavum septum pellucidum, what are these two called? This is CSP. What are these two lines called?
Leaves of the septum pellucidum.
Septi pellucidi, because there are two of them. You're absolutely right. Instead of septum pellucidum, I'll use septi pellucidi. Agreed?
Yes, sir.
Okay, two septi pellucidi. Now look at them. The same septum pellucidum is the medial wall of what?
Frontal.
Frontal horn, correct. And the same septum pellucidum is the lateral wall of what?
CSP.
Correct. That you have to note. If there is a distance between the anterior horn and the so-called CSP, the so-called CSP is not a CSP, right? So we've sorted out this way. Now let's come this way. So here what you see is the anterior interhemispheric fissure, and then it stops abruptly. Agreed? Disagreed?
Yes. Yes, sir.
Why has it stopped abruptly is the next question.
It is interrupted by the CSP.
No.
Because
no. Because of what? CSP is
corpus.
Excellent. Corpus callosum. Which part of the corpus? Genu, you're right. Genu of the corpus callosum. And if I increase the gain, I want you to tell me, is the genu seen as a little hyperechoic structure? Compared to the fluid here, can you appreciate the difference here or no?
Yes, sir.
Yes, but doesn't matter. So the moral of the story is the genu of the corpus callosum looks almost as hypoechoic as the fluid inside. Yes or no?
Yes, sir.
So let us say that the genu is difficult to be seen. I want you to see, very easily seen, what are these two?
Sulcus. Callosal sulcus.
Callosal sulcus. This is the interhemispheric fissure. These are the callosal sulcus on one side, callosal sulcus on another side. And why is it well seen? Pia mater again.
Yes,
so answer my question. Is the genu seen easily or the callosal sulci seen easily?
Callosal sulcus seen easily.
Second question, if the corpus callosal genu were to be absent, would there be callosal sulci?
No, sir.
Excellent. Did the audience understand the logic? So for me, if I see the callosal sulcus, even if I don't directly demonstrate the presence of genu, I know that the genu is
present in direct side.
That's it. That is the value of seeing this T-shaped structure, callosal sulci. This is the genu, this is the cavum or the cavity of the CSP, and once you come posteriorly, you see the two fornicial columns. One fornix, the other fornix, and that completes your anatomy. So don't see the CSP as the CSP alone. Look at it as the IHF, callosal sulci, genu, septum, cavum septum pellucidum, and anterior horns. If you add all this into your algorithm, you can call it anterior complex. So the teaching is do the anterior complex and not the CSP as the CSP alone. So with this we move on to the next view, and the next view is transthalamic. In the transthalamic view, what I do is I sacrifice the ventricle, but I preserve the corpus, the cavum septum pellucidum. So what I do is, as the name tells me, it's transthalamic. So the importance goes to the, fill up the blanks.
Thalamus.
Thalamus. So hook or crook, I'll get my thalamus. In the process of getting the thalamus, I have lost what? I have lost what? Lateral ventricle I have lost. But I am also seeing part of what?
Cerebellum.
Cerebellum. So this is a wrong transthalamic view. I am purposely creating mistakes so that we don't do it when we are in clinical practice. So a transthalamic view should be taken without any part of the cerebellum coming in. You have to get the thalamus and the CSP, yet avoid the cerebellum. So here what has happened is I see the CSP, but I don't see the cerebellum, I don't see the ventricle. I don't bother about the lateral ventricle now, but my mind, my conscious tells me that I should get a better CSP. So let me try. It's real time, so no problems. I'm going to try, because these basic sections are very, very important. Now tell me, are you happy with this? Are you happy with this?
Okay, sir.
What do you see here?
Yes, sir.
CSP?
CSP.
Do you see the thalami?
Yes, sir.
What is this white line between the two thalami?
Interhemispheric fissure.
Interhemispheric, not interhemispheric fissure.
Yeah, third ventricle usually.
This is one thalamus, this is the other thalamus. So this is?
In between third ventricle will be there.
Yes, so this is the third ventricle, also called the thalamic, interthalamic fissure. It's not the interhemispheric fissure, it's the interthalamic fissure, broad thalamus anteriorly, tapering down posteriorly. So the arrow of the thalamus points towards the occiput. So I have sacrificed the lateral ventricle, but I have gained a beautiful picture of what?
Sylvian fissure.
Sylvian fissure. And look at the basal ganglia. This is a detail which you need to know, not as a part of the checklist. You don't do it, but you need to know some anatomy over here, right?
Yes.
And what is the anatomy? What is this structure, doc?
Basal ganglia. Caudate nucleus will be there.
No. What is this, what I am showing?
Frontal horns.
Frontal horn. Now the frontal horn is indented by a certain structure.
Caudate nucleus.
No. Complete it.
Head of the
caudate nucleus. Am I making you imagine, or you can see it?
Yeah, appreciating, sir. Round structure.
What about all our colleagues in the audience? Loudly.
Yes, sir.
Wonderful. And what is this big thing here? What is all this?
That's globus pallidus.
No. What is this?
That is interthalamic fissure.
So what is this?
Yeah.
What is this? If this is interthalamic fissure, what is this? Thalamus. What is this? Thalamus. So this is the thalamus. This is the caudate nucleus. What am I angling at? Anybody tells me?
Yes, sir.
I'm showing you the head of the caudate,
yes,
and I'm showing you thalamus. Why am I only showing you those two? Customized Paraleda, you're enjoying? Oh, she's also appreciating. Okay. Okay, if this is the caudate and if this is the thalamus, why am I asking you? Anybody?
Oh, caudothalamic germinal matrix.
Excellent. This is where the germinal matrix is. No textbook will give you this, but this is common sense. This is the caudate, thalamus, this is the caudothalamic groove. So not always you will be able to use a high frequency probe, and not always do you get a 34 kg patients. In fact, the more common patients you get is 134 kg patients. Isn't it? So you may not see all this, but remember the caudothalamic groove is actually posterior end of the box of the thalamus or the anterior end?
Posterior.
Posterior end. However obeys our lady is, you will see the CSP, yes or no?
Yes, sir.
You go to the posterior end of the box, and even if you don't see the caudate and the thalamus, that is the caudothalamic groove. If you are wanting to rule out hemorrhage, germinal matrix hemorrhage, you want to, or you've seen a hyperechogenicity and you wonder where it is here, that is the caudothalamic groove. Now once having realized that this is caudothalamic groove, you have the internal capsule over here, posterior, genu, anterior limb, and this triangle is what? The lentiform
nucleus,
which is composed of
globus pallidus,
and putamen. Excellent. Globus pallidus and putamen. That is the lentiform nucleus. This is the cortex outside of the basal ganglia. You have the claustrum and the external capsule over here. This will be the future insula, and this will be the lateral fissure, and this is the, is it clear?
Yes, sir.
This is not a part of the checklist, but it's nice to know this anatomy. So this is the transthalamic, and in the transthalamic you use it to look at these measurements, both the BPD as well as the head circumference. Head circumference, avoid the scalp thickness and do a OI BPD, and also outer ringing without the scalp of the HC. If you are using OI, then you have to use OI tables. So this is basically a plane of measurement. You don't add anything in terms of anatomy, and quickly from there, from the transventricular, I'm moving very subtly, you get the transcerebellar, transcerebellar superior, very important, and transcerebellar inferior. Both of them you should store. Transcerebellar superior, no fourth ventricle. Transcerebellar inferior, you see the fourth ventricle, right? So let's look at the posterior fossa. Dumbbell-shaped cerebellum, hemisphere, hyperechoic vermis. Dumbbell-shaped cerebellum, hemisphere, vermis. Hyperechoic vermis separating fourth ventricle from, fill up the blanks.
Cisterna magna.
Cisterna magna. Fourth ventricle is wider than longer, whereas CSP is
longer
than
wider.
And remember, even in the transcerebellar plane, you have to preserve the CSP. Very, very important. And once you see something, you can measure outer to outer. You can take the transverse cerebellum. Yeah. So that is the cerebellum, and it's grabbing by itself. You see it's 2.16, which is equivalent to 49th centile. Normal, store this. Always store with measurements, store without measurements also. Cerebellar size is normal. You can see the foliae. Can you see the foliae?
Yes.
Yeah, those are the foliae.
Cerebellar foliae.
Yeah, foliae of the cerebellum, and that is the vermis and the fourth ventricle. Now the other thing which we must realize is your transcerebellar is a transcerebellar only if you produce a good picture of the cerebellum with a preserved CSP. Otherwise, no full marks. So
it's not valid.
It's not valid, right? So therefore, you go back and then you will see my CSP also is seen, cerebellum also is seen. So I know that this is good, I can freeze it. So in addition to the posterior fossa, remember transcerebellar plane takes you through the anterior as well as the middle cranial fossa. And if somebody asks you, how do I study the temporal lobe and the temporal horn, your answer is transcerebellar view, and we will see how it is done. So I am getting a transcerebellar view. Are you convinced this is transcerebellar?
Yes, sir.
Yes. Now look at this.
That is
This is the temporal lobe,
temporal lobe.
and this is the medial temporal cortex or the lateral temporal cortex?
Medial.
The medial temporal cortex indeed is the hippocampus. This is what? The temporal horn of the lateral ventricle. It's also known as the inferior horn. And between the medial surface of the temporal lobe and the lateral surface of the cerebral peduncle, you have fluid there. And
Ambient cistern.
That is the ambient cistern. Very good. That is the ambient cistern, and this is the anatomy of the middle cranial fossa that you can see. And then, of course, anterior cranial fossa, we know the anterior complex, and again you have a good view of the lateral fissure. So with this, I almost took half an hour for the basic sections, but was it worthwhile or was it a waste of time?
More worth, sir.
More
worthy.
More worthy, okay, thank you for that. So now quickly I'll do 2 maneuvers and then I will get on to my lecture because I have to leave in another half an hour. Okay, so this is transventricular. Now this lady has got, the fetus is above, in the sense the head is above. I can't do a transvaginal scan to get at the other sections. So therefore I have to use my real-time skills. I'm hovering on the transventricular plane. So how do I get mid-sagittal? Just watch what I do. I go cephalad, lose the skull. Then I bend down 90 degrees and then I come to the midline.
Yes.
Somebody sneezing. Okay, so you take your time, you get the parasagittal view, you freeze it, and then you go to the mid-sagittal view.
Mid-sagittal.
Are you convinced that I'm able to get the mid-sagittal view?
Now it is, now yes, sir.
So you can choose clips, you can store stills, but don't give up until you get it. There you are. Okay?
Okay, sir.
Quickly, I'll take you through the mid-sagittal anatomy. Rostrum, genu, body, splenium. This is the CSP. This is the tila choroidae. Stops abruptly, anteriorly. Foramen of Monro. This is the interthalamic adhesion of the third ventricle. This would be the tectum or the midbrain. This is the quadrigeminal cistern. This is the vermis. I'm not happy with this. I'll try again. Is this better?
Yes, sir.
Much better.
Much better.
Much better. Store it. Don't let go an image once you've got it. Tila choroidae, it's continuous with the pia mater on the tectum. This is the quadrigeminal cistern. Why? Because you have superior and inferior colliculi. Tectum has 4 collicular bodies. 4 is quadrigeminal bodies. This is the cistern overlying the quadrigeminal bodies, and therefore we call it as the quadrigeminal cistern, which goes seamlessly into the supracerebellar cistern. This is the vermis. This is the primary fissure. 1/3 of the vermis above, 2/3 of the vermis below. Kidney bean shape of the vermis. That is the fastigium. Fastigium. This is the tectal plate. This is the tegmentum. Tectum, tegmentum. In a transvaginal scan, you will see the aqueduct of Sylvius over here, connecting the third ventricle to the fourth ventricle. In a transabdominal, it may be a little hard, right? So in front of the midbrain, you have the interpeduncular cistern. Interpeduncular cistern. You come down from the midbrain, you get the pons, and what is this of the pons?
Belly.
Belly of the pons, the medulla oblongata, right? So you see the kidney bean shape, and this is the entire corpus callosum that you can see. Are you convinced you can do this?
Yes, sir.
Right. And quickly, I'll take you through the coronal sections, and I'm doing it transabdominally again for obvious reasons. So there you are. I'm going. Amma koddiga press chestanamma, loose ga vadilipettu. So can you see the coronal transcaudate?
Yes.
Freeze. Right. And then frontal. Okay. Transcaudate. P1. Transthalamic. P1. And transcerebellar. Can you see the cerebellum?
Yes.
P1. Yes? Those are the 4 coronal planes. With that, I think we will call an end to this workshop because I'm really running short of time. Amma, thank you very much for your patience. Gottayindi kadamma? Nappainda? Yen ledhu kada? Okay, koncham tissues ivamma. Thank you, ma. I didn't get your name. Priya. Thank you, Madam Priya, for your presence and for your guidance. Thank you very much. And Dr. Uma, thank you so much. Thank you very, very much indeed. So we will. నేను తీసుకుంటాను హెవీ ఉంది ఐ టేక్ ఇట్ ఐ థింక్ ఇట్స్ హెవీ గణపతి ఉంది లోపల యా యు బ్రింగ్ ఇట్ ఓకే ఓకే Manju, can I finish my lecture? You're sure? Or do you want to cancel my lecture? రెడీ పెట్టిండాలప్పా వచ్చింది ఆ లైట్ వద్దప్ప ఆఫ్ చేయండి నో నీడ్ వెరీ గుడ్ కెన్ యూ గివ్ మీ ద ప్రొజెక్షన్ ప్లీజ్ duplicate వచ్చింది రాలేదే ఇట్ సెన్స్డ్ ఇట్ బట్ ఇట్ డిడ్ంట్ కమ్ problem, huh? Oh, వచ్చింది. So we look at the lateral ventricles, and the topic says, is ventriculomegaly a diagnosis? Obviously it's not. Ventriculomegaly is like a symptom. Febrile episode is a symptom. Ventriculomegaly is just like that. It doesn't tell us why the febrile episode came, what is the diagnosis. Similarly, why did the ventriculomegaly come? What is the diagnosis? So what is the clues that fetal lateral ventricles give us is the question. We did this already in the workshop, how to get your neoventricle from the transventricular view and how important it is to document in every case, right? This we did already. We know how to get the mid-sagittal view from the axial view, and of course this is a few tricks that you have to use to get good transvaginal cranial images, but I don't think we have time for this. Remember, ventriculomegaly is divided into mild, moderate, and severe. 10 to 12 millimeters, 13 to 15, and greater than 15 is what it is. It's a common entity, so we should know how to handle this situation. 1% of fetuses would manifest with mild or moderate ventriculomegaly. Right? When you say mild or moderate ventriculomegaly, there are certain qualifications that you need to know. One is whether the ventriculomegaly is unilateral or bilateral, roughly half of them unilateral, roughly half of them bilateral. Whether it is symmetric or asymmetric. If you minus the smaller ventricular size from the larger ventricular size, should be less than 2 millimeters. More than 2 millimeters, you use the term symmetric, asymmetric if it's more than 2 millimeters. Then you have to think in terms of stable versus progressive versus regressive. You need serial studies, at least at 2 weeks intervals, to say whether the lateral ventricle is the same as what it was, decreasing or increasing. And lastly, but not the least, the center stage is taken by isolated or not isolated. Extremely important. Because if you find another finding with the lateral ventriculomegaly, you might be actually getting your diagnosis and your job is done, right? So that is extremely important. And here is a case where you have on the near side 10.3, on the far side 5.5. In your practice, in this case, if you had not done the near ventricle, you would have missed the diagnosis. So half unilateral lateral ventriculomegalies will be wiped out of your recognition. So it's extremely important. And here is another case, 23 weeks, 10.7, and at 28 weeks, 0.91. Good or bad? Good. It's regressive or progressive? Regressive, right. So let's look at this as isolated or non-isolated. Mild ventriculomegaly plus any other finding in terms of associated finding would mean non-isolated. In non-isolated lateral ventriculomegaly, counseling depends upon what is the final diagnosis because of the associated features. Now what we will do in this lecture in a very fleety manner is to look beyond the size of the ventricle. I agree that the size of the ventricle grabs your attention to do more, but does the lateral ventricle give you any more clues? Apart from the size, the answer is yes. Size is important, shape, symmetry, margins, content, periventricular zone, or combinations of abnormalities in all of these, right? That's very important, and we know that size is a common way that the ventricle expresses a potential abnormality. Now let's look at the shape abnormality. Here I want you to see the posterior horn is dilated, anterior horn is narrow, no CSP, far placed anterior horns. What are you thinking of? Complete agenesis of? And what gave you the indirect sign? What do you call that? No, the answer is here. Teardrop. So it's a shape abnormality. A shape abnormality has given you the diagnosis of an indirect sign. So your diagnosis is confirmed by direct. And direct is mid-sagittal. Do you see the CC? No. And on coronal, you see the Viking horn, sign, absent, CSP, and of course, no CC body in the direct 22 weaker coronal section in the transcaudate plane. So shape has helped you. Now let's look at this. 19 weeks. Look at the occipital horn. Is it normal shape or is it normal or abnormal? It is angular and sharp, isn't it? That's called the ventricular point sign. And also there's a diamond-shaped space over here. You're wondering why, and then you move to the transcerebellar view, and what do you see here? Banana sign. So things are very clear. This is an open spina bifida with Chiari 2 malformation, and a part of that you have the ventricular point sign as well as a prominent CVI or a cavum velum interpositi. This is the normal shape of the occipital horn. This is the abnormal shape for you to actually compare. Are the slides too bright or is it okay? It's okay, we'll carry on. For me, it's a little too bright. Okay, doesn't matter. Now we go to the margins. We finished the size, margins. Now look at this clip as I'm doing the clip. I've given you a clue already. One clue that the fetus is giving you is subjectively itself, don't you feel it's dilated? Yes, it is dilated. And then I want you to see the ependymal margin. What's happening here? Is it regular or are there small kinks? There are small kinks here. So I put down on the gain and look at what I have found. Can you find 2 bumps? Underlying, can you find the 2 nodules? What is the diagnosis? Nodular heterotopia. So I go parasag, and in parasag, what do I see here? Multiple nodules, yes or no? So again, margins gives you the clue. And I want you to see the shape of the lateral ventricle. Normal or abnormal? Highly abnormal. It mimics the kiwi bird of New Zealand, right? The national bird of New Zealand, which is abnormal, a truncated, blunt-looking occipital horn. And you do your entire neurosonogram, you find other nodules also, but all of this happening on one side. This is your 3D showing you virtual ventriculoscopy, showing you the nodules which are projecting into the ventricular lumen. The other ventricle was normal, so that was a unilateral PNH or a unilateral periventricular nodular heterotopia. Here is a 25-weeker. Again, look at the margin. There is not only a ventriculomegaly, there's also something sticking to the ventricular margins. What do you think is sticking? What can stick? Hemorrhage clots. Clots are sticking. Clots have gone to the aqueduct of Sylvius, or clots have gone to the foramen of Monroe and obstructed. And that is why the ventricle is there. Why didn't I say aqueduct of Sylvius? Here, the answer is here. Unilateral. If it's aqueductal stenosis, both ventricles would have dilated. That is why I am telling it's possibly Monroe, because the opposite ventricle is normal. So you see the clot sticking in, and you know it's a grade 3 intraventricular hemorrhage, because there's not only intraventricular hemorrhage, there's also ventricular dilatation. You can see the clots over here sticking on the choroid plexus, and also clots everywhere. The other ventricle is normal. So it's a unilateral lateral ventriculomegaly. Let's go to periventricular zone. And the first case I'm going to show you, to cut a very long story short, The narrow CSP, callosal hypoplasia, and on the parasage, you find a brilliant hyperechoic zone all around the lateral ventricle. Yes or no? Classical of a CMV infection. So this is a periventricular halo secondary to a CMV infection, and you have the proof out over here. You can see the lab torch PCR says that cytomegalovirus DNA has been detected in red. So it's a proven CMV infection. Let's look at this. Again, ventriculomegaly, periventricular pseudocyst. That means it's periventricular. The clue is coming to you from outside of the ventricle, and you see cystic encephalomalacia. Again, you have to think of CMV infection and do your invasives and send it up for PCR. Obstructive periventricular lesion. Let's look at this case. 30 weeker, one ventricle normal, the other ventricle is dilated. When this happens, you will think of aqueduct of Sylvius or Monroe? Monroe. So look at the region of the Monroe. You find a hyperechoic lesion sitting over there. You're scratching your head whether it's a bleed or whether it's something else. You do a neurosonogram. You find other lesions elsewhere. Very well contained, coin-shaped hyperechoic. What do you think they are? They are tubers. They are tuberous sclerosis, and these are hamartomas. You do an MRI, you find corresponding to this lesion, you have a hypo-intense lesion in T2 weighted image sitting at the foramen of Monroe, causing dilatation of the ipsilateral ventricle. The lateral ventricle on the opposite side is normal or abnormal? Normal. You look at the heart, no rhabdomyomas. So therefore, this is one of the rare cases where you had a CNS abnormality, but no associated rhabdomyomas in the fetal heart, and that is a case of tuberous sclerosis, and thanks to the fact that the ventricle gave out the initial suspicion. Abnormal content. Now let's look at this. One lateral horn normal, the other lateral horn is full of something hyperechoic. You turn your probe, go to parasage, you find that the entire ventricle is occupied by what? That's hemorrhage. It's a clot. It's a cast. And when hemorrhage occurs, clot forms, it retracts. That is a normal, natural history of a clot. When it retracts, you find that there's CSF all around. Can you see that? Yes or no? Layer of CSF. So that is a cast of the lateral ventricle due to intraventricular hemorrhage. Now let's look at side-to-side asymmetry in shape and size. Here is, I will directly go to MRI. All these findings are there in ultrasound also, but MRI is easy for you to perceive. Asymmetric lateral ventricles. Yes or no? Unilateral lateral ventriculomegaly. Yes. Asymmetric anterior horns. Yeah. Midline which is curved. Yes. Lateral fissures are asymmetric. They are looking different on either side. Front, look at the hippocampus. Hippocampus on either side. This is different, that is different. Asymmetry. Anterior horns, asymmetry. And midline distortion. Now I want you to see the anterior interhemispheric fissure and the, what is this? Third ventricle. Are they in the same line? They are not in the same line. So there's asymmetry everywhere, and that is what you see in tubulinopathies. So be careful, in tubulinopathies you have a lot of asymmetry which is happening. Multiplicity of findings. Here you have dysmorphic large lateral ventricles. You also have a lot of calcification in the subcortical regions. This is not periventricular, this is subcortical. You also have a periventricular pseudocyst over here. Your corpus callosum is hypoplastic. The rostrum and the splenium are missing. So you know there's a lot of things happening here. please go molecular for any one of these findings, whether it is PNH, whether it's lissencephaly, or whether it's calcification with highly dysmorphic features. Please do molecular, and I'm sure you will pick up a case of Aicardi-Gouttiere syndrome. Serial examinations are very important. You have to repeat with 2 or 3 weeks interval. If it's regression, your message is good, that there's a good outcome, chances are more. But if it's progression, you have 16.7% of neurodevelopmental delay in these fetuses, right? So therefore, it has prognostic influences. Here is a 17-weeker, you have 0.96, 0.99, and at 22 weeks, what has happened? It's increased or decreased? It is increased badly. Posterior fossa is normal, so you're thinking of an aqueductal stenosis. You will see that it is male genitalia, and if there's an adducted thumb, you're going to think of X-linked hydrocephalus L1-CAM mutation. So this is the importance of repeat. Here is again another repeat. 20 weeks, I see 0.9. So the 0.9 also, you call them back for a repeat. Nothing is lost. And in this case, when she came back at 22 weeks, it was the same, but look at the 26 weeks, look at the lateral fissure, normal or abnormal? It should have been much, much deeper. It's obtuse, and there's an abnormal gyrus here. Abnormal gyrus here, very, very poor formation of the lateral fissure. And when you do your coronals, you on the MRI, you see polymicrogyria. This is a synechium in the posterior horn, synechium in the posterior horn, and therefore your repeat scan showed you a clue both by ultrasound, and that was confirmed by MRI as polymicrogyria. Additional findings you can get in 10 to 76% of times, and with improvement in technology and protocols, your missing rate of additional has gone down about 7% now. Remember, this is an important slide. If you've done a transvaginal ultrasound, your chances of getting anything additional information in MRI goes down to almost 1.6%. So therefore, always refer to an MRI only after a full neurosonogram and not after basic sections. Genetic testing, as I said earlier, is extremely important. Let's look at a case of choroid plexus cyst, lateral ventriculomegaly, nothing else at all, and this turned out to be a Down syndrome. She was NIPT high risk. We did a karyotype shows you a free trisomy. Let's look at this particular case, lateral ventriculomegaly. You go to transvaginal, you find nothing else at 18 weeks. You're sure that it's an isolated ventriculomegaly, but we got a very bad surprise. When we did an amniocentesis, we picked up a 11p13 microdeletion, which correlates with Wilms tumor, aniridia, genitourinary malformation, and MR, Wager syndrome, which is a poor prognosis, right? Here is lateral ventriculomegaly with sulcatory delay. Here is a case of 23 weeks, ventriculomegaly. And for 23 weeks, what do you call this? Normal or delayed? It looks a little delayed, but I'm not very confident because she's only 23 weeks. I'll wait for 1 or 2 more weeks. But because of the lateral ventriculomegaly, because of this giving a suspicion of delayed, and at 23 weeks, do you see parieto-occipital sulcus? In this case, do you see it or you don't see it? It's not seen. It should be seen. It's not seen. So there are subtle signs of delayed sulcation. So you do your molecular, and when we did a whole exome sequencing, we found a TUBG1 gene mutation, which codes for a tubulinopathy. So therefore, you do not know which case will give you a positive result, which case will give you an abnormal result. It's your duty to offer it and do it to patients or fetuses who deserve it. Extracranial anomaly is very important, as in this 36-weeker, lateral ventriculomegaly, third ventriculomegaly, then you have a little brachydactyly, short digits kind of things. And this is the profile of the face. Do you find the face normal or abnormal? Abnormal, because the nose looks very small, and this is the 3D of the same, showing your face with dysmorphism. So facial dysmorphism, brachydactyly, and intracranial findings, please think of syndrome. She was 36 weeks, so it was too late for us to do anything in terms of molecular diagnosis. So timeline is important. You can do a scan at 18-20 weeks as basic, and then, of course, you need another scan at this magic number, which is 26 weeks, because at that time, you know, you have given enough time to the fetus to show you some sulcatory landmarks, and later scans can come on a case-to-case basis, right? So this is the incidence of various causes of lateral ventriculomegaly in terms of percentages from a meta-analysis, and this is a comparison of asymmetric versus symmetric, doesn't matter, but this slide is extremely important. In the case of mild lateral ventriculomegaly, do an extended neurosonogram, right? So if the findings are negative, do a TIFA. If the findings are negative, you still give an option of chromosomal microarray and whole exome sequencing. If that also is negative, then you term this lateral ventriculomegaly as isolated. But if in this journey of doing this isolated stuff, if you find something in the neurosonogram, then that can come at a repeat scan of 26 weeks. It may give you the diagnosis. You might do an MRI, and once it gives you a diagnosis, targeted counseling. Or in the brain, you might not find anything more, but you might find something more in the rest of the fetus. That may give you the diagnosis. Your targeted counseling will be there. Or all this may be normal, but you might get a positive result from CMA or WES, and that gives you a targeted counseling. Whereas if it is isolated and all of these have turned abnormal, including studies for infection, you call it isolated, and the counseling is non-targeted. It's not targeted, non-targeted. You need a multidisciplinary team, and for non-targeted, for isolated ventriculomegaly, non-targeted counseling, normal neurodevelopment in more than 90%, right? For mild, for moderate, it is 75 to 93% of them have normal neurodevelopment, and for normal intracranial fetal findings, you have 97 to 98%, those even without ventriculomegaly. So it's hard to say which fetus comes in the 10%, which fetus comes in the 90%, but at the moment, that is the best thing that we can do. So wrap up, ventriculomegaly is a finding, not a diagnosis. You've got to differentiate isolated from non-isolated, and isolated ventriculomegaly should be branded as such only after the process of 3-step ruling out. First step, neurosonogram. Second step, TIFA. Third step, invasive testing, including infection. And when you're doing a neurosonogram, never forget to ask for a repeat neuro after or at 26 to 27 weeks. Right? Thank you very, very much for a very patient listening. Thank you.
Dr. Rao and his family plus his team for being together and getting all this together. No words to thank you. Thank you so much. And lastly, I would like to invite you all, because Dr. Ramamurthy is going to be there, and we would like you all to come to USCON, which is in Jaipur, October 3 to 5. I'll send the details to him. Thank you. Thank you so much.
Thank you for. So now we are closing the session. I thank all the faculty members who traveled all the way from different places, New Delhi, Bombay, Bangalore, and Hyderabad, and thanks to all the delegates. And your presence and contributions have truly enriched our program. Thank you all. Thank you very much.
Can switch on that?